Best of Ispad session. I am one of two chair people for this session. My name is Emma Clateman. I work with Life for a Child, and I'm joined by Mahira. Mahira, hi. Nice to be with you all and all of these wonderful, wonderful speakers. Looking forward to this Life for a Child JDRF Joint Symposium, where we will hear from Dr. Apurva Gomber from the US, from Tom Robinson from JDRF, and from Dr. Graham Ogle from Life for a Child. So firstly, we will pass to Dr. Apurva. Apurva, we're really looking forward to your talk about managing diabetes in challenging environments, and we can't wait to hear from you. Take it away.
Thank you so much. Can I get access to share my? Oh yeah, thank you. 1 second. Thank you so much, Emma, for the introduction. And I will try to share my slides. Can you see the slides?
Yes, dear.
Oh, okay. The topic for today's session, and I think I'm really grateful for the opportunity to talk about this topic after a wonderful discussion at Ispad, which I had the opportunity to attend with all the eminent people from India, and Dr. Sabu really wanted to showcase what happened at Ispad and finally dissipate what was learned at Ispad through the best of Ispad sessions. So I hope I can deliver what we kind of learned at Ispad, and I hope this is helpful for everybody in India. And I will be happy to take any questions at the end of the session. So my topic for today is managing diabetes in challenging environment. I actually work in the Type 1 Diabetes Global Health Equity Department as a research fellow at Brigham and Women's Harvard Medical School. And my research basically involves around implementation of diabetes care and understanding the inequities in healthcare delivery models across the globe. So the key points before we begin is to understand that there have been wide advancements in diabetes over the globe. And diabetes has improved, these advancements have improved the quality of life and glycemic control in people living with type 1 diabetes. However, a large subset has still been left behind. And those who have been left behind have continued to be at higher risk for diabetes complications. And they are also those people with deep-rooted inequities and disparities within our fragmented healthcare systems. Now, if you see these wide inequities and duality in the global health continue to exist between the global north and the south. In global health, we basically see something called the brand line, which basically clearly shows the deep inequities and disparities in care. But now over the years, this brand line is way more complex because even within the developed countries, there are wide inequities and disparities. And the less developed countries or the developing countries are still left behind. And a lot of diabetes inequities continue to exist even with the advancements in technologies. So my outline for my talk would be based on these following steps. And I would like to introduce the background around the diabetes inequities, and then finally understanding what are the opportunities for integrated care models, and as a research fellow in the Center for Integration Science, how we are working towards with WHO and trying to achieve the targets for improving the diabetes care globally, especially in the lesser developed, in low resource settings. So to understand the disparities in diabetes care, it is important to see, and I'm sure a lot of people are familiar with this study by Lipman and Hawkes in diabetes care, that the diabetes outcomes are very closely related to the social determinants of health, and disparities in diabetes are very complex because of these social determinants of health. However, these measures of social determinants of health are associated with suboptimal glycemic control and are not routinely addressed by the healthcare professionals in routine clinical practice. And to address these disparities, we need to find an approach and find out the opportunities to include social determinants of health in our healthcare delivery models. So we are all convinced that our health systems are not organized for long-term chronic care of individuals, but rather for managing the acute care. The management of diabetes requires regular supply of drugs, data collection systems, trained healthcare teams, and educated, empowered patients, in addition to the health services tailored to the social and cultural needs to determine good clinical outcomes. Now, when we see all of this seems to be a very ideal situation to achieve good glycemic outcomes. But when it comes to complex situations where there are challenges of food insecurity, when there are challenges of supply chain issues, when there are challenges of patients not able to understand what's happening with their diabetes treatment, and they're not part of the decision-making process, these inequities are way more diverse. So to understand and quickly to surpass through how the global diabetes burden is on a rise, we will see that over 386 million people are living with type 1 diabetes, and it is predicted that this number will only increase. These stats are terrifying for what seems to be a very manageable conditions. However, this rise is not just because of the people are surviving longer, but also a lot of people are getting diagnosed with type 1 diabetes. But we have to realize that as more and more people are getting diagnosed with type 1 diabetes, there are also huge barriers in the psychosocial challenges that are coming up, causing increased burden to our healthcare systems. So when we see, to summarize this situation, we often see the rules of halves, and we say that people, out of the total people with diabetes, only half of them are actually correctly diagnosed with diabetes, and half of them receive the recognized care, and only half achieve the glycemic targets. Now, I want to switch your attention towards what are the challenges. Now, these are the challenges in a normal scenario, but these challenges are much more profound in complex environments. What do I mean by complex environments? Complex environments where people, other than the socio-political environments of health system organization, are also battling through the social determinants of health, not having access to food, not having access to sustainable supplies for managing diabetes, not even having one test strip to check their blood sugars. So there are diagnostic challenges where physicians cannot diagnose or differentiate between types of diabetes. There are high rates of misdiagnosis due to lack of diagnostic tools and infrastructure. Yes, we are in the 21st century, but these diagnostic challenges still continue to exist. And it is disheartening to say when you are there and you don't have the equipment to actually do the tests and to make a diagnosis. Now, the challenges are also there at the supply chain level. A lot of patients are living in the outskirts and they're long distance from the health centers. It is also crucial to understand that most of the diabetes services are delivered at the tertiary care centers. A lot of people cannot travel and hence the care cannot be delivered. There are misdiagnoses and people land up into tertiary care centers with high rates of complications because the care is not delivered at the primary health centers. There are challenges at the referral level where people land up in DKA complications, which could have been easily picked up or easily diagnosed at an earlier stage, and the patient could survive. So the availability of specialties for referral are also unavailable at primary care centers. So it is crucial to understand that these complex challenges make diabetes diagnosis way more difficult. Now, there are tough management questions which continue to exist. Are food insecurity. A lot of people living with diabetes have to choose between food on the table or to take their insulin. And it is very sad. And these situations are very draconian because you cannot do anything as a clinical provider when your patient doesn't have food on his table to manage his blood sugars. So we need to address these gaps of food insecurity and addressing the literacy gaps in patient education and awareness. Also, I think this cultural stigma around diabetes and chronic diseases is so deeply rooted in our system that we need to work in collaboration with lots of nonprofit organizations to improve the education and also improve the peer community support around diabetes care. Also, the tough management question that comes is the political instability and crisis, like we saw with the Ukraine war, and how people could not access diabetes care just because of the political instability. So, in one of the papers which was recently published, they tried to understand the comparative health system assessment and saw that beyond insulin, various health system factors are actually responsible and can impede care. Financial burden of care remains significant, and many diabetes related supplies are not available or affordable to people with type 1 diabetes. Now, in Kyrgyzstan, A1C kits are not available in the public sectors. And in Mali and Peru, they continue to remain unaffordable. So often people do not get themselves tested. The doctors cannot make the diagnosis correctly, and thus high rates of misdiagnosis continue to exist even in the 21st century. So I want to emphasize on the fact that we have seen a lot of advancements, but when it comes to complex scenarios, people are still struggling to get at least one test in a day to even check their blood sugars. So I had the opportunity to work with my team at Center for Integration Science, and had the chance to spend 3 months in Malawi, where we tried to improve diabetes care in training clinical providers there. So from the experiences I had, there were not just challenges of lack of access to insulin, but also deep-rooted challenges where patients could not even have food on their table. There were challenges of not having peer support, not able to understand what's happening with their disease, and also unable to be an essential part in their diabetes management care. So I think I used the type 1 index to understand how it was, how the situation was in Malawi. And it made me so grounded when I was there to see that even with the best of the technologies, the best of the information we have, we cannot deliver the best of the care because of a lot of other barriers in these complex situations. And the T1D index currently clearly says that if we had the appropriate toolkit to actually correctly diagnose patients, we would have had over 15,923 people who would have been alive today in Malawi. And I think these numbers are almost similar to what it is in India as well. And these challenges continue to exist. So this is a very important study, which I think was also shared at Ispad, to understand that the level of type 1 diabetes care in children and adolescents for countries at varying resource levels, and what should be the ideal aim for comprehensive care, even in resource limited conditions. So this was a paper by Graham Ogle, and it clearly aims for comprehensive diabetes care in complex environment, and showcases that yes, sometimes it is unrealistic to do 3 tests or 4 tests in a day. But in situations of limited care, like minimal care, there are certain things which we need to cater to. And through collaborative approaches, we can improve diabetes care even in complex environments. So another thing I wanted to point out was that when we talk about complex environments, we have to cater to what happened in humanitarian crisis, like the Ukrainian war. And we know the essential diabetes medicines are so critical, and this becomes even more essential when it comes to humanitarian response and should be integrated into routine care. Now, humanitarian crisis and diabetes have been increasing at an unrelenting pace, and there are large numbers of migrant populations who are living with type 1 diabetes and are still facing the challenges of getting access to insulin and essential diabetes supplies. So one of the papers was recently published in Lancet, talks about the diabetes in humanitarian crisis, and also why it is essential when we are aiming for 100% access to type 1, 100% access to insulin for all people living with type 1 diabetes, how we can involve and include these people who are migrant population and who do not have a place called home. So yes, there have been a wide change in the global health equity, but there is no progress in global health equity over the course of 2010 to 2020. And you can see clearly that a lot of the health budget has gone into infectious diseases, and diabetes continues to be left out. What is the way forward? Why is type 1 diabetes care not reaching the poorest in remote areas? We know a lot of NCD initiatives have focused on integrated care models at health centers, at tertiary care centers. Less complex conditions have been focused, but type 1 diabetes continues to be left behind. Now, the existing efforts in low middle income countries are largely delivered through health centers, which are far out of reach from patients who are living in very remote areas. We need to think about pathways for integration and sustainability and ensure that the lethal gap for healthcare delivery is addressed. So I want to introduce you to a package of integrated care, which our team at Center for Integration Science is working on. And this package of WHO package of essential non-communicable disease interventions has been incorporated by many of the African countries, and it is also adopted by at the WHO Health Assembly. So PEN Plus is basically part of the ecosystem of chronic care, and the aim of the PEN Plus is through this integrated model. It is trying to overcome these barriers of complex health systems and making sure the healthcare systems are delivered at the first level hospitals, which are the district hospitals, and also ensuring that the mid-level providers are able to identify and reduce the burden of diabetes and ensuring type 1 diabetes is delivered to the poorest of the person. So some of the work of the NCDI Poverty Network and PEN Plus is focused on this African countries and also involving the new PEN Plus sites in Nepal, Chhattisgarh, Bangladesh, and Cambodia. So PEN Plus is an integrated model which focuses on health equity and increasing the access and for the poor, those living in rural areas, and also ensuring the access to chronic care for severe NCDs. Also need to focus that this is primary training of the mid-level care providers, such as nurses and clinical officers, and to ensure that through this integrated package model, we are able to deliver services and making the best use of the resources. So PEN Plus is about training these mid-level providers, the nurses, clinical officers, and other frontline clinicians who are at these hospitals, ensuring that healthcare is delivered and we are able to save lives at the basic level and where it can be diagnosed early. So to summarize and not to take much of the time on PEN Plus, I want to emphasize on the fact that type 1 diabetes care is complex. And this is much more profound in these complex environments where people are struggling with access to basic health necessities and basic lifestyle, basic health rights. So despite these increasing efforts from various sectors and stakeholders, type 1 diabetes is still a challenge, and we need to focus on integrated sustainable solutions. Now, at the 2022 World Health Assembly, the PEN Plus was incorporated, but also along with that, the WHO member states endorsed the target of 100% access to insulin for all people living with type 1 diabetes. This is one of the targets along with the other 5 targets which were endorsed at the assembly. Also, the Ispad 2022 guidelines are currently underway, and they are also addressing in how we can essentially manage type 1 diabetes in limited resource settings, and how one of the tables you saw by the paper from Dr. Graham Ogle on how even in the resource limited conditions, how we can achieve the targets for minimal care. This is not easy. And yes, it is easy to say it, but this requires interlinkages of a lot of parameters. Education of healthcare providers at mid-level, and also educating the clinical providers at all resource centers. Awareness and wider community education and peer support. Implementation strategies for the complex humanitarian settings, and finally, health system strengthening, advocacy, and improving capacity in diagnostics. So lesser misdiagnoses happen and more people living with type 1 diabetes can be picked up and given access to what they actually deserve. So ultimately, I just want to say that yes, this is an urgent call to action, and a global movement of solidarity needs to be achieved, and especially through through the focus on complex environment, a large portion of the global south and large portion even within the global north is still struggling with disparities in diabetes care with the advancements in technology. So our focus should be to, like I think we will talk about it when Dr. Graham Ogle and Tom Robinson is going to present about how we are still leaving so many people who are left behind, and so many people can achieve a better diabetes outcome just improving through a collaborative model and through improving care to the poorest of the billions. So thank you for giving me a chance to present, and thank you for. I'm open to answer any questions that come along. Thank you.
Thank you, Apoorva. Mahira, are you there?
Yeah, I'm there, Emma. I would like to introduce the next speaker of the day, Dr. Tom Robinson. He's the co-author for T1D Index, and Dr. Tom is the Vice President for Global Assist Team at JDRF International, working to ensure everyone with type 1 diabetes receives quality care no matter where they are born. And prior to this, he spent a decade with the Boston Consulting Group, where he was awarded a fellowship for his social impact work, and he holds a degree in law and philosophy from UNSW. So over to you, Dr. Tom.
Myra, we will have question answer at the end after the session is over.
Yes, sir.
Okay, thank you.
The same. Yes.
Well, thank you for that introduction, Mahira. And I'd like to thank all of you and the organising team and Dr. Banshi for inviting us to participate here. It's a great honour to be at this important meeting and join in discussions with this impressive group of healthcare professionals. I'm grateful to be here, and for all the many others of you who've shared your expertise and vision for type 1 in India, both with myself and my colleague Priyanka Rai here at JDRF. I firmly believe that in future we will be celebrating many of your achievements together and many great changes. Can everyone see my slides okay? Has that come up?
No, it has not yet.
Right, let me try again. Second time. How about now? Is that working?
Yeah, the screen is.
Do we still have you, Tom? I think Tom may have dropped out.
Oh, no, he's sharing the screen. This is what I can see on my screen.
Okay.
His picture's frozen now.
Give it a couple moments. And if Tom is taking... Okay, we've just lost a signal with Tom. And if he's not back in the next minute or two, I might suggest, Graham, if you would like to step in Tom's place, and then Tom will come after you, but let's give it a moment or so.
Sure.
And to the audience, please do feel free to put in the chat any questions that come up. We will go to questions after all, Graham, Apoorva, and Tom have presented together, so we can ask them questions together on a panel. Okay, I think we have Tom back. Tom, we just lost you for a moment, but I think we have you back now. And you are muted now, but if you would like to try and share your screen again.
Thank you again. I'm so sorry about that, everybody. That's obviously very embarrassing that the internet's gone out.
No worries, Tom. Go ahead.
All right. Well, let me try and dive in here. So I want to talk to you about the Type 1 Diabetes Index, which is a big part of why JDRF is becoming more involved in global access, but it's about much more than JDRF. Let me rewind 4 years to a time when we were trying to think strategically about JDRF's role in helping improve lives around the world. And others were doing the same work. You can see some of the logos of our key partners across the bottom here: Life for a Child, Ispad itself, the International Diabetes Federation Beyond Type 1. And we couldn't answer some very simple questions. How many people have type 1? How many people will one day need the cure? How well are they living with type 1 today? What would be the impact of, say, 3 more test strips per day? And although estimates did exist, the numbers available were not reliable enough. You could compare them with good quality registry data and they'd be off by 35% or 50% or 300%. And so right from the start, what we did is we partnered with some really smart people and groups, and you can see the initial partnership here to help build the numbers. And each of these groups brought significant intellectual capital and resources that helped advance the work 12 to 18 months. This is a true collaboration of partners to build this index and to try and answer those questions and shine a light for the first time on the global state of type 1 diabetes. Now, that work is now available. The October edition of the Lancet Diabetes and Endocrinology includes a paper that has taken roughly 50 people across 6 continents 3 years to write. We talked to people with type 1, we talked to their doctors and healthcare practitioners. We studied programs and interventions, and we built this new simulation tool that we call the T1D Index. It's now available as a paper. It's available as a website, t1dindex.org. It's available as a simulation tool and as an open source database. And in fact, you can pull it up on your screens right now, t1dindex.org.
Okay, we're getting spotty connection from Tom again. Let's give him a couple more minutes to see if he can rejoin.
Emma, I suggest to take Dr. Graham.
But first, let me just introduce Dr. Graham Ogle to the audience here. I'm sure Graham needs no introduction in this space, but Graham is a renowned expert on global diabetes care. He is a particular beacon of knowledge on the epidemiology of diabetes, and he is here to speak on just that subject in terms of numbers for India and what they mean going forward. So take it away, Graham.
Thanks very much, Emma and Myra. And can you hear me clearly and see the screen?
Oh, good.
Good. Okay, so this is one of my favorite pictures from the most recent LFAC art competition, which shows that for a young person with diabetes or an older person with type 1 diabetes, they're walking a tightrope every day. So I think probably everyone on the call knows that the incidence of type 1 diabetes varies widely around the world. And this is the IDF Atlas numbers, which were used as part of to generate the numbers in the T1D index that Tom was just introducing. And you can see that Finland and Sweden, followed by some countries in the Middle East, have the highest incidence. And then this is only part one of the table. This is the second part of the table. And you can see that India has a relatively low incidence, but not as low as Japan or China or a number of other countries. And I personally think the incidence measurement in India is probably underestimated, and it's quite possibly a little bit higher than that, pushing up towards the top of that. The top of that row there. But the problem that's the number of new cases. But when you try and translate that, even if it's accurate into the number of existing cases, how many cases, what's the prevalence, how many cases are walking around with type 1 diabetes, it becomes harder because many countries don't have any data even on incidence. And many studies are old, and the Atlas methodology does not allow for changes in incidence since the studies were done. And mortality is incompletely addressed. And so the mortality may be quite high in some countries and very low in other countries. And that will markedly affect the prevalence. An example of the age of the studies is shown in this global map. And you can see the countries in red have data from 2015 or onwards. And the countries in grey have no data at all. And much of the data from many countries is from the 1990s or the early 2000s. And we know also that incidence has been increasing. Type 1 diabetes incidence has been increasing. It's been increasing in around 3% a year or more in most countries that have data. And this has been going on in Europe and Australia and Canada and the United States and New Zealand for a few decades, maybe 2 or 3 decades. But it does appear to be tailing off or even ceased in some of those high-income countries I just mentioned. And also this is also happening in Japan. While in some other countries, it's still increasing, sometimes at 5% or more per year. And this shows this increase that I've been talking about and if you log the increase, these lines are actually quite similar. This is data that we have from a study we did in Uzbekistan. And you can see that the top panel is incidence, the number of new cases. And you can see that that's going up by 5.6% a year over this 17-year period. That's a lot. It might be 3% in Europe, but it's 5.6% on Uzbekistan. And so not surprisingly, the prevalence is going up even quicker. And happily, with the improved care from local efforts there, following the St. Vincent's Declaration and support from Insulin for Life and Life for a Child and just lots of more government support there, the mortality has fallen very steeply. So these numbers change. That's the point that I'm trying to make here. And then, so that was about children and adolescents. The problem with adults when we started doing this work is that there weren't any good estimates at all of global incidence or prevalence for adults with type 1 diabetes. And we know while the peak age of onset for type 1 diabetes is in children, there's lots of adult years, and type 1 diabetes can occur in a 20-year-old, in a 40-year-old, in a 60-year-old, even in an 80-year-old. And there's some suggestion that there's a little rise in the incidence in seniors in communities. And so you can't estimate type 1 diabetes without thinking about the adults as well. And so that led to the T1D Index project, which Tom will give you the overview of. And as he mentioned, it's a partnership between JDRF, Life for a Child, Ispad, and the International Diabetes Federation. And that's the paper published, as Tom said, last month in the Lancet, Diabetes and Endocrinology. And this is the dashboard that Tom was referring to. And this is the numbers for India. And you can dial up what the numbers are estimated to be this year, last year, in 10 years' time or 10 years before for India, and look at the different age groups. And you can see the magic number there, that the estimate for 2022 is that there's 860,000 people in India with type 1 diabetes. That's a lot of people. And so the big numbers, which Tom will talk about, 8.7 million people worldwide are living with type 1 diabetes, and 1.5 million of these are less than 20 years old. And the median age of someone with type 1 diabetes is 29 years. And this is the chart that's in the paper, which gives numbers for all countries. And honing in on India. So this is the number of incident cases. So incidence is the number of new cases. So in 2022, this is our estimate, our best estimate of the number of people in India who will develop type 1 diabetes this year. And that's 78,200. And of those, almost half of them are under 20 years. But you can see there's a lot of adults as well. And even some, as I mentioned, some older people who will develop type 1. So 78,000 new cases in India this year. That's the estimate. And then when you look at prevalence, when you look at the total number of people who are walking around today with type 1 diabetes, the highest in the world is the United States with 1.4 million. And then we have India second at 860,000. Now, we know that India has a much higher population than the United States, but the United States has a higher incidence. So that's why it comes out on top in this table. But then when you look at less than 20 years old, because of population pyramids and more young people relatively in the population in India rather than the United States, India has the highest number of young people with diabetes in the world. And this has been estimated from the IDF Atlas in the last one, that the IDF Atlas numbers, I think, underestimate this number because of that increase over time that I was talking about before. And so this is the prevalent cases. How many cases are walking around today with type 1 diabetes in India? And we estimated 860,000. And even in India, that's a big number. And of those, 282,000 are less than 20 years old. And as I mentioned, that's higher than the IDF Atlas estimate of 229,000. And this shows the age pyramids that I was talking about. So we've got 4 countries here. We've got United States as an example of a high-income country, Brazil as an upper-middle-income country, India as a lower-middle-income country, and Democratic Republic of Congo as a low-income country. Now, the pale blue bars are the people who are still alive. And then the darker blue ones are the ones who've already passed away early, have already died early because of their type 1 diabetes. And then you have the very dark blue ones who were people who were never diagnosed properly. And I'll talk more about that in a moment. But these are children especially who come along to clinic and they've been developing diabetes, had symptoms of diabetes for a few weeks or a couple of months, and they come in and they're short of breath, they might have an infection, they might be vomiting. And people think, doctors around the world diagnose it as all sorts of things, gastroenteritis or pneumonia or meningitis or malaria or typhoid, all sorts of things. And often that misdiagnosis is corrected before it's too late, but often we believe it isn't. And so we think that a number of thousands of people in India are dead today because they were misdiagnosed when they were young. And you can see this age pyramid where America has many older people with type 1 diabetes. Now, it was very exciting to hear Dr. Mohan talk yesterday about how he knew people in their 80s and 90s with type 1 diabetes, that this is happening now and it will continue to happen. And Tom might talk more about this, but type 1 diabetes steals millions of healthy life years each year. So we looked at we estimated life expectancy of a 10-year-old child who develops type 1 diabetes today in India. And we estimate that that's 24 years, so that they will live until they're 34 years, 10 plus 24. Now, they'll lose 5 further healthy life years because of diabetes complications and time spent managing their diabetes. But if they don't develop type 1 diabetes, the additional life expectancy of a 10-year-old today in India is another 63 years, i.e. you'd expect them to live until they're 73. So there's a huge gap between what could be and what is. And this gap is there in all countries, but it's much narrower in many countries. And so the index estimates that 39,000 people will die of type 1 diabetes this year in India. And 12,400 of those will be less than 25 years old. And 7,600 of these 12,400 will die from non-diagnosis of type 1 diabetes. Now, I presented these numbers in Chennai, and some doctors thought that they were on the mark. I think some doctors thought they might have been a little bit underestimated, while some doctors thought they were overestimating. We're not sure, and further studies will tell. But I think whether it's 7,600 or 1,600 or 10,600, these are tragedies. These are children who develop type 1, which is a treatable condition, and they go along and they're misdiagnosed as something else, and the correct diagnosis is not made. No one thinks to do a blood glucose level, and they die. And this is a tragedy which we need to avert. And then the index also estimates that the 900,000 Indians should be alive today, but they're not, because they died early from type 1 diabetes. Either it wasn't diagnosed or they died after diagnosis. And briefly, we expect these numbers to grow. And I won't go into this in great detail, but you can see the South Asia panel to the right of the screen here. And you can see that with increasing incidence and also increasing population and improved care, we expect the numbers of people in India and Bangladesh and South Asia to continue to grow. And looking towards the future, by 2040, we would estimate that 130,000 more Indians would be alive if they had access to a timely diagnosis. And 580,000 would be alive if they had access to intermediate or comprehensive care. Going back to the tables that like the traffic light table that Apurva showed before, that if we can move from minimal care, which is just insulin to keep them alive and hardly any blood glucose monitoring, to intermediate care, which is basal bolus regimen with blood glucose testing and education, or if possible to a comprehensive care, which is continuous glucose monitoring and analog insulin by pumps and that sort of thing, many, many lives can be saved. And that's the further step, if you can see what technology can make. But the big step, you can see the big numbers are here in this middle category. If we can move people on to intermediate care, where they're self-monitoring their blood glucose, they have the understanding, and they have the education to do that, the diabetes education. So what should be done in India? Now, I'm not an Indian, and so, but these are my thoughts from a distance and after discussion with people in India. I think it's critical to eliminate deaths from non-diagnosis. And secondly, to ensure every Indian with type 1 diabetes has access to intermediate or comprehensive care. And finally, to map the situation and to gather more data on incidence and mortality and to monitor changes. Now, coming to non-diagnosis, I've talked about this before. There's a legion of misdiagnoses of infectious diseases and surgical conditions. I've heard of young ladies having operations for ectopic pregnancy when they weren't even pregnant and dying, all sorts of misdiagnoses. And the first story competition that we did for Life for a Child is this boy, Ray, 17 years old in Ghana. He wrote, "As a child, I was vibrant and active. So when it all started, everyone noticed at once because I became still. I was treated for malaria, anemia, worms, and others I don't even remember with both modern medicine and traditional medicine. I'd never taken so many treatments in my life as I did when I turned 10. After 5 months of no improvement, I was still growing lean and wetting my bed. That was shameful. My siblings teased me, my dad punished me, and my mum thought I was just lazy. I became less and less active. One day I started vomiting and I was so weak that I could not open my eyes. I was rushed to the hospital, and after a series of tests, my parents and I were told that I had diabetes. I don't think any of us doubt that he would have been dead within a day or two if that diagnosis hadn't have been made at that moment. And so how many are misdiagnosed? Our numbers are based on an Ispad survey where we asked this question from 20 experts in India who answered the survey. And we talked about people under 25 years of age. And the estimate that we came up with is in about 2010 to 2020, around 85% of children were being diagnosed. And that's where we get this 7,600. Now, maybe it's 90% or 92%. But whichever number it is, there's still a lot of deaths happening. So how do we prevent these deaths? We need education and awareness of health professionals, teachers, parents, and religious leaders and others. And these sorts of programs have had success in reducing rates of diabetic ketoacidosis in high-income countries. And they've also had success in reducing deaths in lower-income countries. So what do I mean? This is an example of, this is the one that started it all, actually. This is originally, you have to imagine this in Italian. I don't speak Italian, but this is the English translation. But this was about drinking too much and bedwetting, a campaign in Italy, which was remarkably effective. And so Australia did its own one in a typically Australian way of the outside dunny, outside toilet, if you like, and trying to get that message across to young people. And to older people, and to their teachers, and to doctors, to everyone in the community, particularly health professionals, so that the misdiagnosis wasn't made. And then in a less resourced country, in partnership with Santa Diabet, Life for a Child's shown rapid increases in observed incidence and prevalence in a period in Mali, which is a country in West Africa. And you can see that over this 10-year period, there was a huge jump in the number of diagnosed cases. And this isn't just an environmental change from causing increase in incidence. This is more cases being diagnosed, less cases dying. And this jump between 2013 and 2014 was when we did this poster across the country. It's in Bambara and in French, the two languages that are used in Mali. And it shows someone who's drinking too much and weighing too much, losing weight, the bedwetting resumption, getting too tired, excuse me, and a very sick child. And saying, think about diabetes if there's any of these signs. And we have these posters in many different languages. But in India, it may be a differently designed campaign. That's fine. We have to think about how do we get the message through to the people who need to understand this message. And so soon we'll be having, or JRF will be having a request for proposals. So the T1D Index project, we're putting out a request for proposals for initiatives that aim to reduce deaths from misdiagnoses. We're looking for adaptations and innovative interventions appropriate for the Indian context, which are measurable. The second point, and I'll go through these very quickly as I come to a close, is improving the level of care, especially in regional and rural areas. And Apurva has already spoken at length, very adequately on this, but there's challenges in many areas, as you can imagine. And so that's why we designed this chart, trying to emphasize intermediate care, which is more affordable, easier to deliver, and yet it still has quite good results. And you can see here, this is data that we published from Pittsburgh, University of Pittsburgh, about what happens over 30 years at different HbA1c levels. Let's just look at blindness, which is the green bars, and renal failure, which is the dark bluey, sort of purpley bars. Dark blue bars. And this is over 30 years. And you can see if you can have an A1C of 8.5%, you've got a very low chance of going blind or needing dialysis or otherwise transplant or otherwise dying. Even at 9% on average, your chances are very low. It's much better to be down here at 7%, but you can virtually eliminate these very serious long-term complications over 30 years with an A1C of 8.5 or 9%. But if you're at 12.5%, which a lot of these kids are at, then you've got a 50% chance or more of being blind or developing renal failure over 30 years. And actually, usually from the data that we had, it didn't take 30 years. It took about 14 years or 16 years. And then in the absence of dialysis or transplant, the child would die, or the young person would die. And so there's already a lot happening and improving care. And there's many local initiatives, and I've listed some of the ones I know, some of the ones that I know about here, but there's many others. And then Life for a Child is helping, and Changing Diabetes in Children is helping. There needs to be more education of nurses and doctors. There needs to be benchmarking. What I mean by that is looking at your clinic's A1C and thinking, how does that compare to Chandigarh? Or how does it compare to Ahmedabad? How does it compare to Sydney? How does it compare to Stockholm? And thinking about, okay, well, theirs is better than mine. What can I learn? Or maybe we're doing okay, but we need to change that. That's what benchmarking is. It's comparing your clinic's results to others. And then advocacy leading to government provision. And this is where I'd really like to congratulate Dr. Sujoy Ghosh from West Bengal, from Kolkata. 5 districts there are getting glargine and regular insulin in vials with syringes, 1 strip a day, which isn't enough, but it's a start. A1C testing, complications screening, and education. And this is happening with national and state government funding. And Dr. Ghosh is working that in as part of the new National Juvenile NCD program, which he's been promoting to the government. And the government are interested in taking this up and rolling this out in a larger way through different states. This is a very exciting approach because it's potentially a sustainable approach. And then finally, and I think this is my last slide, we need mapping and better data. And there are expert centres in many major cities in India, but it's not clear what's happening in many other areas. And so it's most likely that Dr. Mara Said, who's the chair here, will be doing a project to look at this and try and map what's happening in India, not just in the famous clinics that everyone's heard of, like Dr. Mohan's clinic or Dr. Sabu's clinic, but all over India, what's happening, and how do we get education materials out there? How do we build connections? How do we do benchmarking, these sorts of things? And also we need more incidence data. It's quite possible that incidence varies a lot. India is a very diverse country in terms of its environment, in terms of its ethnic makeup. You know that. And quite possibly the incidence varies a lot across India. Is it higher in urban areas? It quite possibly is for various reasons. But that's important to know. And then finally, mortality data. We have very little published information. And so Life for a Child is helping in 45 countries. We are helping 15 centres in India with analog insulin, analog long-acting insulin, and also blood glucose strips, 3 tests a day. And we're very happy to explore helping new centres next year. So if you'd like support, please contact us and we can discuss that. And our vision as a program is that no child should die of diabetes. And I'd like to thank you all for listening and for your attention.
Thank you, Graham. Thank you. That was tremendously insightful. And I think it follows on well that Tom is going to be joining after you to kind of put this into a context surrounding action moving forward. So Tom, please take it away.
Thanks, Emma, and thanks, Graham, for jumping in. I'm very sorry about the internet troubles, but as they say, the third time's the charm. So let's hope that this works more smoothly this time. it's been really exciting yesterday and today seeing so many of you using type 1 diabetes index data. It's exactly what it was built for. We wanted it to be a useful set of numbers that let people identify how to take action. And I'm going to tell you a little bit about where those numbers come from and also about how some of the ways that we're seeing them being put to use already to share with you. But I'm conscious I'm part of a group here of people who are taking incredible action, whether it be Sujoy's programs in West Bengal, Dr. Sada's work, and many, many more of you. I won't enumerate the full list. This is a group that's changing India for type 1, and it's very exciting to be here. The index tool is available as a paper on thelancet.com. It's also available at t1dindex.org, and you can go and type that in right now if you like and go to the website. We also have a more detailed dashboard that's available, so you can get additional numbers. It's more for scientific use and for medical practitioner use. And then finally, for those of you who are data scientists, there's or familiar with code, all the code is available open source on github.com. And you can find the link to that at t1dindex.org. And that means that you can take the code and you can investigate it and you can improve upon it. And in fact, one of the goals that we set ourselves was to create this first set of estimates that we could all improve upon over time. And early next year, we'll even release some prizes for people who make the best improvements so that we really bring together the whole global community to get the best possible numbers and a single source of truth for type 1 diabetes data or epidemiology.
Emma.
Okay, Tom, do we have you still? Okay. Unfortunately, I think we have lost Tom again. So considering the timing right now, maybe we could get into a bit of a discussion. And if Tom joins again, we can involve him in this. So I'll pose to the audience any questions that you may have specifically for Dr. Apoorva or for Dr. Graham. Please do enter those into the chat. But I'm sure, Mahira, you may have a couple of questions to Graham and to Apoorva, but I certainly have a couple of questions to start us off with, and maybe Graham, you can kind of take the space of Tom here in this regard to speak on the index and also the numbers globally and for India. But so first I'm going to ask Apoorva this question, and then Graham, maybe you can give your comments back to Apoorva. So Apoorva, I think, we can all agree that the index is a first of its kind, incredible tool to truly display the burden of type 1 diabetes care on such a drilled down country and national level. And so putting this in context for, the places in which you have had a lot of experience in working, of course, in India, but also in Malawi, how do you really see the index in helping to ensure diagnoses are made to that 100% level and that those with T1D continue to have the tools that they need to thrive? So how do you expect the T1D index to help address the chief building blocks, as it were, of low access to type 1 diabetes care in the years to come? And then Graham, if you'd like, please do respond to Apoorva.
Yeah, thank you so much, Emma, for that question. That's a really big question. I know too big a problem. And I think T1D index, like Graham also pointed out in his talk, really tells us a lot about diabetes for people who for years did not believe that type 1 diabetes actually exists. We can actually give evidence to the fact, yes, type 1 diabetes is there. It's a problem. We can finally talk about that. yes, it can happen in children. There are so many people who are just misdiagnosed, and they're just misdiagnosed with probably malnutrition, malaria, or some other diagnosis, but it was actually type 1 diagnosis, type 1 diabetes, which was missed. I think we can finally, I think the index gives us that confidence, and it really helps us to talk to the policymakers and stakeholders to finally convince them that this is a problem that needs urgent attention. And if not now, then when? I think Graham can really talk more about it. That like coming from my experience working in India as well, like I remember like during our medical school training, we were never taught about type 1 diabetes. We were always told this is a rare disease of the West. It doesn't happen in India. So I think that, the index now jolts us to actually believe that this is a problem which has been there in India for quite a while. In many of the underdeveloped, resource limited areas, it has been there and often been just ignored by other infectious disease pathologies. And I think that's what the index is giving us now, that finally the clinical providers are talking about it. And then we can actually work together in educating providers to detect and also get people who need urgent type 1 diabetes care earlier on the care and not land up in draconian complications, which could have been prevented by just a simple diagnosis. Yeah.
Yes, absolutely. I just got a message from Tom. Profuse apologies. His internet isn't working for some reason, and he said that he'll record a video and he'll send that to Dr. Sabu tomorrow. So yes, I think the problem of misdiagnosis is acute because it's a child that is either going to live or die, whether if the diagnosis is made and or not. And we know that as doctors, I think we can all jump to conclusions when we see young people or older people with a condition. We can think it's this because of that and that. And then we have to sort of backtrack, don't we? Sometimes when we get the results of the tests, or when we think more, or when someone else looks at the patient. And so I think, as Apurva has said, it's important that this goes into medical education of doctors and nurses. It also goes into the clinics, into those primary health clinics that Apurva was talking about, where these young people are first seen. And that's where I think the posters can be good. Now, maybe it won't be posters, maybe it's some other way, getting the message through to teachers as well, and religious leaders who will see young people and note if a child has to go off to the toilet often and everything, that they will wonder what's happening. And I think also in emergency rooms, anyone who's sick, any child who's sick, and it's not, they haven't just been involved in a car accident or something or other, they're sick and it's not quite clear what's happening. Even if they've got a fever, they need to have a blood glucose test done just to be certain they don't have diabetes. And if those things are done, then people will start to learn. And so it isn't a simple fix, but it's a fix that will save life after life.
Absolutely. And I think this kind of feeds into my next question. I can think of kind of no better time for the T1D index to come to the fore and really have as much light shown on it as it presently has, because, I think in the global diabetes space, there was so much momentum in 2021 and in this year in 2022, because in 2021, there was the discovery, the 100-year mark of the discovery of insulin, and then 2022, the 100-year anniversary of the first use of insulin. And so I think many already very active players in the global type 1 diabetes space are kind of sitting at the edge of their seats, holding their breath, saying, both what next and also how do we keep this momentum going? How do we not lose steam? And so I hear all of these connections being made at a very high policy epidemiological level with the T1D index filtering into the ground level with healthcare professionals and those living with diabetes. And I feel, personally, and I'm sure we all do, very excited about this. But Apoorva, I wonder how you think that we can keep this momentum going that we have seen over the last 2 years, so that this steam is not lost. And I'll even posit this super difficult question to you both, Graham and Apoorva. Where do you see us in the next 10 years in terms of access to type 1 diabetes care globally?
Okay, I can go ahead first to answer this. I think there were years, and this should have happened way sooner, that finally the attention towards type 1 diabetes is now getting so much high on the agenda because of so much advocacy around it, and people living with type 1 diabetes finally breaking those stigma barriers and finally talking about it. I think the momentum needs to continue, and there is no way we can stop here, because we've seen the challenges after the pandemic, the COVID pandemic, how people, especially the ones who are deeply facing challenges because of where they belong or where they come from, the social determinants of health play a huge role in the clinical outcomes in diabetes care. And I think the momentum cannot, it just has to go up, and it's our responsibility as clinical providers, and also that we need to make sure that people who are living with type 1 diabetes get their basic right to insulin. And when there are advancements in technologies and advancements in also insulin delivery models, it's important that we need to ensure an individualized, patient-centric approach and make people living with type 1 diabetes an integral part of the care as well. And we know the type 1 diabetes incidence is on a rise, and this is not just about ensuring everybody has access to insulin, access to diabetes supply, that is basic necessity, but also ensuring that people living with type 1 diabetes have psychosocial support and peer support so that they can thrive living with type 1 diabetes and not just survive. And I think that is what should make us motivated to keep the momentum high, and that like the motto of Life for a Child, that no child should die of type 1 diabetes. I believe that no child should feel limited because of diabetes. That should be our final aim when we think about improving diabetes care globally. Over to you, Graham.
Yeah, no, I agree, and there's been pressure on me to change that byline to something that you say, and yet there are still young people dying. So that's why we've kept it like that. But of course, that's just the first step. The second step is and as I was talking about, is to give them a level of care with the education that we all understand is critical. That they can manage themselves so that they can live like they want to. In the next 10 years, I think it will be little advances here and there. It'll be gaining sustainability, building sustainability. In Australia, a big one was earlier this year, where flash glucose monitoring, or CGM, became available for everyone with type 1, provided by the government. It was available before that for young people, but not for everyone with type 1. So that was an advance. I think what Sujoy Ghosh is doing in West Bengal and potentially across the country is really exciting. And I think to get the government involved in providing care at a reasonable cost, and the Pen Plus program rolling out in countries where it isn't just a decision at a meeting, yes, we're going to do this, yes, we'll sign here, but this is actually going to happen in our countries. That's where the rubber hits the road, isn't it? And I think we can support that by pushing for this, and encouraging diabetes advocates, people living with diabetes, to have their voice heard, and for us, working within the diabetes community and the medical community to build better sustainability. There isn't going to be a simple fix. And even if tebuzumab's been approved in America, and that appears to delay the onset of diabetes, type 1 diabetes, for a period. But even if that was rolled out tomorrow, it's still not going to solve the problem. We've got a problem here. But I think the increasing attention that's being paid to it, and the various initiatives that are happening and how they connect, is making a difference.
Brilliant, super uplifting answers, but also I think quite realistic as well. Mahira, do you have any other questions?
I have one question for Graham. It is from the epidemiological point of view. As that is my interest, and I just wanted to know, I'm curious to know that when you talk about this many people might have been alive, how have you arrived that calculation from? Like how can we get that numbers from?
Yeah, it's essentially you model the what can happen to a person, and they might die tomorrow from their diabetes, they might die much later. And you model you model 1,000 people and see what happens, and they have a particular chance of dying each year. And so just because I've given a number that the life expectancy may be 34, as we know, some of those people, some people die earlier than 34. Some people might be 80 when they die. And so it's adding up the numbers of all of those people who died before the average person without type 1 diabetes does. So it's a mathematical model that runs over and over again, looking at different and adding up at the end what's happened. It's a little bit hard to explain over a Zoom call, but I hope that helps you understand it a little bit better.
Yes, I could get that, and I'll find out more on that.
Well, if there are no more questions from the audience, I think we will finish about 5 minutes early. But I'm sure Apurva, Graham, and Tom would be more than happy and delighted to carry on any questions or conversations that you may want to continue with each of them, as they come all from such different angles at this. And to just close out, thank you so much to Banshee, Dr. Banshee, for organizing such a tremendous couple of days of learning, and all the best for the next day going ahead. Thank you all.
Thank you so much, ma'am. Well, we are done with the questions. I would like to thank all the dignitaries, Dr. Apurva Gombar, ma'am, Mr. Tom Robinson, and Dr. Graham Ogle. It was fantastic to have you over here. I would also like to thank the chairpersons, Ms. Emma and Dr. Mahira. Thank you so much. It was a pleasure. So I would like to introduce the chairpersons for the next session, and those would be Dr. Sanket Pense. Dr. Sanket Pense is a consultant in diabetology and internal medicine at the Diabetes Clinic Research Center, and Ms. Gopika Krishnan. She is the academic head for Jyoti Dev's Diabetes Research Center, Trivandrum. So over to you, both the chairpersons. If you're there, Gopika ma'am and Dr. Sanket Pense.
Dr. Sanket sir is here. So
I'm here. So very good morning to all of you. I'm Dr. Sanket Pense from Nagpur, and a very good morning to Dr. Graham. Excellent talk. We'll move to the next session. That is, the first talk will be by Dr. Nimri from Israel. She is a senior pediatric endocrinologist, director of scientific and technology diabetes service at Snyder's Children's Medical Center of Israel. She is expert in diabetes, focusing solely on new and innovative technologies for management of type 1 diabetes. And her talk will be on artificial intelligence and decision making in type 1 diabetes.
Good morning. Can you hear me?
Yes, ma'am. Good morning. Good morning.
Good morning.
Good morning, everybody. Can you look at my slide in the full screen?
Yes, it is
Or
visible.
it's a full screen because I don't
Yes.
see it.
It's a
Okay.
full
It's full. Okay, because I see it in part of the screen. Sorry. Thank you so much. It is my pleasure to join this meeting, and it's early morning here in Israel. And thank you for the organizing committee and Dr. Banchi Sabo for inviting me. This is my disclosure slide. Okay, I hope that you see, because I don't see so much the slides. My talk today is about the clinical uses of artificial intelligence-based decision support system. I'm going to start with what do we mean by artificial intelligence-based decision support system? Why do we need it in the world of diabetes? Talk a little bit about the available artificial intelligence-based decision support this system. Does it work for healthcare provider and people with diabetes? And we'll end with a glimpse into the future of AI in diabetes. So let's start. Clinical decision support system, what does it mean? In brief, it's a system that uses tools that make sense out of data and support informed decision-making. Today, we have a lot of data related to diabetes treatment that can be easily collected. We have uploads from CGM, from pump. This abundant, valuable data must be linked to system that can process and analyze the data to provide actionable therapeutic recommendation. Therefore, decision support systems have the potential to improve clinical outcome and may increase access to care, enhancing utilization of healthcare resources by integrating e-health and telemonitoring program, and particularly important in the perspective of precision medicine. And what is artificial intelligence? Is the tool that can analyze this amount of data. It's a smart machine or computers that capable of performing tasks requiring human intelligence like learning and problem solving. So can we do without a clinical decision support system? Yes, we can do it in the old way. We can analyze the data in an old way, just like navigating with a map, because we can use plenty of general consensus statements and guidelines that are there, how to treat people with diabetes, how to support diabetes care, and are we successful with that? So the quality of care for people with diabetes is not getting better. But even worse, data published just last year in the New England showed that in the last decade, only 1 in 4 adults meet all the 3 ADA recommendations for care, and less than half achieve the target glycemic control, with even less success, as you can see, among insulin-treated people. So something is not working, and we need to find new ways and strategies to tackle diabetes. And for that, the ADA, the American Diabetes Organization, recognized the gap in current practice and the need for new ways and strategies to improve the quality of care. For that, you can see here in this slide, this ADA practice framework was issued and recommended integrating decision support system into the workflow to support providers in clinical decision-making and treatment adjustment, and people with diabetes for self-management. And you can see also that other diabetes associations advocate the use of apps and digital tools and decision support system, like the American Association of Clinical Endocrinology, the Ispad, the EASD. So can we do without a decision support system? Like we said, yes, but we probably can do better with using decision support system, just like the ways enable us a more effective driving instructions, like to choose the short way or the way without traffic. And a wide range of decision support system and diabetes application are available to support almost all aspects of diabetes management and treatment, from physical activity, nutrition, training, and physical examination, up to system for calculating insulin delivery, how much insulin to deliver. And I classified all this decision support system into 4 main categories. First, tools that support people with diabetes for self-management, tools for diagnosis, screening and prevention, mainly for diabetes complication, prediction tools like models for new onset diabetes prediction and prediction of hypoglycemia. And the last category are tools for clinical management support for insulin dose adjustment and inpatient treatment algorithms. In the upcoming slide, I will give some example of decision support systems that are there in use. And this is a nice study from 2007 that showed nicely that different people have different postprandial excursions after consuming the same piece of bread, as you can see here in the illustration, demonstrating the need for personalized nutrition recommendation. And today there are apps for self-management tools that use different ways to predict individual postprandial responses. This can be based on CGM data, wearable sensor, microbiome, and body composition analysis. And I brought one example that I like is the Under My Fork app that combines glucose data with photo-based food logging. People are asked to take photos of meals. We all do it nowadays. And the app automatically recognizes and tags the foods. The app sorts meal into green, into amber, and red and categories based on the 2 hours postprandial time in range. And this data from previous meal may help with decision on what to eat in the future and how much insulin to give in future when you eat the same or similar meals. And this data can also be shared with the healthcare provider. Another tool is for physical activity, because one of the barriers for physical activity is the challenge that it possesses for people with type 1D. And decision support system can provide physical activity support. The general idea is to take data on glucose, insulin, nutrition, and connect it to fitness data like Fitbit or Apple Watch, analyze and provide personalized advice to support physical activity. For example, the Diabetes app that predicts future glucose level using a machine learning algorithm. It's case studies algorithm that learn from the past how glucose level will be in the next time doing the same exercise, so treatment can be adjusted. And decision support systems are also available for exploring diabetes-related complication. On the left, you can see FDA-approved software that uses artificial intelligence to analyze images of the eye taken with retinal camera and detect diabetes retinopathy. No need for ophthalmology. And it is done automatically, so it can be a great tool for screening in clinics in rural areas. And there is also apps, another mobile apps that called FootSnap. As the name indicated, a software for longitudinal follow-up of feet by images of the feet of people with diabetes for early detection of pathology such as ulceration. And we also have several prediction tools that are being developed using big data and machine learning for precision medicine. There are plenty of ideas and we don't have time, but I gathered some of the examples like looking on data and seeing that different people respond differently to rapid insulin injection, prediction of how people will react to immunotherapy, analyze data to detect people with prediabetes in primary care settings for early intervention and treatment, and so on. So hopefully I convince you that one treatment doesn't fit all. Technology should be personalized, targeted, and suited to individual need. And this can be done with decision support system. And for the question, can a software provide better patient care? There are several randomized control studies showed in this table that showed better glycemic control when using these decision support tools as reducing hemoglobin A1C. And the abundant, like we talked before, the abundance of insulin and glucose data uploads, like we see all the data that we have from sensors, from pump and so on, can provide really important insight into the management of diabetes. But we need to find them in the huge amount of data. And this takes time, effort, and knowledge that does not always exist. An artificial intelligence-based decision support system can provide a comprehensive data analysis within a split of a second. Such an automated decision support system is the EndoDigital. It's a cloud-based system that utilizes glucose, insulin, and other data uploaded from the various diabetes management devices. It uses artificial intelligence to analyze the data, deliver structural visualization of the data, and suggest treatment adjustment for pump therapy and also for multiple daily injections, both for type 1 and type 2, as well as personalized diabetes behavioral recommendations, all within a split of a second. The user receives the treatment plans and behavioral recommendations from the smartphone app. After approval by the provider, this decision support system is intended for use by healthcare provider. So this is how does it work? First, the provider enters the population tracker, find the patient, and ask for a new recommendation with a click. And within a split of a second, you can see it here, it gets recommendation how to exactly adjust insulin doses. Here is the first page is for the basal. You can see in bold the recommendations. The provider can edit the data and look for the data in the bottom of the page. You can see here there is the AGP in the bottom. There is a logbook that you can see all the data and the daily data. It's all to simplify the provider review process. Then going to the carbohydrate ratio in the same way as you can see here. And then next to the correction factor. In right, you can see the recommendation. Looking again for the data. Once the provider, the healthcare provider, approves the data, you have the final report to look at it, to write comments, and then by clicking approve and share, it is sent directly to the patient so it can see the recommendation for changing in insulin dosing. Sorry?
Excuse me?
Dr. Delia, can you mute yourself?
Sorry?
Dr. Delia, can you mute yourself?
I am sorry, I cannot.
I'm sorry, ma'am, just a second. Dr. Umesh, sir, yeah.
Yeah. Thank you.
Sorry, we can continue. And a decision support system that you can seek should provide comparable quality of treatment as an expert physician would, wasn't it? This was demonstrated for our system, the EndoDigital, in several survey studies, which have shown that recommendations generated by the system automatically were similar to those of experienced physicians for the same set of data. The next step was we conducted a multi-center, multinational prospective randomized study that also demonstrate non-inferiority in glycemic outcome between the arm that was treated by expert physician and the arm that was treated with the algorithm, the EndoDigital. And we also have some early data of the effectiveness of the system in real-world use that I will present. So first, for the degree of agreement, you can see the results of the first survey of pump user. We gave 26 experts the same set of patient data and asked them to give insulin dose recommendation. As you can see, the level of agreement between physician in red was around 45% for the basal rate, CR and CF. It was similar to the level of agreement between the EndoDigital recommendation and the physician for the same patient set of data. You can see it in blue. And we did the same survey, giving this same data for expert for people with that using MDI, either type 1 and type 2. And you can also see that the level of agreement between physicians in the upper panel was similar to those between the physicians and the artificial intelligence-based decision support system. So we can conclude and say that the automatic decision support system, the EndoDigital, is just like another team to consult with, another member in our healthcare provider team. And this is exact medicine is not an exact science. Therefore, it is acceptable and encouraged to consult and ask for a second opinion. And this is always happens in Grey's Anatomy, but also needed for the single doctor participating in his or her own clinic with no one to consult with. An artificial intelligence-based decision support system can be his or her consultant. I'll show you now the outcomes of the multi-center, multinational study that we conducted that included 7 centers of excellence in diabetes care around in the US and in Europe. We had 108 young people, average of 15, 16 years, with baseline A1C of 8.4. And after, you can see here the study overview. After a 3 weeks running period, eligible participants were randomly assigned to participate either at the advisor, were given advice by the decision support system or by the physician arm. Every 3 weeks, participants upload their pump data and CGM from home and receive insulin dose adjustment recommendation. And here are the outcomes. After 6 months, glucose control was found to be similar between the two arms, the one that received insulin dose adjustment by a machine, by the decision support system, or by expert physician with 20 years of expertise in diabetes. So a similar reduction in glycemic hemoglobin was observed between baseline. You can see here, it was significant only in the decision support arm. Thus, decision support system has the potential to automatically recommend insulin dose adjustment while matching the current safety and efficacy standard of care provided by experienced physician. And we can say that great minds think alike, and the study outcome provide evidence that an algorithm can be fed with human intelligence and get similar results. In this slide, you can see the reports for the MDI page and the app for MDI that has a diary and a bolus calculator. And I just want to give a glimpse for the diabetes behavioral recommendations. This is an important behavioral management causes that the algorithm gives for hyperglycemia and hyperglycemia. The one for the hyperglycemia, for example, is that you don't treat your meals. You don't give a bolus before the meal, or for hypoglycemia because you don't use the meal boluses. And the recommendation is phrased in a positive and non-judgmental way, underlining the motivation for following the advice. It gives an advice like this: I noticed that many of your heights may be avoided. Replacing your pump tubing or pod every 2 to 3 days may help to get better results. And here are some the ones from a real world analysis of the management behavioral tips. And it's not surprising that the most frequent behavioral recommendation for hyperglycemia was missed boluses, and for hypoglycemia was blind boluses. We also ask 18 providers who use the decision support system in the routine clinical to indicate, in their opinion, the key benefits of the software. And interestingly, most providers stated that the key benefit was that the software recommendation facilitate useful discussion with the person with diabetes and the family. And here is a quote from one of the physicians: the algorithm has been great at recognizing over-treatment of lows, and so many of my family just smile and say, yes, I do that. It's been helpful. And I want to give you also a glimpse for the EndoDigital that it is already in clinical use in the US. And here is data, initial data from real-world use, including 122 individuals from 10 pediatric clinics. As you can see, 50% of the population increased their time in range by more than 5% when using this decision support system, with no increase in hypoglycemia. And we also evaluated the level of agreement over time. And in this longitudinal analysis, you can see that there was an increase in the level of agreement that might imply over time, that might imply that provider gain trust over time with the system, like in every technology that has its pace of acceptance and adoptance. So I can conclude and say that there are many expectations from decision support system to improve clinical use, to use in telemedicine and so on. But I think that the most important is that it enables personalized care. And with these tools, people with diabetes and healthcare providers are not alone, as people with diabetes manage their diabetes mainly on their own. And it is the time for automatization of treatment decision. And in the future, we see that each person with diabetes will have his or own Genie app, like a physician in the pocket, who accompany the patient anywhere at any time, who knows everything about him or her individual medical care and so on, and can provide and support personalized therapeutic decision in every place. And I would like to thank you all for listening, and a special thanks to our team at Schneider Children's Medical Center of Israel. And then I invite you all to visit. Thank you.
Thank you, ma'am, for an excellent talk. It was truly an excellent talk and a good overview of the clinical decision support system. And like the way you put it, as a team member, rather than replacement of the physician. It is a team member of the physician team. That's a very good way of talking about artificial intelligence. So we'll have questions at the end of the session. And if there are any questions from the audience, please type them in the chat box. And I would request Dr. Gopal Krishnan ma'am to introduce the next speaker.
Thank you. Thank you, ma'am. So we'll move on to the next topic. So let me take the pleasure of introducing Ms. Jaz Sethi, who has become the digital face of type 1 diabetes community in India. I recently listened to her at the Detox Symposium at Ispad, and I could literally see how she is touching the lives of thousands of people across the globe with type 1 diabetes. So Jaz Sethi is the founder and director of the Diabetes Foundation. She was diagnosed with type 1 when she was 13, and she is currently on PALM CGM and the DIY loop. She is on the IDF's Young Leader of Diabetes for Southeast Asia for 2019 to 2022, representing India. The Diabetes Foundation works closely with Diabetes India, RSSDI, and NHS England for developing projects and publications. She's also a certified diabetes educator and did her training with the IDF program. She's also a professional dancer, choreographer, theater artist, and a published author. She completed her training from Broadway Dance Center in New York and AEF from Florence. Her mantra is simple: live happily and ball regularly. So welcome, Jaz. Let's listen to her.
Thank you so much, Gopika, and thank you everyone for the invite. And it's very so happy to be here and do this best of Ispad session with everyone. And I have a very interesting topic today. Normally, I'm always asked to speak about DIY loop, which is also great because it's something I'm very, very passionate about. But today, I think we're going and delving a little deeper into that. So bear with me one moment. Hopefully, you all can see my screen.
Yes.
Correct. So I think, like I said, I always talk about DIY loop and how to set it up and things like that. But today we're sort of going into a more collaborative approach and talking about how HCPs can assist people that choose to use DIY. And this is, I think, a very important topic because at least in India, we found that, a lot of times there is a gap between what the HCPs can provide for the patients who are with type 1 and their sort of will to start looping. And I'm going to share a few tips and tricks that I feel and I have found very useful when I began my looping journey, and how all the doctors listening today can actually support their patients that come in who choose to loop. So I think it's very, the basic fundamental of this concept is for the HCPs to, this is where I would start, right? That I think understanding the concept first and foremost is the most important part. Maybe a few HCPs are not aware about the looping concept, which is totally fine, but understanding the concept first and then really believing in the system. So understanding the concept is one thing, but truly believing that it is something that can change lives, it is something that can improve quality of life of a lot of people is very, very important. And then giving and highlighting the options to people living with diabetes. Now, I know that it is a little bit complex, and maybe there are a few healthcare professionals who may not be that tech savvy, again, which is totally fine. But it is still important that one must highlight that these are the options available. A lot of time what happens and what I have personally seen is that a lot of people with diabetes just don't know about looping and they haven't heard about it from the healthcare fraternity. So I think this is especially true for India. And I would like to mention that this is coming from a very personal experience also, that I think doctors and educators and guides should be able, even if they don't know how to set it up, they should highlight the options to people living with diabetes and then signpost them to resources and people. So let's say I don't know how to set up a loop system, it's okay, but I will connect my patient with somebody who does know how to set up the loop system. And I think that's very important, to create a network of support and to create a network of people and collaborators who together can work towards this. So I think that's the biggest and the most fundamental thing. One is to understand the concept, believe in the system, believe that this is something revolutionary, give options to people with diabetes. When they come into your clinic, give them the option, as we give the options for there is a pen system, there is a pump system. I think there is a very important option that you need to give that there is a loop option also available. And then if somebody is interested in looping, then you signpost them to the resources, you signpost them to people, let them connect with each other and take this journey on. So the biggest thing is, like I said, understanding the concept. What is DIY looping and what does it do? So getting the basics of the understanding, which is that it is a system wherein you hack your pump and your CGM to make them talk to each other, and you it makes decisions on itself based on the inputs that you put in as a user, which are things like ISF and ICR and suspend threshold and target range and things like that. Then you also, I would say, understanding the concept also requires you to understand the tech that is required. So yes, a person who wants to loop will require a pump for sure and a CGM for sure. And then based on the different system that they're on, they would require a third party, maybe a radio frequency device or sometimes an Android phone, or sometimes they'll have to build their own rig. But just having like a quick chart that tells you that, okay, this is the hardware that is required, this is the software that is required for somebody to start looping. Again, you don't have to know it. I understand that you may not have the time to actually understand the nitty-gritties of the coding bit of it, but just to broadly understand what is required. Also, as a healthcare professional, because DIY is not FDA approved, it's also important to understand the risks, but at the same time also understand the benefits. So, and this is something that you very cautiously tell your patients also, that, yeah, there are risks involved, that, this is not FDA approved. There's no like customer helpline available 24/7. But you also need to tell them that there are a lot of benefits, which is like 90% time in range, frequency of hypos decreased and things like that. So this is the broad understanding of the concept that I would recommend for the HCPs that are watching this. When I was talking about making them aware of the options, right? So when making them aware of the options, like there are loop, either you can take Open APS, you can take Android APS, or you can take the new free APS. And these are the different software options that one can use to begin looping. So it's very important that you tell them that this is not like you go and there's only one thing available. There are different options for different people's needs, for different people's budgets, and for different people's lifestyles. So making your patient aware that these are what is available. And again, this is a very quick breakdown of the main three that are in the market right now, which is Open APS, Android APS, and Loop. Open APS is a system that runs on a small rig, which you need to build yourself, which has like a Raspberry Pi and things like that, and works with legacy Medtronic pumps and any CGM. And it can be set up using any type of computer. So it's very important, right? Because somebody may not have an Apple computer, but they might have like a Dell computer. So which one would they choose? It's not practical for them to go buy a new laptop because that. So, or what they can get their hands on, what they can acquire. Android APS is an Android only base. So you need to have an Android phone for this. And it uses the Open APS algorithm and works with Dana pumps, Roche Combo, Roche Insight, legacy Medtronic pumps via RileyLink, and Omnipod EDOS via RileyLink as well. And then the Loop is an Apple only framework that uses an algorithm that runs with legacy Medtronic pumps, Omnipod, Dexcom, or Medtronic CGMs, and requires a third-party radio frequency device to communicate between all. You, of course, require an Apple phone for that. So again, just having something like this with you in your clinic will help you distinguish and understand the characteristics of what it requires. And then also it's very important to make your patients aware of the hardware and know the alternatives, what we call jugaad in India. So, for example, to loop, you don't require a Dexcom only. A Libre with a third-party transmitter like a Meow Meow or a Bluecon will also work. And also just know what are the pumps, because looping does not work. DIY looping does not work with newer Medtronic pumps. They only work with the older models, which have a lesser fireware. So it's important to, again, I would suggest all clinics to have a chart of all the looping options, what pumps are required, what CGMs are required, what laptops are required. So at a glance, your patient can see the options. Then the biggest thing I would say, like I would, if a healthcare professional does not know how to actually do the coding, again, which is totally okay, guide them to resources that can help them. And the first three, what I have mentioned, are the best ones out there. You can take a screenshot of this slide. Please do that. because these are resources that will really help. They are very detailed. They are very easy to understand. So for looping, it is the loopkit.github. For OpenAPS, it is openaps.org. And for Android APS, it is wiki.apps.app. And then those are the main like tutorialish websites. Then there are also great blogs that have gone into the details and given you other tips and tricks. So one of my favorite blogs for looping is Diabet Tech. It's run by a great friend of mine. He's absolutely fantastic. He himself uses Android APS and he's great with tech. So these are some resources that I personally, as a user of DIY Loop, also refer to time and again. But I would really recommend you giving these to your patients if they want to loop. These are some of the screenshots of what it looks like, some of the documents. Yes, it is a little lengthy, but it's a lengthy process. So you need to sort of sit through this. There are also a lot of YouTube videos that you can recommend your patients if your patients are not ones who like to read. So maybe a YouTube video would be better. I have personally done one as well where it's a video of me setting up the whole my loop system, and then there are other videos wherein they give you more of a tutorial kind of a vibe. So again, give your patients these videos and ask them to go and see it. Biggest thing I would say, and the biggest thing that helped me when I was looping, is connecting them to people who loop. And this changed my life, right? Because they can really give you a user-centric advice about how to start looping. And I was connected with a few people in the UK, and I bothered them with every type of question, the most silliest questions to the most complex questions. And because they had gone through this journey multiple times, they were able to help. So today, when somebody asks me if they want to start looping, I can help them because I have had the experience as well. They can, help them with the initial hand holding and help them set up the tech. And they can guide with personal lived experience, which I think is the most important one. There are lots of social media groups which you can ask your patients to join. This is the one I am personally a part of. 30,000 other people are part of it, but it's called Looped. And this is only for people who are using Loop, but there are similar Facebook groups for people who use Android APS and Open APS. So again, if somebody from your centers want to start looping, ask them to go join these groups, because these groups are active all the time. These are literally the customer helplines, which we don't have in the looping community. This group becomes it. So please do ask them to join these groups, because you get the maximum detail from these groups. So I would just like to conclude by saying, the first thing that at the end, like for HCPs, don't resist and don't fear the technology. Sometimes what happens is when we personally don't understand something, we don't tend to recommend it because we are not too sure about it. So I just want to say to all the HCPs out there, that's totally fine. I mean, you're doctors, you're not supposed to know technology and coding. But when this revolutionary thing has come out, try not to resist it, because there are people who can support you. So again, you are still required to do the insulin dosing and the management and things like that. But we can get people who can help with the code and who can help with setting up the things like the DIY. Be cautious while explaining the risks. Don't scare them that there's no helpline. It's on your own. Yes, but there are risks and you must explain those risks. But also be optimistic while sharing the benefits, because I feel in a risk-benefit analysis, if you do, the benefits of DIY looping are way higher than the risks. And have allies who have lived experience. Like me, for example, if there's a doctor that wants someone to start looping and they're not able to explain it, get people who are looping to talk to them. And that will really, really help them. Because honestly, like I was talking about the risk-benefit analysis, this is the risk-benefit analysis in front of you. How looping drastically shifts one person's management is something that I have personally experienced, and it is life-changing. And to all the HCPs who are a little bit, who want to try something new, I would say, why don't you try setting up a loop system yourself with all these resources, so that even, once you do it once, then you're very comfortable to recommend it to someone. If not, like I said, there are always allies who are ready to help. So yeah, I would just like to end by saying that diabetes has always been do it yourself. It's always been DIY. So let's use this technology to get the best quality of life for people who are living with type 1 diabetes. Thank you so much.
Thank you, Jess, for that enlightening session. So you made us feel that DIY looping is something like a cakewalk. So thanks for that. So we'll take the questions to the end of the session, and I'll request all the delegates to type your questions in the chat box. So we'll move on to the next topic. So.
Thank you, Dr. Jas. Thank you, Ms. Shetty, for an excellent talk. And we are in the third talk of this session, which will be delivered by Dr. Aspi Irani. He is a senior consultant pediatrician from Mumbai, a very passionate doctor for type 1 diabetes. He is trustee in charge of medical services at JDF Maharashtra chapter, joint editor and member of writing group of Ispad guidelines for management of diabetes in children and adolescents. And he was invited speaker at Ispad 2016 Valencia. He has also contributed many chapters on pediatric diabetes. So he will be talking about how to manage long-term or how to reduce the long-term outcomes of type 1 diabetes. So over to Dr. S.P.
Thank you. Am I audible? Can I share the screen?
Yes, you are audible.
Sure. Is my screen visible?
No, sir, not yet.
Sorry?
It's not visible yet, sir.
Okay.
It's visible now, sir. Yes.
So the topic I will be speaking on is how to improve long-term diabetes outcome. And my focus will be on the class of patients we deal with. Basically, I'm a pediatrician, so I look after children and adolescents. And the majority of our patients are belonging to the middle class, some to the upper middle class, and many to the lower class. Parents have very little time. In many instances, the parents are both working. So in this category of patients, how do you improve the long-term diabetes outcome? Now, what we would desire is that every patient should receive appropriate, uninterrupted treatment with financial assistance if needed, which we provide at the Juvenile Diabetes Foundation. Every child with diabetes should grow, mature normally, and should remain free from long-term micro and macrovascular complications as long as possible, and enjoy a near normal life expectancy. What is very important also is that there should be no diabetes distress, depression, disordered eating, anxiety, which are known to be commonly associated with pediatric onset diabetes. Comorbidities, especially thyroid and celiac disease, should be detected early, treated early. Every patient should be educated in type 1 diabetes self-management. The education should be ongoing, and we should ensure that the child grows up to have a successful career and successful married life. How do you prevent or how do you delay the long-term micro and macrovascular complications and therefore hope for a better life expectancy? There are two important things. The HbA1c should be as close to normal as possible. The current recommendation for the pediatric age group is below 7% with minimum glycemic variability. At least 70% of the sugar values should be in the range, with less than 5% below 70 and less than 1% below 54. But now we know, unlike in the past, that it's not only severe hypoglycemia which can affect the developing brain. Even hyperglycemia plays an equally important role. So the stress is not just on preventing hypoglycemia, but also preventing hyperglycemia. There are three important pillars: the insulin replacement therapy, medical nutritional therapy, therapeutic monitoring. But very, very important, and none of these pillars can succeed unless there is ongoing comprehensive education and, even more important, psychosocial guidance and assistance. Coming to insulin replacement therapy, presently, for all our patients, we use a basal bolus insulin regime. The basal insulin is given to regulate hepatic glucose output in fasting state and to suppress ketogenesis. The bolus given preprandial covers each meal or snack. NPH insulin, which was very commonly used in the past, was not an ideal basal insulin, and hence now we have better long-acting analogs. NPH did not cover 24 hours. It had a distinct peak, which is not what you want in a basal insulin. As a result, children had to snack in the evening during the peak of NPH action, and they were at risk of hypoglycemia in the night. There's tremendous day-to-day variability of absorption in the same patient from day to day. And part of it is because NPH requires very careful resuspension. But NPH does have two advantages. The most important is the cost. It is far, far, far cheaper than any of the analogs, which is why at times we still have to use it. And the other advantage, if one can call it so, is in a poor patient, it can be mixed in a syringe with either regular insulin or a rapid-acting analog. In the 2000s, we had insulin detamir and glargine coming up. They had a much lesser peak as compared to NPH, and they worked for nearly 24 hours. The most common basal insulin we use today in our patients is glargine. In 80%, you need it only once a day. In 20%, we may have to give it twice a day. Detamir, 50 to 70% do need it twice a day. In patients who need glargine twice a day and cannot, or rather who can afford a more costlier analog, we may use degludec or the recently approved glargine U300. Well, if NPH was not the ideal basal insulin, regular human insulin is not an ideal bolus insulin, as you can see here. If you compare the physiological insulin response to meal with the time action profile of human regular insulin, there are three disadvantages. One, slower onset. That means you have to inject 20 to 30 minutes or more before eating, which in children is a big disadvantage, particularly in the short lunch break they have in school. A lower peak, which means that it's less efficient in controlling post-meal glycemia, and a prolonged duration of action, which means that after the meal, glycemia has been controlled, the action still continues, and therefore the child may have to eat a snack in between the two major meals to prevent hypoglycemia, and this can lead to excess weight gain. So therefore, in patients who can afford, we prefer the rapid-acting analogs, Vispro, Aspart, etc., which can be given 10-15 minutes before eating and which cover the meal appropriately and which have a shorter duration of action, so there is no need really for between meal snacking. Of late, Fiasp I have found very useful because it can be injected soon before eating. And in fact, there is data to show that even if you inject it after eating, the results are not bad. And in India, Fiasp happens to be even cheaper than Aspart. Now, the ideal insulin regime in a patient using MDI would be a basal bolus regime where the patient takes a rapid-acting analog before breakfast, before lunch, before dinner, and glargine once a day. Now, if this patient wishes to have a snack between meals, then either the snack would have to be low carb, or the patient would have to take an additional dose of rapid-acting analog or use human regular insulin. The basal dose, we ask the patient to adjust in such a way that the blood glucose is maintained in the target range overnight and before breakfast and also before each meal. The bolus dose is calculated based on the carb content of the meal. For this, the patient has to learn carb counting and know his insulin carb ratio, which in children we calculate as 500 divided by the total daily dose, in toddlers 300 divided by the total daily dose, and then fine-tune the ICR by comparing the 2 hours post-meal blood glucose with the pre-meal blood glucose when the patient takes a meal of known carb content with low fat and protein. Ideally, it should be 20, 30, or 40 above the pre-meal. Some patients may also add extra insulin for a meal with high protein or fat. For every 100 kilocalories of fat or protein, you may need the same amount of insulin that you would require for 10 grams of carb. Having calculated the insulin dose based on the carb content of the meal, then you add a correction dose if the pre-meal blood glucose is above your target. For this, you use the insulin sensitivity factor, which is 1800 or 1500, depending upon whether you're using a rapid acting analog or regular insulin, divided by your total daily dose. And then you may subtract the active insulin. If you have given a bolus in the last 4 hours, assuming that 25% will be used per hour. And therefore, at the end of, say, 3 hours, 25% would still be remaining. If there is activity planned within 90 minutes post-meal using analog, you may reduce the calculated bolus accordingly. Now, MDI compared to the insulin pump therapy. The pump offers several advantages. What are these advantages? With regard to bolus insulin, you can give multiple doses with one painless prick once in 3 days. You can give precise small doses. This is very, very important in children. In a child taking 3 units, if I increase the dose by 1 unit, which is what the pen allows me to do, except for one pen which allows half unit, that's a huge percentage increase in dose. With the pump, I can make fractional increases in dosages. I can also deliver the bolus over different periods of time, depending upon the glycemic index of the food, the manner in which I eat, and the fat content of the meal. And if the child, after taking the insulin, does not eat, then the bolus can be suspended midway. When it comes to basal insulin, the pump also offers many advantages over MDI, since it uses only a rapid analog for basal, which is released in small pulses. There is no subcutaneous depot, and hence course correction during the course of the day is possible. So the basal can also be suspended. It can be reduced for exercise hypoglycemia. It can be raised on sick days. We can set multiple basal rates to the day, which allows us to take care of the dawn phenomenon. And you can have different patterns for different days of the week. And most important, it can be linked to CGM. And pumps can have a low glucose suspend, a predictive low glucose suspend, which can prevent hypoglycemia or delay the time you spend in hypoglycemia. And with the 780G now, automatic basal delivery is also possible. But not all patients in our scenario can afford the pump. The pump would be for those who can afford the additional expense. But I think this is not the most important criteria. More important is patient should be comfortable wearing the pump. The patient should be motivated and willing to put in effort. Patient should be intelligent enough to learn the finer details of pump management. And very, very, very important, patients should receive intensive education in pump management. And of course, have a 24-hour backup facility. Now, when cost is a concern, or when the patient prefers carb-containing snacks between the meals, but will not take additional doses of rapid-acting analog, then we put the patient on human regular insulin, giving it before breakfast, before lunch, before dinner, to cover the main meal and a mid-meal snack. And when an afternoon pre-lunch shot is not possible, and let me tell you, this is pretty common in our situation because many schools refuse to allow the child to take insulin in the school or refuse to even supervise the insulin administration. In such cases, we can give them a rapid-acting analog with NPH in the morning. The analog would cover the breakfast, the NPH would cover the lunch and the snack the child takes in school. And again, pre-dinner rapid-acting analog with glargine at bedtime. And for the patient who cannot afford analogs at all, then we use the basal bolus regime with NPH and regular insulin. The regular insulin, as in the previous instance, covers breakfast, lunch, dinner, and the snack following each of these meals. And a small dose of NPH is given before breakfast to fill the gaps between the dosages of regular insulin, and a larger dose is given at night, but there is always a risk of nighttime hypoglycemia. Very, very few patients are still on conventional insulin regime, which was used prior to the DCCT, where 2 injections a day were given, each being a mix of regular and NPH. This we use only for those patients who just cannot and will not take an afternoon injection, and there is resource constraint. Coming to medical nutritional therapy, there are two arms. One is healthy eating and the other is matching insulin with food. So point number one, healthy eating. Healthy in the sense the quantity should be correct. So how do you judge that? By monitoring the weight gain. If the weight gain is good, the child is eating the right amount and the quality should be good. In our scenario, the problem is with the glycemic index of the food. So they need advice how to improve the glycemic index, how to improve and increase the protein content of the food, lower the salt content, have healthy fats in the right amount, and maintain adequate fiber content. No junk food should be kept in the house. Sweeteners and diabetic foods have no role. And because this is healthy eating, the entire family should eat the same meals. Not keeping junk food in the house is very important because having it there and telling the child not to eat it never works. Only children who are obese, hypertensive, have microalbuminuria or celiac disease may need a special diet. And when it comes to matching insulin with carbs, which is very, very important, either we use carb exchanges or we use carb counting, depending on the patient's ability to learn and depending on the insulin regime. So in carb exchanges, the patient is taught to exchange within the same group in the stated amount after being given a sample diet based on their preference, and the carb type and content of a given meal from day to day is fixed. So this gives limited flexibility. But at the same time, monotony is avoided by using exchange system. And in carb counting, I think everybody knows this, the patient learns the carb content of commonly consumed foods, right? And can eat whatever healthy item he likes at any time by just knowing the carb content of what he's eating and knowing his insulin carb ratio, thus giving considerable flexibility. Coming to therapeutic monitoring, this is at home very important for the patient to do so that the insulin dose can be fine-tuned. We normally start with 0.7 to 1 unit per kg per day. We give a higher dose after recovery from TKA, a higher dose during puberty, and we warn the patient that the dose would go down considerably in the honeymoon phase. The bolus to basal ratio is 50 or 70 to 50 or 30. And this depends on whether you're using the analogs or whether you're using human insulin. And fine-tuning is done by doing SMBG, and many patients do CGM now, fortunately. So in SMBG, it has to be done at least 6 to 10 times a day. Unfortunately, many people do it, but they don't do the rest of it. That is recording, analyzing, and acting on the results, and which is why we ask them to stay in constant touch with us. The basal insulin controls the overnight blood glucose and the pre-meal blood glucose, and the bolus insulin, if it is the analog, controls the 2 to 3 hours post-meal blood glucose, while regular, if you use regular insulin, also contributes to control of the next pre-meal blood glucose. The target given to the patients is the simplified target of 70 to 180 at any time, or more specifically, 70 or 80 to 130 or 140 pre-meal and 100 to 180 post-meal. And those adjustments are based on blood glucose pattern when the child is eating a fixed carb meal plan. CGM, we have 3 varieties available here. The implantable sensor available abroad is not yet available here, right? And many patients are using CGM. The professional variant is also useful as an educational tool, or especially in children where we don't know what's happening overnight, what's happening in school, because many a times hypoglycemia, hyperglycemia would be totally asymptomatic. So it is pretty useful even for those patients who do not use the real-time or the intermittently scanned CGM. For those who use these, of course, it's much better and they can have better control. There are studies which have shown that using the CGM right at the onset of diabetes leads to much better long-term control. Coming to clinic monitoring, patients must attend the clinic every 3 months, and at every visit, we review the symptoms. Most of the times they are asymptomatic, but then checking the SMBG records would help. The injection technique, blood sugar technique is checked, We revise the hypo and sick day guidelines with them. Very important, we chart the growth, which gives a lot of information, not only about the control, but even about onset of celiac, thyroid disorder, etc. The BP, we look for a goiter, liver, and lipohypertrophy. Extremely important because lipohypertrophy commonly develops in children as children resist injections and therefore parents do not do systematic site rotation. HbA1c once in 3 months, annually after 2 to 5 years of diabetes, and when the child is above 11 years, we check the urine for microalbumin, eye for dilated fundus examination for diabetic retinopathy, and a comprehensive foot examination. So annually, we look for evidence of early microvascular complications at a stage where they are reversible. Once in 2 years or when symptomatic, we do thyroid function tests. More often if the patient has antibodies positive and a celiac screen. Every 3 years, if lipids are normal, we repeat the serum lipids after 11 years of age. And if there are symptoms that are suggestive of other comorbidities, we may look for adrenal, gastric, parietal antibodies and for autoimmune hepatitis. Most important, meeting the mental health team. If there is a suggestion that the patient is finding it hard to manage diabetes, worries a lot about various aspects of diabetes, worries a lot about the future, their own future or the long-term complications, doesn't sleep well regularly at night, generally feels unwell, there are frequent conflicts in the family over diabetes, the child or adolescent is embarrassed about having diabetes, cannot reveal to others, they feel hopeless, they feel like a failure, they feel life is worthless, no interest in things, cannot concentrate, or they are overeating or gaining a lot of weight, or there is frequent school absenteeism, or they have been hospitalized more than once for DKA, they must meet the mental health team. And there are a lot of good questionnaires available to look for depression, to look for eating disorders, anxiety, the quality of life in children with diabetes and in their parents. Lastly, a visit to the diabetes clinic or even management of childhood diabetes is not just about meeting a doctor. It's about the nutritionist, it's about the mental health team, it's about the educator, it's about the social worker. Very, very important. It's about meeting seniors who have been successful and who can act as excellent role models and guides. And of course, most important, for supplies for patients who cannot afford. Thank you.
Thank you, Dr. Irani sir, for an excellent talk. And you have highlighted several points, but specifically talking about the importance of the basal bolus regimen as compared to the premixed insulin, which should not be used in type 1 diabetes children. And also you have highlighted the importance of mental health, because that is a very common problem in, especially in adolescents, diabetes distress due to type 1 diabetes. And it definitely is also associated with high HbA1c. So often overlooked by the treating doctors. So I think it's very essential that we address this point, which can be very useful in the long run to reduce their complications. So I would request if there are any questions from the audience, we'll be happy to, our esteemed speakers will be happy to answer them.
So I have a question to Dr. Nimri. How efficient is the CDSS on those exceptional days in the management of type 1, maybe for the sick day management or on a fasting day? So how efficient is the CDSS in giving recommendations on an exceptional day?
This is a really good question, because decision support system most of the time does not have all the data, all the comprehensive data. And when looking on the data, we as physicians or a healthcare provider looking at 2 weeks of data. A system looked on this data and doesn't exactly know which are exceptional days. But when the decision support system analyzes the data, it looks for days that are exceptionals and give them less value than other days. And for that, this decision support system is for the healthcare provider that knows when there is. And I think that in the future, and we're working on it, that will have, like in other platforms, days that we can do this is exceptional, don't take it into account. And I think this would be in the future.
Okay, thank you. Thank you. Yes.
There's a question from Dr. Pradeep Joshi to Dr. S.P. Renu. So that which rapid-acting analog is best for insulin pump?
You can use Aspad or you can use Fiasp or any of the other equivalents. I'm not sure if there is any data to show that one rapid-acting analog is superior to the other rapid-acting analog.
Yes. So, Jess, are you there? So it's a usual question. So what are the challenges that you faced while you initiated the DIY looping? So what were the common challenges? So do you have any tips to give the newcomers?
I think the biggest, difficulty in setting it up is understanding that initial coding aspect of how to create your app. And there are different complexities with different systems. I can only speak personally with Loop because that's the one I use. I know Android APS is a little bit more
easier.
Advanced. Yeah. I think Loop would actually be the easiest out of all three. But I think the biggest thing is that initially it gets a little overwhelming because there's a lot of code line. It's all raw data code. So it seems a little bit too much, but I just want to let everyone know it's not that hard. It seems hard, but it's not hard. So getting over that first bit of setting up your app, then just out of experience, setting in it becomes like a trial error process at the end. But I would say the biggest difficulty is creating your app and coding it in. So once you cross that, then it's a breeze.
So what's the average time like for a newcomer to set the DIY looping to set it going? So
right. If you're sitting at the laptop, you've got everything done. You've downloaded your Xcode, you've got your licenses, if once all of that is done, I would say give it about 3 or 4 hours to sit and make it.
Okay. And do you recommend it to the smaller ones? Or do you recommend it to the adolescents or the adults, or rather can we do it in the pediatric age group as well?
A lot of pediatric patients are also now starting to loop, and we are seeing that data coming in. And I think it's really improving their quality of life because also it takes away the management from their hands completely. So I would say that, of course, like the pumps age group needs to be maintained. Like if Omnipod, it's 2 years and above. And for the Medtronic, they don't allow it for younger kids. But once you have the pump on the child, whatever age that may be, I'd say immediately if you get into looping, I would say there's nothing better than that.
Thank you. Nice piece of advice.
Second, I have a very basic, simple question that suppose if some patient goes to looping and uses it for several months, but then he feels that he wants to undo and go back to his original pump. So is it possible?
Absolutely, it is. It is very much possible. You just need to remove that, that there's one element of code. You reverse that and you can go back to your normal settings.
There's a question for Dr. Mimri. It's again a basic question that if a patient uses Endo digital app, then how much time it takes, for example, in the clinical decision making? Suppose he feeds the insulin dose, so how much time will it take for the patient? If it is too much time consuming, then it will be a factor of inertia for the patient to use it.
Thank you for the question. The decision support system that we have, the Endo Digital, there is a website that you enter. It's for healthcare providers. So it is for us. We enter the website, sign in, and that's it. And the patient, what needs to do is to upload the data. But we also know that today we have some devices that are cloud-based, and like the Omnipod pump and so on, that the data is uploaded automatically to the cloud. So most of the patient doesn't need to do anything, but if they don't, their data is not in the cloud, they need to upload the data, and the system pulls the data and analyze it like I showed you in a split of a second. So it takes time to upload an app, to download the app. It doesn't take a lot of time, and that's it. But for people that use MDI, they need to, for now, to record their insulin dosing in order for the system to see the insulin, because for now we don't have still the connected pens, and I hope that in the future we'll have also connected pens to the cloud.
Okay, thank you. And one question for Dr. Iran, sir. What is your experience of using degludec in young children with type 1 diabetes, or are you using it commonly?
No, as I mentioned in the talk, the most common insulin that I use for basal in children is insulin glargine. And in most of the children, it appears to work for 24 hours, and therefore I have adhered to that. I have used degludec in some children with type 1 diabetes, as I mentioned, when I found that the insulin glargine was not covering 24 hours. That means that when they took it in the night, by evening, the sugar started rising. And
sir, how often do you
there's also the cost factor involved, you see.
Yes.
Yes.
Yes, ma'am.
Yeah, I wanted just to say something. We are in Schneider using only tregludec in children. Also in the small ones, because we saw that glargine has in the first 5 hours is strong and may cause hypoglycemia in small children, especially when it's given at night. This is our experience. So for everybody, we almost don't use glargine. We use tregludec, and it is for 24 hours, and it's almost steady and need less insulin than for glargine. Just my comment. So.
Thank you.
Yes. So how often do you give glargine twice daily? So in how many percentage of your patients do you require to be given? You give the glargine twice daily. Do you have any patients?
No. So what I said is that if a patient needs glargine twice daily, then we switch them to degludec.
Okay. Got it.
And I do accept that giving degludec would make more sense in children, more because it works for over 24 hours. And therefore, if there is even some variation in the time at which you give it, it would not make much of a difference. But here, again, the problem is the cost factor. Yes. Here, for every decision we take, we have to consider the cost.
Thank you.
Sir, we listened to you mentioning about children not being allowed to take injections pre-lunch. So what in your experience, what are the suggestions that you give to the parents to make them inject before lunch? So should we take some measures? Because in our center, we make it compulsory that children inject insulin before their lunch. We even write to the school authorities saying this. So what are, in your experience, what are the measures?
So we also insist that the pre-lunch injection should be taken. And as you said, many a times we have to write to the school authorities, especially in those schools where they don't have a nurse. In fact, very recently I had this experience where the school refused to allow the child to take the insulin injection. So I wrote to the school authorities that the child will take his own injection. The school will not be held responsible. All we want is that one of the staff members should be there to make sure the child takes the insulin. You see, but even there, the school raised an objection.
Yeah.
So now we are trying other means to get the school to accept. Now, in such cases, as I said, rarely we may have to use NPH insulin in the home before the child goes to school, as I showed, to cover the meal. But as far as possible, we try to avoid such a situation.
Thank you.
And the other thing is, of course, the interval is very short. You see, like a child has a lunch break, which is just 30 minutes. So then that is why I said I prefer fiasp, so that the child can inject and eat.
Yeah, take the lane straight away. Yeah.
That's right.
Thank you, sir.
Well, I think we are done with the questions. Any more questions we have?
I guess we have one question in chat boxes for Epidra in insulin pump.
I think.
Dr. Pradeep Joshi.
Yeah. Can we use epidraine pump? That has been, I think, answered very well by sir. Sir, if any more light you would like to throw on that?
No, that's fine.
We have actually used epidraine a couple of patients on insulin pump, but what we have observed is that there are more of occlusion. The occlusion rates are high when we use lulzin, that is epidra, in insulin pump. So we discourage our patients nowadays.
Fine. I think we are done with the session. So thank you so much, all the dignitaries, Dr. Nimbi ma'am, Ms. Jaz Sethi, Dr. Aspi Irani sir. The session was quite good, very informational. And I would also like to thank the chairpersons, Dr. Sanket Pendse sir and Ms. Gopika Krishnan ma'am. So let's move on to the next session. And I would like to introduce the next chairpersons, Dr. Dhruvi Hasnani and Dr. Rutul Goklani. Dr. Dhruvi Hasnani ma'am is a consultant diabetologist at Rudraksh Institute of Medical Sciences, and Dr. Rutul Goklani sir is a consultant diabetologist at Ahmedabad. So over to you, both the chairpersons.
Thank you. Good morning. You're having an exciting second day of Ispad, Best of Ispad 2022. Rutul, would you like to go ahead and introduce
You please go ahead. Go ahead.
All right, okay. So our very first speaker of this session is Dr. Sujoy Ghosh sir, who is an endocrinologist from the state of West Bengal and city of Kolkata. He is one person who has introduced some guidelines and a program for juvenile NCDs for the state of West Bengal, and that is an example for a lot of us to do the similar kind of work for our patients with type 1 diabetes. So, without much ado, let's hear from Dr. Sujoy Ghosh on type 1 diabetes and celiac disease.
Hello, friends. I'm going to talk to you about type 1 diabetes and celiac disease. Now, that's going to be the flow of my presentation. I'm going to talk a little bit about the introduction, the definition of the disease, the epidemiology, the genetic basis, the possible environmental factors in the pathophysiology, the emerging role of gut microbiome and the pathophysiology of celiac disease, the possible clinical features, how to diagnose, the complications, treatment, and take-home messages. So it was in the 1960s that it was first understood that celiac disease and type 1 diabetes both seem to go hand in hand. Both are immune-mediated disorders, and they share certain susceptibility factors, including HLA. And now we are realizing that gut microbiome and infectious agent possibly modulate immunity to increase the risk of both type 1 diabetes as well as celiac disease. Now, type 1 diabetes, as we know, is characterized by antibody-mediated destruction of the beta cells of the pancreatic islets. Celiac is a polygenic systemic immune-mediated enteropathy triggered by dietary gluten and is characterized by the presence of specific serum antibody response. Celiac is the commonest, or one of the commonest, apart from, say, hypothyroidism, autoimmune disease occurring in type 1 children and adults. It is estimated that about 8% of type 1 diabetes individuals actually have celiac disease. Now, if you compare that with 1% in the general population, it's 8 times commoner in patients with type 1 diabetes. Of course, there's regional variations. The lowest incidence is from Finland and the highest is from Algeria. Even in India, if you look at eastern part of India, where I come from, celiac is rather uncommon. We get about 2%, 3% at the most. Whereas if you look at Western India and Northern India, celiac is very, very common. And high frequency has been reported from areas consuming wheat or barley as staple crops. So that could be the reason why that happens in India as well, because Eastern India is predominantly consuming rice and not wheat or barley. Now, this is some of the data published from India, including the data by Dr. Bhadada's group, which suggests that there is very high prevalence of celiac disease. We have published our own data, which I'm not sharing here, where we have less than 2% celiac disease. Now, if you look at the
prevalence rate of coexistent type 1 diabetes and celiac disease in different countries and regions, you can see that there is gross variability across nations in the world. Now, both type 1 diabetes and celiac are thought to be polygenic disorders with more than 30 identified loci, and celiac is seen even in first-degree relatives, and a concordance rate of almost 70 to 80% is found in monozygotic twins, highlighting the importance of genetics in celiac disease. HLA-2 association has also been found to have role in causation of both type 1 and celiac. Out of the 8 celiac loci, 6 showed association with type 1 diabetes as well. And out of 17 loci described in type 1 diabetes, 8 shows association with celiac disease. So there's a gross overlap in the loci. And if you look at the loci and the genes that we are looking at, there's a gross coexistence of these genetic susceptibility of type 1 diabetes and celiac disease in a significant group of individuals. There's overlapping environmental risk factors. It is postulated that type 1 diabetes happens more commonly in infants who are formula fed compared to breastfed individual. And there's often a history of particularly childhood exposure to viral infections. Similar postulations are there for celiac disease as well. Early or late introduction of cereal is associated with autoimmune seropositivity. Breastfeeding may be protective for both. In terms of gut microbiome, there has been abundance of the phylum Bacteroides in patients with type 1 diabetes. Patients with active celiac have more abundant population of Proteobacteria, Enterobacteria, and Staphylococci, with fewer Firmicutes and Streptococci. Enteric microbes might actually modulate host immunity through altering the balance between the Th1 and Th17 cells. The gut microbiome may influence autoimmune diabetes through effect on the innate immunity system, specifically the adaptor molecule MYD88. There have been several hypotheses for both type 1 diabetes, which also hold good for celiac. That is the hygiene hypothesis, the fertile field hypothesis, the old fields hypothesis, and the perfect storm hypothesis. It seems that both groups have both of these as postulated hypothesis for mechanism of having a coexistence of celiac with type 1 diabetes. Pathophysiologically, we know in type 1 diabetes and celiac, there is selective destruction of beta cell and enterocytes respectively. Infectious agents like adenovirus, hepatitis C, rotavirus has also been implicated for celiac apart from the commonly implicated culprit, that is gluten. Similarly, enterovirus and herpes virus are also known for type 1 diabetes. We've already talked about gut microflora. Isolation of pathogenic strains from duodenal mucosa of celiac has also been done. And this is a summary of the various postulated mechanisms that I've already talked about in the pathway of commonality of destruction of both beta cell as well as the enterocytes. So in terms of clinical presentation, in the setting of type 1 diabetes, many patients often do not necessarily have the classic signs and symptoms of celiac. Many might actually be asymptomatic for celiac. Individuals with subclinical disease known as silent celiac are seropositive patients with no gastrointestinal or extraintestinal manifestation. This implies that type 1 patients may harbor florid celiac disease, which might be silent or potential celiac. And the signs and symptoms might appear at any age, and the courses of celiac and type 1 do not necessarily run a parallel course. In terms of the clinical features, if you look at the age of onset, an Australian study suggests that those with celiac in type 1 tend to have an earlier age of onset compared to older patients who have type 1 who often don't have celiac. And about 50% of type 1 patients diagnosed with celiac in adulthood had celiac disease-related complaints for about 5 years before the diagnosis. People hadn't picked them up. And there seems to be a bimodal distribution of celiac at ages 10 and again at age about 45. And it's more common in women and girls rather than men. And less than 10% of patients with type 1 diabetes and celiac disease actually have gastrointestinal symptoms. So if you look at the symptoms of type 1 and celiac on both sides, If you're looking at celiac, patient might have abdominal discomfort, bloating, weight loss, most commonly and predominantly growth failure, fatigue, infertility, hypogonadism, aphthous stomatitis, compensatory hyperthyroidism, dental hypoplasia, fractures due to bad bones, and anemia. So if you have a child with type 1 diabetes who's having growth failure and delayed puberty in spite of reasonable glycemic control, the first differential diagnosis that one should think of is celiac. And a majority of type 1 diabetes usually precedes celiac, and then there might be risk of celiac is highest in those who had the diagnosis before age 4 years. Celiac diagnosis is usually screen detected at a median age of 8 years. Therefore, screening for type is essential, particularly in those who are having growth failure despite optimum glycemic control. When you're talking about screening, most guidelines suggest that screening with anti-TTG, IgA, and also confirmed by the endomysial antibody or IgG in patients with IgA deficiency, because that is possibly the best way of diagnosing with high sensitivity and specificity. IgA deficiency happens in 1 in 500. Other guidelines recommend retesting at intervals with no firm evidence, but usually it's stated that you should recheck every 2 to 3 years. The Ispad recommends screening for celiac disease at diagnosis of type 1 diabetes and every 5 years thereafter, and less frequently in successive 5 years. So if you look at looking at the serology, the commonest test that we are doing is the tissue transglutaminase IgA, and that's recommended test for screening. And if you look at the deaminated gliadin peptide and also the endomysial antibody is what we are doing more commonly. Anti-gliadin IgA and anti-gliadin IgG is often not done in routine clinical practice. If you're looking to confirm the diagnosis of celiac disease in the presence of an elevated antibody level, a small biopsy is needed to confirm the diagnosis. And usually multiple samples are taken, at least 5, because there's often patchy involvement of the gut. We'll talk about the Marsh classification a little later. For clearly symptomatic patients with high TTG titers, celiac can be diagnosed without duodenal biopsy, particularly if the EMEA IgA level is positive and the patient is HLA-DQ2 and DQ8 haplotype positive. Now, this is what the modified Marsh classification looks at. It looks at intraepithelial lymphocytes per 100 enterocytes, looks at the crypts and the villi of the biopsy sample of the duodenum. And this is how it is classified into type 0, 1, 2, 3, A, B, and C, progressively more severe disease, as you can see in this particular slide. In the top row that you can see, there's gradually more and more progressive disease with villus atrophy. Now, what happens if a child has celiac disease in type 1 diabetes? So there's more likely to be erratic glycemic control because of the GI problems. Type 1 diabetes with celiac have an increased propensity of hypoglycemia, interfering with carbohydrate absorption, and there might be significantly lower insulin requirement among children with type 1 and celiac than with type 1 alone. Type 1 with celiac are at a greater risk of nephropathy and retinopathy, particularly with increased duration of celiac disease. Celiacs are an increased risk of autoimmune disease such as autoimmune thyroid disorder. Treatment of celiac in type 1 is same as you would do in other isolated individuals with celiac disease. Strict gluten-free diet should be initiated for those people with serology or histological evidence of celiac. And you've got to get rid of wheat, rye, and barley in the diet. Dietitian's consultation is essential. Vitamins to be supplemented because there's certain vitamins in gluten-free diet, there's lack of it, and because of the GI problem. Dietitians do have a tough time because, the moment you take out the gluten-containing stuff in your diet, you tend to replace it with other food stuff, and which often have high glycemic index. So you've got to figure out a way of replacing the gluten-free diet with other food stuff which do not have high glycemic index. Dietary management is complicated when both of them coexist. Dose of exogenous insulin is to be adjusted. Hypoglycemia alert is mandatory. In terms of treatment outcome, most people will improve well in 2 to 4 weeks after being off gluten. A portion of patients with persistent symptoms are called non-responsive celiac disease and should be referred on to higher centers. Complete elimination of gluten from the diet can lead to clinical, serological, and even histological remission in most cases. Serology should be rechecked after 3 to 4 months and thereafter yearly when symptoms have disappeared. So if I have to summarize in terms of the take-home message, celiac disease can coexist with type 1 diabetes and is often asymptomatic. It should be particularly ruled out in children with growth failure in type 1 diabetes. Ispad guideline talks about screening for it at diagnosis in every 5 years. And if symptoms are there, erratic glycemic control might be a possibility. Growth failure might be a possibility. Gluten-free diet often normalizes the clinical, serological, and histopathological features. I shall stop there and thank you for your patient hearing.
So, thank you very much, Dr. Sujoy. Though it was a recorded version of his lecture, now we'll move forward to the next lecture, and this is immunotherapy in type 1 diabetes. And for that, we have Dr. Green from UK. We have recorded lecture of him as well.
So Ria is searching for the recorded lecture. Till then, we can have the sir.
Discussion.
Yes,
okay.
sir.
Okay. So, as Dr. Sujoy Ghosh was sharing his data that it's around 2% of celiac disease in his region, and which was very much different from Dr. Badada's data. So what do you say, Dr. Dhruvi? What is your experience in our region, Western region, as we have seen very less cases as Dr. Sujoy was sharing?
So, Dr. Rutul, if you remember, I think it was your and our paper together in the IDF. I think in 2016, we presented that we have very less celiac disease in our region, and the prevalence was somewhere between 0.2 to 1%. And it was.
So it's quite less than even Dr. Sujoy Ghosh.
Yeah, that's really less. And are we not screening our patients? We do not know, but I think it's a routine practice that our pediatricians as well as diabetologists are screening once in 3 years for for celiac disease in our people with type 1 diabetes. So that's that. What's your
as the symptoms are not absolute in celiac disease, what we are finding that abdominal discomfort and nausea, vomiting, sometimes abdominal fullness, these all are the symptoms are very common at this age. And this is why that could be missed, as most of the patient, they directly go to pediatrician and they don't come to us, as we are not pediatric endocrinologists. So this is the very common thing. And we have Dr. Sujoy Ghosh here. Sir, so we were discussing that in your lecture, you showed that your data is saying that it's around 2% of prevalence of celiac disease. And Dr. Dhruvi was telling that in our paper, it was even less. It was around 0.2 to 1%. So yes, prevalence is very less, or is it so that we don't check it frequently?
Right. So essentially, if you look at our cohort, we actually went and tested everyone. So there was no selection bias in terms of, testing versus not testing, because it was done as part of a research project. The challenge is we used only anti-PTG antibodies. And I showed you there are so many other antibodies which could possibly be positive. That's number one. And number two, historically, if you look at celiacs, eastern part of India seems to have lower incidence of celiacs due to reasons not known. Probably because wheat is not consumed that much in eastern India. It's more of rice. So it could well be that unless and until you're giving the antigenic trigger, you don't get celiacs that commonly in this part of the country. Having said that, I think we had a discussion with Dr. Bansi and with one of the experts from Singapore that we'll probably do a study in other parts of India as well as the eastern part, where we look at all 5 antibodies. That might actually give us a better clue whether it is actually lower or whether it's because we are testing only one antibody.
Great.
I have a question.
Yes,
which sets of patient we should suspect this patient is suffering from celiac disease?
Right. So first of all, if you look at what the guidelines state, technically we are supposed to screen everyone for celiacs, particularly the ones who are developing type 1 diabetes very early on, because they are the ones who are having a stronger autoimmune background. That's number one. Number two, a child who, in spite of relative good glycemic control, is not growing properly. If you find that the linear growth is stunted, then think of celiacs as one of the possibilities. When you find that you have unexplained hypoglycemia in a type 1, suspect that there is celiacs. And of course, if you have florid GI symptoms, of course, you will suspect celiacs.
Thank you so much. Okay, sir.
We are ready with a recording of Dr. Green. So, Sujoy sir, one last question from my side. Inversely, at our institute, we have one girl. She's Dr. Vipul's patient. She has celiac disease, but she's not type 1. And, what are the chances that, it could be the other way around, that for kids with celiac disease, we should screen them for type 1 as well?
Right. So if you look at the genes in the talk that I was trying to talk about, is you have some sets of genes which are common to both. In most of the circumstances, the type 1 diabetes will precede the celiacs. But there will be a subset of people who will develop type 1 after the development of celiacs. Now, because they share the same genetic background, now it's very difficult for me to at least make a comment that, how many of our non-diabetic celiacs will go on to develop celiacs. So just at least in the part of the education, if we educate them and say, if you have symptoms which might be suggestive of type 1 diabetes, because, unlike type 2, if somebody has type 1, it's going to become symptomatic. It's not going to remain undiagnosed. So just awareness of those symptoms is good enough.
Thank you so much, sir. Thank you.
So your hypothesis, one last comment, your hypothesis was what about that you are rice eater in eastern part of area, but in western part of India, we are like wheat eaters, heavy wheat eaters, but we have the similar kind of condition. So this is the point of research, that what could be the reason.
Definitely.
Yeah. Great. So we can move forward to the next session of immunotherapy in type 1 diabetes. May I have the introduction slide?
Sir, that UK sir was supposed to join live, but he is not currently available. He just informed us. Can we move to the next session after the discussion of this?
Okay, so we have next speaker, Dr. Vasant Kumar, and for that we have chairpersons Dr. Archana Sada ma'am and Dr. G.D. Ramchandani. Do we have both the chairpersons and Vasant Kumar sir?
Vasant sir is here, but Archana ma'am.
I'm here, Dhruvi.
Yes,
so we can. I guess we can start the session. I guess. Yeah.
That's okay. Can you ask them to allow my slides to be shared?
Yes, you can share your slides, sir.
Rutul, could you please just introduce sir before he starts sharing his slides?
Yeah. So Dr. Vasant Kumar, sir, is a senior consultant and physician at Apollo Hospital, Hyderabad. He is immediate past president of RSSDI and founder and president Diabetes and You Society, that is DAY Society, supporting kids with type 1 diabetes. He is actively involved in with RSSDI for last 15 years. He has organized 2 national conferences of RSSDI in Hyderabad. He was a scientific chairman of RSSDI 2021 held at Ahmedabad, conducted several diabetes awareness and diabetes educational programs, contributed to many articles in national journals, and he has delivered many guest lectures and orations in national meetings of RSSDI and API. So over to you, sir, for your lectures.
Thank you for that rather long introduction, and Thank you so much. I'm trying to share my slides. Yeah. Just a minute. Are you able to see my slides on the screen?
Yes, sir. You'll just have to put it into the slideshow mode.
Yeah. I've done it.
Okay. Perfect.
So thank you, Dhruvi. Thank you, Rutul. So it has been a good experience to listen to many learned speakers on and off. I actually just finished one camp for type 1 diabetics and caught up with 1 or 2 topics. And this is going to be very brief. Dr. Bansi was asking me to speak on some of the RSSDI's initiatives. So I'm not trying to repeat because we have extensively spoken about type 1 diabetes and various aspects of it. And this is just a slide for us to understand again that, diabetes in young can be type 1 or it can be even type 2 or it can be even other varieties. Sometimes it's not so easy to differentiate. So this is an important thing that we should understand. And this is the most common pediatric endocrine disorder, as we all know. And this is about ICMR registry, which has told us it's very prevalent. And almost 64% of the young diabetics are type 1. That's the inference given. So we have many challenges. I have been listening to many of the very learned speakers, Dr. Rishi and others, and Dr. Sharda, many of you, in fact. So it's quite a challenge to manage type 1 diabetic people, especially those who are economically poor, those who are rural based, and many of the parents could be, less literate. And many times the parents are involved taking care of the other children, doing so many things. And somebody was mentioning about the afternoon dose, which is always a challenge for us. And some of the children in the government school do not have even toilets. So it's a problem for the girls. So we have been looking at all these and some of the things that probably mentioned, but I still thought it's worth repeating that many of our, especially poor children, eat a lot of carbohydrate diet, whatever you say. It's the white rice more prevalent in South. They keep eating it. The government supplies them. So the problem is many of these children, although they are low weight, they require high dose of insulin. And as many of the earlier speakers said, we skip the afternoon doses and children do skip the doses during the travel functions. So many things happen. And also they get into a lot of hypoglycemic attacks very often because they may not be eating in time or they have seasonal fevers, other conditions, and the insulin is continued. And this is what I was mentioning about. And we also know that we have the highest number. And the problem is 50% of them cannot afford the treatment because of the poverty. And coupled with the poverty, they are in the rural areas. No access to especially care. So I always put this slide to say that who should treat type 1 diabetics children in India? Is it pediatric endocrinologist, pediatrician, physician, finally general practitioner? So I think even we have to train our general practicing doctors and of course all diabetologists and all that people in the above group who can reasonably manage type 1 diabetes. I'm not exaggerating when I say this because at least they are able to provide certain minimal care to our children, especially those rural based, especially those who belong to a lower socioeconomic strata. And as you know, RSSDI has been doing extensive work in various areas, whether it's in the public awareness programs, in type 2 diabetes, gestational diabetes, diabetes in children. And recently, thanks to my colleague, Dr. Bansi Sabu, and many of you are here, we have also started working on doing projects for type 1 children with the help of some of the corporates and with the help of our members. We have even made some modules which will be useful to our members, modules for diabetes educators, modules for diabetologists, modules for even diabetes caregivers. These are the ones which have recently been formed and they're available on the website so that, we want to spread the knowledge about type 1 diabetes and equip them with more information so that somewhere across the management improves, if not perfect.
So these are some of the modules that we have already rolled out. There are doctor modules, there are patient giver modules, educator modules, which I mentioned to you. We need to make them more popular. We need to see that it reaches out to the people. And these are some of the things that we have already done. Training the pediatricians is also important. Because basically the children go to the pediatricians. Also, GPs cannot be ignored because in the rural area, they are the practitioners who are available to either the child or adult. So we need to make them a little more confident to initiate, at least look at the problems. Probably, many of the children present themselves right at stage of DKA. So they need to do something before shifting the child to some other place. So we cannot ignore anybody, any medical practitioner when it comes to managing type 1 diabetes. So that's exactly what we are looking at training, not only the doctors, also diabetes educators. And we have prepared many modules and it's going to take up more things. And that was one of the reasons that I also tried to make it very short and also see what best we can do. And in fact, we are in the process of evolution. We need to do much more. And programs like this, Ispad programs where we could not attend the main Ispad, it becomes important. So what is the happy thing about it is now that more and more people are aware of type 1 diabetes. And we have yesterday seen Shilpa Joshi and others, many of you. We are trying to sensitize the government, NGOs, professional organizations like RSDA. All of us need to work together. I particularly made it very short so that we can have some discussion, or also I did not want to repeat what all has been said, Dhruvi. So I thought I'll just take only 10 minutes and I'm done with it. Thank you for giving me this chance.
Thank you so much, Vasant sir. Under your leadership, I think these are all wonderful initiatives. All of us are with you. We do need more education, and that is the emphasis of the initiative that you just showed us. Do we have any questions from the audience right now?
I guess we can take questions later as Dr. Stephen Green has joined. So we can take questions together.
Okay, thank you.
Okay. Thank you, Vasant sir. Thank you so much.
Please go ahead.
We have Dr. Stephen Green with us, who is the consultant diabetologist for children, adolescents, and young adults at London Medical College, UK. He is the president of the International Society. He was the Ispad president from 2012 to 2016. And he's also the director for Scottish Children's Research Network, Research of Children's Health, Queensland. So over to Dr. Stephen Green.
Okay, thank you very, very much. Apologies for joining a little bit late. But it's 6:30 in the morning here, and took me a little while to get myself set up. So delighted to be with you. My understanding that this was really to promote some discussion about some of the issues that came out of the Abu Dhabi Ispad conference recently, which we were very pleased to go to. It was great that it was hosted as a face-to-face meeting, and the people who went, I think, gained the sort of things that they normally gain from Ispad in the past, of networking with people, meeting people, and it was a well organized meeting and a lovely atmosphere. So that was a tremendous thing for the diabetologists to come together. Lots of topics, enormous number of topics, and spread across the whole breadth of the diabetes spectrum. I think I was asked to actually speak a little bit on immunotherapy. Is that correct? Is that what you're wanting to speak about? Now,
yes.
This is where I technically fail. I want to share my background. Is that right? So just hold on for a second and I'll have a go. Screen. Here we go. Okay. Right. Am I sharing my screen? How do I do that? Sorry, that's gone wrong.
Dr. Green, you could just open the window wherein you have your presentation slides. You're already sharing your screen. Just open your presentation.
Right, hold on.
Yes.
How's that?
Yes, that's really good. Now you'll have to put it into the slideshow mode.
Say again? Oh, yeah, they're from the side. Yes, I understand. Yeah. But can you see all that now? And you can see
Yes,
me?
I can see your screen. So
okay. I'm doing this on my iPad, which I've normally not done before, which let me get the slideshow. There we go. Right. Okay. From the start. Right. How's that?
Wonderful. It's just that I can see myself as well on the screen. So yes, if you could just put it into the corner, we'll be able to see your slides.
How's that?
You
need me. How do I get you on? How do I get me up there? I don't know how to do that.
The previous time. If you press Alt Tab, oh, you're from your iPad, right?
Yeah.
You'll have to go back to opening your.
Try this again. Let me start broadcast. Right. No, you can't seem to get me. Can we do it just on voice alone? If you...
Yes, we can see that.
Yeah. Is that okay if we do it just with voice?
We can see your slides now.
Yeah. Okay. All right. So
yes,
just to say, as I said, I'm not an immunologist. I'm coming from this from a practical point of view of a clinician. And the interesting about immunotherapy or biological therapy is that it's the treatment of disease by activating or suppressing the immune system. And I think the first thing I'd like to say is that one of the big themes that I took from this meeting, the Ispad meeting, is that in this area, it may well be other forms of treatment and suppression that we should be thinking about. In other words, we're all focusing on suppression of the immune system, but there may well be other areas in the quite immediate future which you'll be thinking about, and I will explain that as we go along. The other thing I took about was a revisitation in the meeting of perhaps a more simpler view of what's going on in terms of the cause of type 1 diabetes. And I'll go through this slide in a second because it's quite complicated. But it's less complicated than many of the other slides that we see around the immunology of type 1 diabetes. And I'm sure you've all seen those pictures with the various monoclonal antibody sites, or the sites in the pathway where various monoclonal antibodies can act in against the immune response. And in a sense, what was proposed at the meeting, and I felt in 2 or 3 sessions that I attended, this gained more credence, was the concept which was put forward way back in the 1980s by a Professor Franco Batazzo, is type 1 diabetes related to the murder of the beta cell or the suicide of the beta cell? And what that basically says is that is there something inherently wrong with the beta cell, which then sets up the whole process? In other words, suicide, rather than always thinking about that the beta cells are fantastically healthy and yet are being attacked from the outside by all sorts of aspects, and that is murder. And I think the concept of the beta cell suicide gained a lot of traction throughout the meeting. So what does this mean? And it raised the issue very strongly in my mind of the whole business of beta cell stress, which is number 1 in this diagram. And one thing that the Ispad meeting really opened up to my eyes, as I hadn't quite registered before, is that the beta cell in the pancreas is one of the most metabolically active cells in the body. And therefore, it, in a sense, I mean, it's hard not to think of this in mechanistic terms, but you can't really think of it in mechanistic terms. But any stress on that cell, any damage to the mechanisms within that cell, is reflected in a poor function. And so, if you get an increased metabolic demand of the beta cell, and that might be caused by all sorts of things. We don't know what that triggering event is. It may be nutrients, it may be chemicals, it may be viruses. But there obviously does seem to have been, in the last 40, 50 years, something external to the beta cell which has produced that drive, because we've seen underlying the rise in type 2 diabetes, we've seen the underlying rise in so-called type 1 diabetes. So you've got an increased metabolic demand, and that results in endoplasmic reticulum and oxidative stress. And the beta cell gets ill, gets wobbly, gets poor function. And because of that, internal chemicals start to leak out of the cell. You get chemokine released by the beta cell. That's number 2. Then number 3, that sets up the attraction of the immune cells, such as the macrophages and the T cells, and induces the autoantibody production. And then you get islet damage from those, the insulinitis, which develops, and you get the T cell interactions, the antibody release, directly through the release of the inflammatory cytokines, reactive oxygen speed, and then you get further endoplasmic and oxidative stress. And you can then see with the islet cell damage that you've got this cycle of stress, damage, response from the body, which unfortunately produces more damage, and you go into a viral a spin. At the same time, it sends off the apoptosis pathways in number 5, and you get inability to restore this homeostasis, and that's what leads to cell death. Now, I think that's a much simpler model to think about, but it's also, I think, probably the correct model. I think we've been, and this is one thing I took away from the meeting strongly, was that we've been lulled into a view that everything is driven by the antibodies, the antibodies that are produced in the diabetes are in response to the damage. They're actually the body trying to repair the situation to a degree. They're trying to stop the attack by the T cells and the macrophages. But obviously, you then get into a flat spin and you get into this cycle of death and destruction. So it's to me a much more simple model, and I favour very much from this meeting the concept that it's beta cell suicide. So move on to the next one. So this sort of picture came up several times from everybody. The disease progression of type 1, which we're all beginning to now use quite frequently. The stages. So you've got pre-stage 1, stage 1 itself, stage 2, stage 3. So in pre-stage 1, you have the presence of antibodies, and you probably have beta cell loss, but that's very difficult to measure, certainly in human subjects. And one of the messages I took from the Ispad meeting was in one of the presentations was that, and I'll come on to this in a minute, in different types of type 1 diabetes, maybe a lot of people still have quite a lot of functioning beta cell mass present. The problem is that the function is not very, very good. So there is this concept between beta cell mass and beta cell function. So when you talk about loss, is it mass or is it function? And it's difficult to work that out sometimes. You might get some so-called dysglycemia, but not really in pre-stage 1. This is all normal physiology. And then we'll come back to this, that this is a variable genetic environmental risk for type 1 diabetes. So here we are. These are the people who are going to get diabetes, but are perfectly well. They then shift into stage 1, and they have antibodies. They may have some beta cell loss, but as I say, it's difficult to work out that exact amount. They haven't got dysglycemia, so their blood glucose control is normal, and they're asymptomatic. Stage 2 then gets into the hyperglycemic phase. So these are the children, the young adult, the adolescents, the adults who have slightly raised fasting blood glucoses, have a high postprandial blood glucose, and will have an elevated glycosylated hemoglobin. They will have antibodies, and they will probably be losing beta cell mass quite regularly, and you can begin to get a feel for that with things like measurement of the C-peptide. But again, they're asymptomatic. And then at this point here, they are diagnosed as diabetes. They've obviously had developing diabetes at this point, but the clinical symptoms that we all recognize, the classical clinical symptoms, start to come in, and you've got persistent hyperglycemia. So that's the simplified version of the progression that we've got. It then gets a little bit more complicated, and I'm actually going to probably miss over this one, but go on to this stage here and really look at where, and this was a topic which was really discussed in detail about the risk benefit of immune therapy in intervention. So here we have the risk benefit in this completely normal stage, pre-1 stage. Remember, we haven't got any antibodies. You've got first degree relative risk, so this may be something that relatives are interested in. You've got varying progression, and you've got to consider that this is particularly aimed, it's not exclusive, but is aimed at young children, because if there's a gap between developing diabetes and the risk session, then it's got to be aimed at the very young. And you've got to consider whether there are any actual risk for measuring any of the biomarkers. Are they good enough? And I'll come back to this in a second. Once you get onto this phase, stage 1 and stage 2, if you like, a pre-symptomatic type 1 diabetes, This is where these two stages here are where most of the work on the immunotherapy has been done. And you've got positive antibodies, you've got progression rates, which people are beginning to understand. You've got developing dysglycemia, and you've got a desire to prevent the loss of the beta cell destruction, or re-stimulate the production of insulin, or re-stimulate the islet cell morphology. And we'll come on to this in a second in more detail. And then finally, you've got this point here where you've got the diagnosis. And again, people have tried to use various immunotherapy at that point, and various therapies at that point, but without success at the present time. So, what sort of therapies can we use? There's lots of different sorts of things. I think we're fixated on the concept of monoclonal antibodies at the present time, but there are all sorts of studies being going on in a whole variety of immunotherapy. But I would point out that this may not be the exclusive track that you should go down. In fact, I think very strongly that came out of a very good workshop discussion in the meeting is that this is not the case at all. We're going to have to look probably at combination therapy and not just of preventing the immune reaction, the secondary immune reaction, but actually trying to think about how you can reduce the beta cell stress, the metabolic and ER stress, which is developing. So there's a lot of work going to come out on that over the next few years. Just as a point on this, the example of what's gone on in the cancer world was raised, and in the sense that we could learn a lot from the way that the cancer people have developed their immune therapy programs, and the way that they've used combination therapy and other sorts of therapy to go along with direct immune therapy. So to finish with, we talked about the clinical prevention trials. And if you like, what you're trying to do is identify this person. This person's got the disease, but in this person and the blues possibly, they're going to go on to get diabetes eventually. And so there's an enormous individual variation between who is designated to get diabetes and the speed with which they then go on to get diabetes. And one of the major themes that was discussed in the meeting was the heterogeneity of type 1 diabetes and the fact that we now have a whole series of endotypes of diabetes. And I think that any clinical prevention trial has to take this on board now. So we're beginning to see that some people, the 2-year-old or 3-year-old with diabetes, is probably metabolically and immunologically very different in terms of their beta cell functioning to the 15-year-old who gets diabetes, and certainly to the 25 and 35-year-old that gets diabetes. What are we trying to achieve in these prevention trials? Well, that's also a good question. Is it that we're trying to look for complete cure? Probably that's what the patients want, obviously, but is it possible? Probably not. So what we're more interested in is looking at the rate of progression to clinical onset in prevention, and actually maintaining some of the beta cell function or beta cell mass after the therapy. So that's also, again, quite important. These are the clinical trials which have gone to stage 3, and since the Abu Dhabi meeting finished, and in fact this week, there was an acceptance from NIH in America that the teplizumab anti-CD3 monoclonal has been released for clinical use. It's been in clinical development research for the last 10 years, I think. And there was a bit of a hold on it last year after the stage 3 trial, but they looked at the evidence and they have accepted that this can be used as the first vehicle for prevention of diabetes. But I just want to say that no study has confirmed complete long-term reduction in clinical diabetes, and neither has teplemzumab. So they've only looked up to 2 years. They've not looked beyond up to 5 or 10 years, and that's going to be interesting to see what those follow-up studies are going to suggest. I'm just going to finish with one major point, which was, if you like, I think avoided at Ispad. It was like the elephant in the room, which nobody wanted to talk about. The vast majority of around the world are picking up people with diabetes at diagnosis. And the vast majority of health services in the world are not thinking about early detection of pre-diabetes. And I think there's a paradox there, because the only successful study, and teplemzumab is probably the only one at the moment, is all about pre-diabetes. And so some countries, there were very few, there was discussion from people from Sweden, people from the UK, are setting up screening programs, potentially looking at the combination of genetic analysis, genetic risk factors, together with antibody measurements, C-peptide, etc. But to give an example from the UK, we're a long, long way from doing this. And there was a very good debate on this in Ispad as to how this will be taken up by countries, how effective it will be, and how useful for then using immunotherapy. And the overall answer was that people are very skeptical about this approach at the present time. Now, it may well change as the data comes through from these countries about their pre-diabetes screening programs, using the combination of neonatal screening information together with later screening through the school system, etc. But it's a long, long, long way down the road. So for the person who gets diabetes, there is, to me, sadly, a great void at the moment of saying, well, can we actually really change the nature of the beta cell destruction at that point? And given the fact that the heterogeneity of type 1 diabetes is there, that may be a much more fruitful area to go down, using the different concepts of what therapy we might use, which is why I go back to this whole business of maybe there should be more emphasis on the morphology and the pathophysiology of the beta cell itself. So I'll leave it there. I'm delighted to ask questions. I'm sorry about my technical failure, but we'll see what we can do now. So how do I unshare? Do that, I think. Oh, let's see. Go back to that. Okay, I'm back on. Is that okay?
Yes, sir. Thank you, sir, for your insightful lecture. Now for the next symposium. Sir, Rutul sir, do we have questions?
I guess we don't have many questions, but from my side, I want to ask to Dr. Stephen Greens and if we have Dr. Vasant Kumar sir, I would like to ask him some of the question as well. So, Dr. Stephen, what is your own experience about teplizumab? Have you used or is it available in UK now?
No, it's not been. Yes, no, it's not been available. It's only been available as a research tool in the United States from the group doing that. But this week very much so. how can I say, the social media's lit up with it, including a statement from Diabetes UK, which has been keeping a very close eye on it. It now has to go through MHRA acceptance and so on and so forth. I have to say that I don't think it will come into regular clinical use in the UK because there are one or two very good groups which are coalescing together, mostly under Colin Diane in Cardiff, which is wanting to do all sorts of development under regulated process. So I think that it will be very, I'm not sure about this, but as to where the MHRA will go with this, and they may well say that it has to be done through groups like that. And I think that's the same over the whole of the world. I think that I get worried about things like this when it flies across the social media, because parents come desperate for treatment, and that's really quite difficult for everybody.
So it is quite an expensive drug. If we see if it can delay for 2 to 3 years, and that also in just 30 or 40% of the patients who are screened in early phase of type 1 diabetes, or even in non-symptomatic stage of diabetes. So I don't think it will be useful in India, as we don't screen that early. What do you say, Vasant Kumar sir, Archana ma'am, or Rakesh?
I think you raise a very, very good point. Very good point.
I think I agree with you, Dr. Rutul. It's absolutely of no use for most of the world, not only India. I was very much interested when I heard Dr. Stephen's inspiring talk. We were also thinking of BCG vaccine sometimes, whether it has some value for reducing the intensity of the disease or whatever. But we were disappointed that where we tried on about 15 of our children in our center, it was only a clinical study. It hasn't made any difference in the dosage of insulin or whatever, at whatever stage of the disease it was. That's it. I just wanted to add, Dr. Stephen, but we are still hopeful something would come in future. Right now, otherwise, we are just trying to Archana here. And as you know, in India, we have many of type 1 children who can't afford to check their blood glucose, to take the insulin. So many of us are trying our best, and people like you always help us in giving us more knowledge. And let's see how we go ahead.
Knowledge and
I think. Can I just make a comment? I think both of you raised very appropriate and elegant points, and I don't think it's just for India. I think it's for the whole world. I think you can get beguiled by the science, and the science looks wonderful. But the practical aspect of all of this is that, first of all, if you see this as a way forward in a health service, first of all, you've got to get the screening process up and running, and that in itself is not only incredibly expensive, it's incredibly laborious, and it's very manpower driven as well. So that's never mind the emotional issues that were discussed at Ispad about the screening process. It's very difficult. So that's the first thing you've got to have. And then secondly, the point you raise is that, is the intervention worth it? So in other words, if the studies over the next 10 years show that, well, actually it did quite well, but eventually they get through, I don't know, is it worth it that you convert all your diabetic patients into C-peptide positive diabetic patients? Could well be. It could well be, and it may well be interesting. That's going to take a long time to sort out. Mm-hmm. So I do think that there are potentially much more interesting things to. I'm going to speculate here, and please, this is a speculation, but it might be some places like India are interested. I had a long discussion with Bart Rope at the Ispad meeting, who presented a lot of this. And he's a fantastic character, and he's been in this area for a long time. And we discussed about the fact that pre-insulin era, one of the most effective things to do was to put people on a very restricted diet. And the Allen diet actually gave people often probably 2, 3, maybe 5 years of life. I mean, it wasn't a great diet. It wasn't a great treatment. In other words, it could well be that there is something in the dietary component that renovated the beta cell stress, reduced the beta cell stress, and reproduced both either mass or function in the beta cell. So some areas like that might be really worthwhile looking at in new people who present with diabetes. In other words, if we can hit them very hard with a combination of, I don't know, I mean, this is speculation, please don't but gluten-free diet, metformin, and maybe some anti-immune therapy, then maybe that will preserve their beta cell mass just as long as we can do with the teplizumab. We don't know. And these are the sorts of things that I think he's thinking about very strongly, and I think may well be something that countries like India may well be able to think about as well.
Thank you, Dr. Stephen, for those insights and your candid opinion.
May I just make a comment? Yes. I just wanted to say, although the science is not there for us today as a cure or a treatment, but in one way it really helps. It gives a lot of hope to the families with type 1 diabetes. When this news came out, somehow it really got spread very fast through social media, etc. And there were so many families who felt, when I told them it's not available today, this is where it is, they were still hopeful. They were very happy that there are scientists actually working on it. Can we have an early staging? Can we have an early detection? That means, and they were consoling me. These are villagers, and they're consoling me. Ma'am, don't worry. If they've reached here, they will reach there as well. We are praying for the scientists and they will make it.
So they are giving us hope.
Yes. So, every step in science also gives hope. So I just wanted to give a other perspective to this situation.
Anyway,
that's a really important point that you raise. I think actually that yes, I mean, over my years with families, I've been absolutely astounded how the vast majority are very supportive of us as well. It's you always think of the patients you've had a row with, and it's terrible, and you don't. But actually, the vast majority are fantastic, and it must be incredibly frustrating for them. Yeah, very difficult. Just as a word of warning, though, I remember. When I first went up to Scotland to work, and it was related to nicotinamide. Do you remember nicotinamide's story? And there's a newspaper in Scotland called The Scotsman, which came out, and it must have been a low news day because they plastered across the headline, the front page, type 1 diabetes to be cured because of the concept of the nicotinamide, and the journalists had got it completely wrong, and yet it caused an enormous number of phone calls and discussions in the clinic afterwards, and families were quite upset. So we have to be a little bit careful ourselves as scientists as to how we handle this information. I'm very impressed with the work that's got on with teplizumab. It's fantastic stuff they've done. But I got a feeling from the Ispad meeting that there's a rocky road along the way. It's not going to be easy. It's not going to be easy.
So I have a question for Vasant Kumar sir. As we have time for discussion, his lecture is already been taken. So sir, are there any planning for RSSDI after this teplizumab thing that we can screen early in high-risk population from any initiative from RSSDI?
Frankly, it's not going to be an easy thing at all. even if you contemplate the idea of screening people for type 1 diabetes, even the so-called high risk, it's almost impracticable to think of in a country like India. And as Archana and as Dr. Stephen himself said, none of them are, we are not even at the distant future. So right now we need to concentrate, catch them at the earliest phase of the disease and sensitize people about type 1 diabetes among the children. We need to concentrate on that more. That's what I feel. And we will see whatever comes in, we will definitely take it up. Thank you.
Great, great. Dr. Rakesh Kumar want to add something.
Yeah.
Yeah, actually, I'm actually practically facing problem on this question. Actually, we did start a study as part of a student thesis, screening siblings with type 1 diabetes for antibodies. So we planned to screen at least 400 sample size. That was our target. So we recently actually analyzed the first set of samples, 100 of them. So 3 have come out positive, 2 antibodies. So I'm actually at crossroads. How am I going to talk to the parents?
Exactly.
So
I agree with you.
It's very difficult.
Maybe it's better to watch the siblings, Dr.
Yeah,
Rakesh.
obviously. Yeah. So I will be obviously counseling them that it's good that we have picked them up and we can follow them regularly. I mean, giving those positive side of it. Yeah, Dr. Green.
Dr. Stephen wants to say something. Yes, sir.
Yeah. Sorry, can you just tell me again the numbers that you had? You had 400.
So 400 is our target. Study is still on. So 100 samples recently analyzed. 3 of them have come out positive. So these are actually siblings and even parents if they are less than 40. So that was our inclusion criteria.
Yeah, I mean that was my experience as well in Scotland, and that's why the large multinational, multi-center and multinational studies are the only way forward. I mean, you obviously have got a large number of patients in India, but you would have to do it across the whole of India to get numbers. And then you're quite right. What do you do with the positive patients? It's a tricky one. It's a tricky one. However, I just would add that most families, if they've got a child with diabetes, in my experience, most families test the other children quite regularly.
I was about to say that. Yes.
Yeah, that's right.
So they've learned to live with it quite nicely.
And since the purpose of screening is maybe to prevent ketoacidosis or early detection, I think that anyway happens with siblings because those families are already aware. And even if you tell them not to, they invariably test the blood sugar levels of all their other siblings. That is true. So,
that's true.
So that's really great work, Dr. Rakesh Kumar, and we are really hopeful that, like drug of teplizumab, we will have another drug and which will actually longer the duration as well as in more number of patients to hold C-peptide levels for longer duration. So we can move forward to the next session if we don't have any questions.
Yes, sir. For the next session, I would like to invite the chairpersons, Dr. Archana Sharda ma'am, and Ramchandani sir will be joining a few minutes later.
No worries.
Can we have the intro slide for Archana ma'am? Archana ma'am is a consultant diabetologist in Aurangabad, India. She is the founder of UDAN NGO for underprivileged children with type 1 diabetes, and she has been working with type 1 diabetics since a very long time. Over to you, ma'am.
Good afternoon, everyone. And our next session is about patient advocacy. And we have already heard the RSSTI perspective from Dr. Vasant Kumar. Now, we will be hearing the Ispad perspective from Dr. Rakesh Kumar. Can I have his introduction, please? Professor Dr. Rakesh Kumar is a fellow of pediatric endocrinology from UK. He is a Professor Pediatric Endocrinology at the Diabetes Unit at PGI Chandigarh. He's also the Joint Secretary. He was the Joint Secretary for Ispad in 2021. So we are going to hear the perspective of, because Ispad is now the leading Indian organization, and we look really towards it for various programs. My own team has been enrolled into a program like Ideal, which they are doing to train educators. So a lot of things are happening there. We would like to know your perspective on patient advocacy. Over to you, Dr. Rakesh Kumar.
Thank you, ma'am, for that kind introduction. So I'll just share my screen. Are my slides visible?
Yes.
Yeah, I'll make it slideshow. So at the outset, I must thank Dr. Banshi Sabu to organize such a program. He's always been a good, I would say, managerial skills he has. And it's really good to bring everyone, all the stakeholders at one stage, which is actually, I think, need of the hour, particularly for type 1 diabetes advocacy, if I say. So I'll be speaking on behalf of Ispad. Yeah, I am Joint Secretary for the last 2 years, and I've been fortunate to be Secretary from next year for next 2 years. So I hope we'll be working in close collaboration with all the stakeholders for type 1 diabetes advocacy. So going to Ispad this year, Ispad Abu Dhabi. So there was a joint symposium with Ispad and Ispad, which actually covered some bits of advocacy related to type 1 diabetes. And the session was titled as Diabetes Care Systems Setup. So it was chaired by our Ispad President, Dr. Shala Bhattacharya. So the first lecture in the symposium was actually by Dr. Silver Bahandeka from Uganda, and he actually discussed Ugandan approach. They have actually rolled out a new program for type 1 diabetes. The talk was titled Health Service Delivery for Type 1 Diabetes in Uganda. So they have actually been working for improving type 1 diabetes care in Uganda, and all stakeholders being brought on table, and they have started this concept of healthcare delivery for type 1 as a team, and they have actually started a digital tool where all different members of the team are connected. Village health team, it's basically involvement of community to screen or bring patients who are suspected to have diabetes to the healthcare system. Nurse and clinical officer would further confirm the diagnosis, doctor would supervise, and endocrinologist would mentor the whole setup. And they're all working in connection, in link, using a digital tool. So this program has been rolled out to whole of Uganda, as was being told. Next talk was about decentralizing type 1 diabetes care for the poorest billion through PEN Plus strategy, where there was some discussion about PEN Plus strategy yesterday as well in this meeting. So Dr. Jean Bookman from Harvard Medical School actually took this session. And PEN Plus strategy from WHO now actually is covering type 1 diabetes, sickle cell disease, and rheumatic heart disease. And it has been rolled out in some African countries, not yet in India. So this is what are the snippets of that talk. So I hope that this strategy is rolled out even in India very soon. Third talk was the outcome of this Life for a Child and Ispad collaborative survey, which was on shifting responsibility for type 1 diabetes care to the team members. The talk was taken by Ms. Emma Klettman from Life for a Child. So this talk actually included initial data results and outcome which were there from the survey. The survey was on talk sharing in the care of children and youth with type 1 diabetes and the current status and attitudes. So the survey actually included a lot. It was sent out through Ispad membership or Ispad website and a lot of other social media to all the countries possible, and 83 countries actually responded with 260 responses from 83 countries, and India was leading with the number of responses. 33 out of 260 were from India. So responses were from the diabetes care teams basically, and most of the doctors actually responded. And the main outcome here was the most of the burden of diabetes, type 1 diabetes care is actually taken up by the doctors rather than diabetes nurses, educators, counselors, or other team members. Even when there are these team members available in the team, the most of the burden is on doctors, and we need to actually involve more other team members, and they need to share the task, so-called task sharing. And another outcome here was that obviously most of the doctors were ready to share that task, and the team members were ready to take that task actually, and sharing was actually sought by most of the respondents in the survey. So coming now to our ISPA's role in type 1 diabetes advocacy, just a brief introduction about ISPA first. ISPA is a relatively very young organization. It was registered in 2007 with an aim to promote greater knowledge, research, education, clinical practice of pediatric endocrinology, obviously including diabetes. Although earlier we were part of the major umbrella organization of Indian Academy of Pediatrics as pediatric and adolescent endocrinology chapters for 20 years before ISPA was registered. And first pediatric endocrinology training formal in India started in Lucknow, SGPGI, and first DM pediatric endocrinology was started just 3 years before at our center in Chandigarh. And 2021, last year, we started Journal of Pediatric Endocrinology and Diabetes, which is official journal of ISPA. And we have already come out with third issue this year. This is how our ISPA website looks like, and this is our journal website. So ISPA, we have total 750 members around, including pediatricians with interest in pediatric endocrinology, endocrinologists with interest in pediatric and adult endocrinologists, in fact, who have interest in type 1 diabetes and pediatric endocrinology as such. So diabetes educators, dietitians, type 1 diabetes advocates, people with type 1 diabetes are also included as associate members. So ISPA has been doing obviously a lot of work for type 1 diabetes care, as we pediatricians understand that most of the patients with type 1 diabetes would be presenting to us, and it's our major responsibility to diagnose in time and then provide optimal care to these children till we transition them to the adult endocrinologist. So first thing I would highlight, I'll be sharing a few points where what all we have been doing and then dwelling on those in the next few slides. The first thing, the clinical practice guidelines were developed for management of type 1 diabetes by ISPA among children and adolescents. Obviously, first edition was released in 2011 and the latest 2017, the second edition. Another flagship program of ISPA, which was started 2021, ISPA Diabetes Education and Learning Program. I'll be telling in details about it a bit later. ISPA BEST, the Basic Education Series in Type 1 Diabetes. That's another program rolled out in 2021. We have a lot of patient education material in different languages across India available on our website. And we do conduct Ispad meetings focused only on type 1 diabetes every 2 years. This year it was in Chandigarh. Patient awareness programs we do have and organize them time to time. Most of the ISPA members doing in their local regions and then combined as ISPA programs. Charity work by ISPA members has been a regular feature. And advocacy, obviously, many ISPA members have been successful in getting government's funding or support for these patients with type 1 diabetes. For some examples being Kerala, where insulin pump therapy has also been provided to some of the patients. There are obviously some criteria which patients would be given that, and free insulin pumps have been given to patients with type 1 diabetes. Delhi, Uttarakhand, Tamil Nadu, or some of the states where insulins are provided free, insulin analogs as well. from government. So clinical practice guidelines are available free for download on Ispad website. The latest edition was 2017. Then patient awareness education material is also there in different languages on our website. We do have a YouTube channel where we release different videos from time to time for public awareness and other programs. So ideal, this actually was the brainchild of our Ispad president, Dr. Shaila Bhattacharya, and we as a team have been successful in executing it. These were the initial 9-member core committee which worked on starting these, and first ideal batch was launched on 9th of October 2021. So these modules actually were made with the help of nearly 50 pediatric endocrinologists and other educators, psychologists, including. So 50 faculty who developed these modules. There are actually 10 modules with around 17 sessions, which are actually done virtually for the time being, virtually 2 sessions per week. So it takes around 2 to 3 months for one batch to be completed. And at the end of it, we have exit exams. It's quite formal. Attendance and all things are ensured before we actually certify these type 1 educators to be trained with Ideal. So we have already actually trained 3 batches. This is our core committee, 9 members, and this faculty around 50 from all over India. And these are the members of second batch. So this particular program was actually, we submitted an abstract to Ispad, and it was presented as an oral session. And obviously the program was much appreciated, as we do need a lot of type 1 diabetes educators. I think that's the need of the hour. So till now we have actually 24 plus 30 and say nearly 85 type 1 diabetes educators have been trained and certified under this program, and 4th batch is actually running right now. So another program started by Ispad last year was BEST, the Basic Education Series for Type 1 Diabetes. So while we were actually training Type 1 educators, there were a lot of demands coming from the general public or patients or parents of patients with Type 1 diabetes or Type 1 diabetes patients who wanted to improve their diabetes self-management education knowledge. So we started this program for them. It is brief, obviously, and catered to the ones who do not have medical background. It's basically a structured version of diabetes self-management education for patients. So this is the curriculum for the BEST, around 8 modules here, which are covered in around 4 weeks, in fact. So I'll pass on. So other activities with obviously Ispad has duty to perform, in fact, I would say. So we are doing a lot of patient and public activities, our Ispad members. Obviously, last 2 years, most of the activities were done online and some being offline. So this is a brief list of some of them. So this World Diabetes Day, we as Ispad actually, we did awareness program. It lasted for around 2 hours, in fact, 2.5 hours. So Ispad team addressing the questions from Type 1 diabetes patients, parents from all over India. So we are also preparing modules for public health education. Apart from other endocrine disorders, diabetes management in schools, we have started work. Already this module is, this will be basically targeted to school teachers. In each school, we can have a structured diabetes management module for care in the school for children. So we are in almost final stages of finishing up with this module, and hopefully we'll be rolling it out next year. So just coming to end of it, I think the need of the hour is that there are a number of societies or organizations working in India. In fact, this is a list taken from one review article published in Journal of Diabetology. So nearly 40 societies across India who have been working for advocacy for type 1 diabetes individuals. So I think it's important that we all come on a single platform, and I think that would be more fruitful. So obviously we have a long way to go, but I'm sure united we can and we will. So I think important challenges and the solutions we need to find out. So universal access is the first thing, I think, for best of care for type 1 diabetes, not just the basic insulins or a few glucometer strips here and there, but we need to have optimal care for poorest of the patients. That's the first priority to my mind. Then I think school is a significant time. Children with type 1 diabetes are spending more than 50%, 60% of their active time in the school, so which is being neglected actually right now. So type 1 diabetes registry is important here. I know there is ICMR registry, but it has somehow been diluted by other forms of diabetes included in it, less than 25 years. It's young diabetes registry rather than type 1 diabetes registry. And somehow I think many pediatricians or many pediatric diabetes clinics are not covered in ICMR registry for some reasons. So it's not the true data which we are getting actually in ICMR registry. So we need to have type 1 diabetes registry exclusively with involvement of obviously all pediatricians who are taking care of children with type 1 diabetes. And concerted efforts and advocacy from all like-minded societies is actually very important. And maybe we can come out with a consortium of federation of all type 1 diabetes societies in India, and then work on with concerted effort and approach the policymakers. Thank you.
Thank you, Dr. Rakesh. That was really an insight to what is happening. All those who did not know that such programs are there, I think a lot more people would now go onto the website and actually be able to access. And I agree, if we can all partner together because we all have the same goal, and that would be wonderful. And that would be the outcome of this forum.
Yeah.
At the end, we will all discuss together once again. Right now, I would like to invite our next speaker. Representing ITF is none other than Dr. Shashank Joshi, sir. We all know him. I don't think he needs any introduction at all. And as the president of Indian Academy of Diabetes and always a mentor, we heard his speech in the inauguration ceremony itself, which itself was advocacy for diabetes care. I would directly ask him to take over for his opinions and views from IDF perspective. Over to you, sir.
Well, thank you, Archana. As a Southeast Asia chair and the board of directors of IDF, I think IDF is always committed to type 1 diabetes from day one. And you are aware that on the global board also, people living with diabetes and particularly focus on type 1 diabetes always have a seat on the board. So that's something very pertinent and important to recognize. Diabetes has partnered with all stakeholders related to type 1 diabetes management. Apart from the atlas, apart from the meetings, apart from having a big advocacy focus, kids programs, they have always been having a focus for people living with diabetes. There are two areas where IDF has a further focus. One is the IDF School of Diabetes. Is a capacity building site where they are looking at developing type 1 diabetes modules for healthcare professionals, for educators and nurses, as well as for pharmacists and for lay people. So that is one area where there is an idea focus on the capacity building fund from the school perspective. Secondly, I welcome all of you all at Lisbon. And you know that the Lisbon Congress virtually is now free for everyone who is interested in attending the meeting. And physically also there is for low and middle income countries, a very competitive registration price. And there, if you see the various streams, there are dedicated streams for people living with diabetes, particularly type 1 diabetes. IDF is hugely committed for affordable, accessible insulin and has a clear mandate and a mission that no human being on planet Earth should be deprived of insulin independent of type 1 and type 2 diabetes. IDF is clearly recognizing the fact that there should not be any stigma or discrimination, and therefore the word diabetic should not be used in common parlance. We should always use the word people living with diabetes or people living with type 1 diabetes or type 2 diabetes. IDF is very mindful that mental health plays a huge role and behavioral science plays a huge role in the overall management of diabetes and type 1 diabetes in particular. Therefore, is hugely committed for the same. And IDF and each of its regions are hugely committed for camps related to type 1 diabetes, particularly the young leaders of diabetes. Many type 1 diabetics who are living now are members of the Youth Leadership Brigade of the IDF, as well as the Young Diabetes Leaders Program, and have benefited from the same. And IDF is keen to partner with all stakeholder and member organizations, including Ispad and others, who have been involved in clinical care, research and education for healthcare professionals, for medical doctors, as well as for people around the communities related to diabetes, particularly type 1 diabetes. IDF is also now vibrant on social media and is trying to make its footprint. And people living with type 1 diabetes are right at the forefront of this social media footprint as well. That IDF has a newsletter called Diabetes Voice, in which a complete section is reserved for people living with type 1 diabetes. And IDF has a mandate that it's committed to clinical care research in type 1 diabetes. Its mandate is to have affordable insulin below 10 cents and universal access of insulin to every human being on planet Earth. IDF is clearly committed for ensuring that devices, including CGM, are made accessible, affordable, or even free for underserved or deserving populations. And those are really the mandates of the IDF. It has partnered closely for various stakeholders in the development of the type 1 diabetes index. And we know that India is a population of living with type 1 diabetes. It's clearly committed to clinical care, research, and education. And those are the IDF mandates. I'm not using slides here, Archana, because everyone has already said what is needed and necessary. And there is a need for clearly focusing both for children, adolescents, and adults, or people living with type 1 diabetes. It's a different disease, it's an autoimmune disease. And clearly, the numbers are spiraling because globally, if you see, the restriction of type 1 diabetes is predominantly the Scandinavian world. Now has moved across spectrums and across geographies. So we are in a global village, as we call it, it's a Vasudevam Kutumbam. And therefore, type 1 diabetes is there everywhere. It's important that we create awareness, education, care. And it's very, very mandatory, at least in the IDF, that nothing is done related to type 1 diabetes without involving people living with type 1 diabetes. Many members of our board are type 1 people living with type 1 diabetes for a couple of decades, who are on insulin pumps and are very committed to care of type 1 diabetes. So that's all I will say, Archana, here. And I'm thankful that best of Ispad is being got to people in audiences like India, so that they can listen, learn, and adapt various care protocols, so that they can have better lives living with diabetes. Thank you.
Thank you, sir. And that was the perspective of a very strong commitment to patient advocacy, and especially with people living with diabetes themselves through IDF. We will now move on, and our next speaker is none other than Dr. Parthakar. And I will not read out, he's just a champion. I think everyone loves him. Even the villagers of Aurangabad, people love Dr. Parthakar. So anyone with type 1 diabetes sees him as a champion. And over to you directly, Dr. Partha, to talk about patient advocacy aspects from all over the globe.
Good morning, and thank you so much. Lovely to see you guys, and early morning here. So just had my coffee and woken up. I can see Stephen here on the screen as well. So I'm pretty sure it's early morning for him as well. So First of all, thank you for the invite. So what I'll do is I'll share some slides and we'll just talk around it and go from there. So bear with me 1 second while I do that. There we go. That should be okay. So what I'll do is I'll talk about common goals for advocacy and just some points for everybody to think about as we sort of go forwards. So I think when we start off, we talk about what are we trying to achieve? Are we trying to just trying to achieve improved health? Are we the only people who can do that? And most importantly, are we the right people? So, we start off with the right intentions, but that doesn't make necessarily us the right people who can do the advocacy and the championing. So it's important to think about that when we start off. I always talk about this, which is important. Okay, we need to have self-management, peer support, access to healthcare professionals. 3 big pillars to improve diabetes care, type 1, type 2. But let's talk about type 1 in this context. But these are the 3 pillars we want to tackle. And this is what we like to do. So if you look at countries which are in that space, we can talk about, how do we improve better access to technology, better insulin, people talking to each other, better healthcare professionals. And that's all okay. But before that, I think the global advocacy sits here. It's about access to basics. So when we, for example, in the UK, we sit back and we have what I call sometimes a bit of an understandably so, we have a first world problem, which is we'll have people coming to us and saying, Partha, I don't have the G7. I'm just getting the Libra, which is absolutely right in the context of where we are as a country. But then you flip it around and you take it to, let's say, parts of villages of India where all these work that you have done, Archana, the conversation is of a different planet altogether, which is we need our insulin, right? So, and I think that's where the sort of that doesn't mean by any means that progress should stop in other countries. They should happen what their advocacy has achieved, where their investment has achieved, what their health system has achieved. And I don't believe in this thing that a lot of people say is that, oh, you should not have this because other countries don't have that. That is the wrong approach. The approach should be, we should learn from the countries which have done that. How have they got to their position? That they can have a discussion about where we are, about the technology. How is it that they have a health system which is different? But what do we need? We need data to convince advocacy as accurate as much as possible. So recently, JDRF have done a piece of work which talks about it. My first instinct at looking at it, that it seems to underestimate the number of people with type 1 in India. That's my first instinctive reaction looking at it, having come from India. But it's a piece of work which just started the ball rolling. It started people think that there is X number of people. My guesstimate is probably underestimates it by a factor of 6 or 7 times, at least. And that's but that will get better as data gets more accurate. And that's probably the most important thing you can do for advocacy, which is get data. Encourage all your colleagues to collect data. And then once you got data, you can then do the next steps of the advocacy. How much insulin are we talking about, to try and save lives? How much strips are we talking about to save lives? And then what impact can we show of the above? And I think that's quite important when you're doing advocacy, because no advocacy can happen without data. And I can tell you this. So in the UK, yes, we have a good system, NHS, etc., but our outcomes are not great in many conditions. But in diabetes, we don't do badly. The simple reason for that is we got data. We can go and sit down and go like, this is the number, this is the data, this is the number of people. So for example, Stephen is doing a lot of work, he's on the call with immunotherapy. I'd say we have got an estimate. So we look at the research that's coming through and we sort of go around and say, how many people could be eligible? We know how many people could be eligible. We know how many people will fit in. The research is happening, etc. So it's easier to do the estimation of costs when you're doing the advocacy, which is what you need. And key and important factors, and I think these are very important. Health system, how you develop your health system is very important. And I'm going to mention politicians because I know politicians, a lot of people switch us off and say, oh, politicians. But without politicians, you can't impact change. And I think it's important to remember, you can't just turn around and say, I don't like politicians. Or as a lot of advocates, a lot of doctors say, we don't do politics. We just do the work. Yes, you do. Of course we do. We do the work for the person in front. But without the politics, you can't open up it to more people than who you just see in front. Because for all of us, it's very, we will obviously try and do the best for the person who comes to see us in clinic, in front, etc. But wider impact can only happen when you go to politicians, you talk about the data, you talk about the money, and you have a joined up working. And India have got or other countries now are coming together when you've got lots of people with the same mindset coming together. And that's important. That's very important, that you don't have different strategies coming from one place. I think once that happens, politicians need something very simple, which is show me the data, show me a joined up approach, show me the benefit it brings through. And of course, what is the impact for them in a political sphere? These are all very important if you want them to invest in a particular condition or a particular area. And then finally, you also need big role models from the community. And we are, as I say to a lot of my patients, recently we have had a case whereby one school has said that they don't have time to train themselves up in technology. So the child cannot come to school. So immediately we have pointed out that, well, you can become the prime minister of a country, you can become a cricket World Cup winning captain, you can become a Champions League football winner with type 1 diabetes, and your school can't provide training. I'm sorry, but that's just not an acceptable position. So you have to do that, etc. But you need those role models from the community to step up and say, yes, we have type 1 or type 2, and hasn't stopped us from doing what we do. And I think that's an important bit, which also resonates with politicians when they see that these are big figures. The role models are very important as we're doing advocacy in that space. And, in a global context, that's why there is a position of what Nick Jonas and others brings, right? You can be a successful pop star, type 1 diabetes, he talks about it. The world number 2 in tennis, Zverev, he's got type 1 diabetes, he talks about it. And I think that's important it puts it out on the global market. We have Kate Moss's daughter walking the ramp with type 1 diabetes. These are all little bits, but they make a difference because it resonates to the politician. They can see those public figures. So what do you do when you're talking about advocacy? You need a mixture of emotions and tactics. You need personal stories. Personal stories are very important, as we do. And, Archana, for example, you've done a fantastic work about what you do, but the personal stories are very important. The health messages as to what the impact it leaves on their lives. Raising of awareness is a big thing. And lots of people go like, diabetes, you just eat less cakes and be fine. Well, it's not relevant in the context of type 1. It's not even right in the overall context of type 2. But I think that's what we need to get across. And it's not like, in the UK, we're sitting here and we've sorted it. Our headlines are still full of people about how we just need to make people slimmer and everything will go away. So that's not going to work either. So, and finally, a few other things, which negotiations with industry are absolute key part of advocacy. You have to sit down, Novo, Lilly, Sanofi, Roche, all of them. And we do that. And I think the important bit there is, so when people say, I don't want to engage with industry or I don't want to engage with politicians, well, I can absolutely assure you, then you cannot move the dial. You just can't. However much you dislike them, as there is a saying loosely translated from India, which basically says that at the end of the, we say that, आपको पेड़ से क्या मतलब, आप आम खाओ, which simply put means that don't worry about the tree. You want the mango, we'll get you a nice mango. How the tree came about, don't worry about it. So I think that's an important thing. If you want to get to that point that you want everybody to have proper access to insulin strips, etc., then you need to have tactics, which involves engaging with people who you may not be comfortable with. So that's important. And then when you get there in a country which has got difficulty in getting progress, you need to prioritize. You need to think about who will benefit the most. Because at the moment, in lots of countries, what is happening? So there'll be parts of India whereby people will have the G7 and the closed loops, right? And there'll also be parts of India where people are dying because they don't have insulin at diagnosis. So the prioritization from the government, quite understandably, will have to be at the second bit, which is getting insulin, getting strips, keeping people alive, the basics of stuff. So, and that's always the big thing. And I've been very fortunate enough to have some amazing colleagues and friends, and we've done lots of national projects. But my advice always has been start small. Never start too big. If you go out and go like, I want to get everybody the insulin strips, or insulin and strips, it's such a big project. You start in some areas, work up some villages, slowly show the progress and go forwards. So I'll finish with this, and I always say this, and over the last fair few years, I've had the fortune of engaging with a lot of professionals, a lot of advocates from around the globe, people with type 1 diabetes, people who are interested in type 1 diabetes, clinicians, scientists, academics, and it is incredibly heartening to see all of them come together, patient charities. And I think, as I said about industry, as I said about politicians, they need to be together as part of the same pack if you want to do global advocacy in my book. So I'll finish with this quote, about going alone and going far and going together. So that's very important in my book. So remember those few things, and hopefully that helps give us an overview. And at Ispad, we've talked about this a lot. We are again going to IDF next week. week after, whenever it is. And we'll be talking about this again as well. So those are the sort of overviews from my end. So I'll finish there, and any questions or whatever, maybe. Thank you. Thank you so much.
Thank you. Thank you, Dr. Partha. I think I would open this forum for some questions. Dr. Rakesh, you are there with us from Ispad. Yes. Bhima Jan, you have joined in. Dr. Deepak, you are there. So this is everyone who's here can please ask questions or interact. We are talking about patient advocacy and how best we can do it together. So, Dr. Partha, I think a very important point which you made very emphatically was not shying away from politicians and not shying away from industry. And these are two big players if we want a major change to happen. But I would definitely, it's a very important point because that's where we usually stop, and that's why we are not able to scale up. So I just wanted to ask from a national and a global level to Dr. Rakesh as well, that if a small organization, I mean, just imagine a small, for example, mine is in Maharashtra and wants to connect, whether it's to Ispad or to IDF or to the international group, how does one reach out? What are the steps just for our audience? Because we have lots of good patient advocacy groups across India today. I think there are more than 40 registered patient advocacy groups with some wonderful champions led by people with type 1 diabetes and their families. So what would be the right steps to go forward for them? Dr. Rakesh?
Yeah, sorry, ma'am. There was a problem in between. I couldn't.
No worries. So I just wanted to know if there's a patient advocacy group in Bihar or South India or Maharashtra, and they wanted to now become part of Ispad in some way, or go one step forward. What could they do? How do they reach out? What are things they could do?
So obviously, we welcome as Ispad. We welcome them, and they could be associate members of Ispad, and Ispad would support them in whatever capacity we could.
Okay.
Yeah, they're most welcome, in fact. Yeah. So we give them associate membership, obviously, as per the bylaws of the society. Yeah.
I see. Dr. Partha, what would you ask any organization in the world to do?
So I think, so I think it's again about putting a lot of the things in the public profile. So what draws the attraction of big organizations is good work, right? And I think people want to see something slightly different. People like to see, so there is, as I said, there's a mixture of what I call passion, right? So passion alone will take you so far, but I think it's also about delivery. So, and I think it doesn't matter how small an organization you are. If you can show you have done X and Y, which, for example, you have done amazing work, it immediately draws people towards you because you're trying to think about, okay, so they have done it in a village, in a few rural places. And I think organizations like Ispad, IDF, etc. will straight away go. So I think when you approach people, my view would be if you approach them with, again, data and what you've done and your ambition to scale up and you're asking for help, that probably is the starting way of doing it. That would be my view, because, if somebody came to us in the NHS and said, we would like to do this, my first thing would be, so who are you? What have you done? I like your passion. So it's not to discourage them, but to see what they've done and then take them on board. So that's what I always say, is that's why when you're doing something good, get the data, write up about it, showcase it nicely so you can, organizations go, I really like this, and we can take it forward. So that probably would be my advice.
So I'm going to ask a very controversial question here, because most of the organizations we see or doctors supporting are actually adult endocrinologists or adult diabetologists or physicians. And we see a lot of resistance or a kind of a divide in that ideally type 1 diabetes should be treated by pediatric endocrinologists only. But the sad part being half of India does not have a pediatric endocrinologist. So, it's an open question, but I do get a lot of vibes and complaints and not able to access them. So where could we place this globally? Who should be treating type 1 diabetes? I just wanted to hear from you so that everyone else can get it.
So my view is very simple. In the UK, I've got a very simple system. I don't want to compare to the UK because it's a bit like comparing chalk and cheese to many parts of the globe. But my personal view is anybody who can keep them alive to begin with. I think in lots of areas that's very important. And I think it's about who does the training. That's important, right? So even though it's not quite pediatric, so as I said, in the UK, it's quite easier in that respect. So we've got enough pediatric endocrinologists, enough pediatrics, so they can look after the kids. In adults, everybody does at the present moment of time. So in a bigger country like, for example, India, or you take on any other areas whereby you will not have the appropriate amount of staff, I think you have to innovate. You have to think about how you use other professionals and other grades to help. Because, as you know, if you go on the sort of philosophy that only certain groups of people will look after nobody else, then you need to have a workforce plan that will deliver that. And that takes time. That takes a lot of time. You're not going to have another 50 pediatric endocrinologists tomorrow. That will take you 10 years from today if you start even right now. So that's my view. So,
Dr. Stephen, you wanted to say something?
Dr. Sharma, can I add anything?
Hello. Good morning, Partha. It's a wet, windy UK. A couple of points. I'd like to just come back to what Partha just said there and the question that you raised. But first of all, I'd just like to acknowledge Rakesh and what a fantastic effort with Ispad, which has really blossomed. I mean, I was at the beginning of it only 10 years ago. Fantastic work that you're doing there, and I congratulate you all for bringing that together. Two things. Partha mentioned very much the aspect of data and driving all of this, and certainly from my experience in a much smaller country, which was Scotland, very much smaller. But the problems were there that you've all discussed, exactly the same. And what really drove the whole thing, and still does actually, was the development of a register. Once you've got a register, as you pointed out, Rakesh, then you can start to coalesce around that, and you can bring in all the ideas from families and so on. That is the key to the data. And in a sense, I presume in India, it would be a federal system, if you like, where each centre would get data. Once we got data, we then did a big thing, which was in relation to what you were talking about, Ashana, in relation to paediatricians and diabetologists, is we got together. We met regularly as a group, and there were divisions at that time. The adult physicians thought the paediatricians were not looking after the children properly. The paediatricians felt the adult physicians didn't understand families. It was crazy. Once you meet together as a single group around diabetes and the register, all those things disappeared quite carefully. And I think the need to say, well, you want a diabetologist or a pediatrician. No, you want somebody who knows about diabetes, and it doesn't really matter who it is as long as it's somebody who can do it. So I think that point that Partha made about the data, it seems daunting at the beginning, but just knowing who your patients are is quite a big step if you can do that and take that forward. And I can see, Rakesh, you had that as one of your priority lists.
Dr. Rakesh, you wanted to?
Yeah, thank you, Dr. Stephen, for those encouraging words. Yeah, we would obviously take your suggestions and work on those. So Dr. Ashna has really brought this discussion to the forum. Really,
I have a question, actually. Dr. Ashna.
Yes, Dr. Rakesh is finishing, and then
okay, fine. After sure.
So who should be managing a child with type 1 diabetes? Actually, it's a tricky question, I would say. But yes, as a pediatrician, I would say pediatricians are more equipped, but they should be trained in type 1 diabetes management. So Ispad as such, we can't say that only pediatricians should be managing type 1 diabetes, as long as we haven't trained a good number of pediatricians in managing type 1 diabetes. And that's one of our priority. And type 1 educators obviously are the main pillars, and that's first thing we have done. And now we are at least 12 to 15 centers in India who are actually training pediatric endocrinologists. We have started 3-year DM training programs in pediatric endocrinology, first in PGI Chandigarh Center, and now in AIIMS New Delhi. So I'm sure many other institutes will come up with that, and we are working in that direction. So I'm sure we'll be getting more and more pediatricians who are actually trained in type 1 diabetes, and then things would improve. In the same go, I would say that it's difficult for adult diabetologists to take good care of type 1 diabetes individuals just because of the numbers they have of type 2 diabetes. So I can understand if they are seeing 100 patients, 95, 98 of them would be type 2 diabetes. So just for those 3-4% of patients, they are not able to maybe accommodate them in the way they should be accommodated at the time they need in the clinic. And the whole scenario which is required in a particular clinic or setup which is required for type 1 may not be available with the adult endocrinologist. So we in pediatric endocrinology or pediatric diabetes clinic, we see around 25 patients in our clinic over 4 hours. And we feel that we give them due time they require actually a pediatric diabetes patient. So I can vouch for my center, but obviously we need to have more and more such centers and more trained pediatricians. Yeah, that's my take. Thank you.
Perfect. Thank you so much. Dr. Dalal, you were saying something.
I have one very simple suggestion from Dr. Abhay Bang's work about pneumonia in diabetes. So they have trained absolutely illiterate ASHA workers for giving injections at home and saving life. So what I personally feel in India, what we need is a properly trained, qualified and accredited basic workers to manage either at the city level or at the rural level. Unless and until we have this much armed force, the things will be very difficult. So I personally feel that investment in educator is much more fruitful than depending on an endocrinologist. And I mean this. And I mean this.
Yes.
So
thank you. Bimajan?
So happy to see you all. Dr. Kar, your last words were amazing. We all are going here to work along together to make a difference. Those beautiful, beautiful words you ended your lecture with. Thank you.
Thank you, Bimajan.
Thank you.
So I think at the end of the Symposium for Patient Advocacy, we have heard representatives from various organizations, but also key people who are very passionately doing this work. So we take home a message, a collective message of training, that is one, reaching out from small to big, and a very big unifying factor, which I heard from everyone, from the experts, is data. And that is one thing that can move mountains in today's world and can actually unify, bring policy change, and create big advocacy. So with that take-home message, I would end this advocacy symposium. Thank you so much. Thank you, everyone.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Over to the organizers for the next session, please.
Organizers for this wonderful and rich 2-day discussion at the best of Ispad. I really enjoy it. Always enjoy listening. Dr. Archana Sarda spoke, Dr. Professor Parthakar spoke, and we've had some wonderful discussions over yesterday as well. So welcome once again, and Shachi and I will take you through this next session. I'd like to invite our next speaker, Dr. Irina, if I could request for the slide, please. Thank you. Welcome, Dr. Irina, and thank you for being here today. Dr. Irina, as we know, is the Vice President at the International Diabetes Federation. She's part of countless other, organizations working in the diabetes space. She's also has been a part of several regulatory documents which have been developed on a national and international level. I will hand over now to Dr. Irina and request her to start her session. Thank you.
Thank you so much for introduction. I'm very happy to be with you. It were before I listen very interesting discussion. This is big problem all the time. We must work together, but a lot of barrier for this, and we not use all the resource for our patient. In this case, it's very good discussion, and we go to reality. And today I would like to speak about pump and pen. Can I share my screen? Slideshow. Yeah. Did you see? Yeah. Did you see my screen?
Yes, we can see it now.
Yeah.
Yeah.
Great. Last few years, insulin delivery device market has emerged as one of the most lucrative verticals of diabetes management industry, gives the unprecedented growth in technologies that partly change the way this chronic disease was managed easier. The insulin pen market in this regards is expected to witness a massive remuneration portfolio. One of the fundamental reasons behind the popularity of insulin pen is the increasing demand in the low-income group. The insulin pump are not only endowed with a matched combination of feature-like convenience, efficiency, needless insulin delivery, and portability, but they also eliminate this necessary of daily insulin injection dose. If you look on market, the global insulin delivery device market size was accounted at 16 billion in 2021 and expected to hit around 29 billion by 2030. It's very quickly grow, you see. And also this is input of regulatory authorities. Major strides have been made in digitalization of insulin pen, insulin pumps, continuous glucose monitoring, and the integration with insulin pumps, automated insulin delivery system, closed-loop insulin pump system. The centralized regulatory body in the USA and more decentralized approval body in Europe have led to differences in the rate of market availability of diabetes devices. But anyway, both US and European systems have different advantages and disadvantages in device approval. They continue to struggle with balancing accelerate devices access with adequate clinical evidence and monitoring to ensure safety and such device. This is if I try to find some new information for you for update, because I know a lot of about pumps, about advantages. But this is also interesting for me, show this insulin trend in USA, insulin use and glucose monitoring for people with diabetes, because the delivery and administration of insulin can undergone many changes over the year. And this was in study show that individuals, you see this is approximately a 9 years study. Individuals with type 1 were most commonly prescribed a basal and bolus insulin regime or short repeat insulin only, while for people with type 2 diabetes, the use of basal only insulin increased significantly over the study period. That is what we're looking for. In both groups, there was a significant decline in the use of premix insulin from 2019 to 2018. Insulin pump use increased for individuals with type 1 diabetes, while this disposable pen use increased for people in both cohorts. In both cohorts, there was a statistically significant increase in the use of continuous glucose monitoring, although this increase was more pronounced at occur earlier among individuals with type 1 diabetes. This case shows this now it's prescribing insulin continue to change in response to the development and new therapeutic advantages in insulin delivery technologies and glucose monitoring system. Of course, many people know how much benefit we have from the pump because it's more likely one without diabetes. I also patient with diabetes who have many years diabetes and go through the many stages with development of technology. I can also I also have my own opinion about this, but I would like to more share with you evidence. But this is, of course, it's true that this is a daily injection with pump versus with pump. It's more easier and make the system helps automate use insulin therapy and keep going all day long without any not too much interrupt your life. This was very interesting study that the aim of the study was to measure the life quality and therapeutic satisfaction of patient with pump and compare the result with data of patient with pen. And then therapeutic satisfaction of the patient with pump is significantly higher than the patient with pen. A patient with pump are more confident on handling compliance, but not significantly. They found no significant difference between the two groups' life quality. And hypoglycemia occur in more cases with patients using insulin pump, especially for beginning of this therapy. In this case, we can see that, but this is of course evidence, but from my side, of course, it's absolutely change life when you use pump. And the last study which we can see and some evidence for and benefit for a pump, like a Scottish experience with insulin pump therapy and retinopathy amongst those with type 1 diabetes. They found that pump therapy was associated with reduced progression of diabetes-related retinopathy compared to multi-daily injection. But in same times, I know that we, on beginning of stage and use pump, we must check very frequently, check eyes, because it could be another case. This is very important check beginning of this therapy, like 1 year, check more frequently. In another Scottish experience, colleague used that one against one non-use control group matches by age, sex, and diabetes duration to check for any trend occur in HbA1c among non-use in similar calendar time. They report significant reduction in HbA1c and also ketoacidosis and hospitalization for severe hypoglycemia, of course, because we can prevent. Review one of our colleagues provide evidence that dial-aware bolus improve postprandial glycemia, that it's very focused, in our treatment, in high fat, high protein, and low glycemic index food. Another research published at World Evidence for the use of Omnipod in type 2 diabetes. The analysis retrospective many data, and the Omnipod use was associated with a reduction with HbA1, self-report of hypoglycemia, and total daily dose. And I find interesting study which published about comparison among the tubeless pump system by Insulet, Roche, and Medtronic. And that we can see that the best way is, of course, it's in vivo or in vitro study that show that inaccuracies are more common a small delivery volume, that's volume influence. The unique piston drive stepped motor of the Roche system appeared to have the best performance. But we must continue this research. This is another part, not benefit for our pump. This is big gaps about data for side effect or some problems with this. One of our colleagues, Carwin, make like special molded database which show that during only 2020 they found 30,000 injuries and 295 deaths reported that were potentially attributable to insulin pump. In this case, but this is not collected. This is a big problem because not everybody delivers this information, that we can lost some information. In this case, we must make this like platform and have more data, and this is data must be can use different researchers. And you see, it's a lot of main problem. This is reaction. And what about this? About side effect? As you know, there is we have a new pump. This is I have like this, and one additional trials underway by Convatec and Capillary Biomedical. Sweeney and colleagues demonstrated in porcine model of diabetes as hyperglycemic failure appears secondary to inflammation due to subcutaneous catheter and insulin aggregate rather than preservation, as some have previously postulated. But at the same time, this is also confirmed another information that was a poster presented by Medtronic team in other that lower preservative content increased insulin aggregates inflammation and decreased infusions at wear time in peaks. Take together, this seems to imply that preservatives are not an impediment for infusions that survive. In fact, they may promote severe razor. It appears that the inflammatory response to the catheter and insulin aggregates are the primary addressable to roadblock and extended wear. Of course, when we speak about pump, this is new pump. If it's before like 1970, but now patch pump is very popular and has been option. It lasts 15 years. And Optimum system was launched 2005, and this was approved by FDA. Patch pump is insulin pump without tubes, and this, of course, it's attractive. These pumps improve quality of life, reduce diabetes-related distress, increase patient satisfaction, and are preferred by patients compared to convenient insulin pump and multiple daily injection therapy. I have not this pump. I never have this experience, but I think, of course, it's more convenient. But in same times, I'm afraid this is reaction, because if you all the time use this, this is continue to all life, it could be some problem with skin. And of course, we have advantages and disadvantages of this patch pump. I will not read this too much, but this is also We must remember that it's like half plus, but also have a minus for this using. And this is individual method must be used for prescribe this. And smart insulin pens. We cannot speak about pens without new technology, which now it's popular. A smart pen with inbuilt calculation to provide proper guidance to patient regarding to insulin dosage. Memory function to display the amount and time of injection, as well as automatic transmission through Bluetooth on produced computer generation. I have my experience, own experience. Sometimes you forgot you did or not, because this is automatical. And of course, somebody maybe smile that, oh, how is possible forgot? Yes, it's possible, because you did this every day, many times. This is a routine in your life, and sometimes you don't know. It is very good if it's have some information, you can check this. And this is smart, some study which show that the lack of reliable insulin dosing information has been hypothesis to be a barrier is optimizate multiple and daily insulin injection therapy. And that you see that it has like 43% reduction average daily meal injection, and also increase in time in range, which is very important. And this study shows that meson bolus injection can be frequent in type 1 diabetes, and also who uses like 3 meals per day food. And this is anyway, the study shows a highlight in the importance of assisting insulin bolus administration during routine diabetes consultation. We must also remind about this, especially. And this is only one thing which I think we're not thinking very much. For example, I'm not thinking about this before, but when I read this is very important, that how we deliver this information, how we can, how you can use pump or smart pen. And this is also one research showed that they developed some infographic instruction for people who maybe not so good in some, it's now it's migration. It's a lot of people move to another place, and this is have not and language now it's big barrier, and maybe it's like infographics show how to use. It's very important, and improve use this new technology. And at the end, you can see that delivery market will be very increased, and geography, mostly, of course, in USA, the most outperformance region that has secured a major chunk in insulin delivery device market. But in same times, I have good news, according to this prediction, that other emerging economies such as China and India are also expected to gain massive growth trends, given the rapid governmental initiatives undertaken to develop healthcare infrastructure and awareness regarding diabetes management. And thank you so much for your attention. If you have questions, if I can answer, I will try.
Thank you so much, Dr. Irina Vlasenko, here with a deep dive into MDI versus pumps, and I can definitely attest to it as a person living with type 1 diabetes, having used both MDI as well as pumps. There is definitely a convenience factor that comes in, which also gets offset with the cost. Thank you so much once again, Doctor, and over to Shachi to please introduce Dr. Deepak Dalal.
Thanks for the beautiful talk by Dr. Vlasenko, and welcome to the Juvenile Diabetes Association Symposium. It's always a pleasure to invite Dr. Deepak Dalal, a very eminent speaker. Can we have a slide, please? Can we have an intro slide also? Yeah. So, very renowned speaker, Dr. Deepak Lalal. He is from Mumbai. He has many awards and publications on his name. He has position head in private practice in diabetes care and metabolic syndrome since 1980, trustee of Juvenile Diabetes Foundation, and for Maharashtra chapter, his main interest, his special interest is in reversal of diabetes or diabetes remission, freedom from insulin, patient education classes. Even I have attended so many classes from Dr. Dalal, and believe me, it's always very energizing, very enthusiastic. It's very learning. So over to you, sir.
Can I share the screen?
Organizers, can Dr. Deepak Dalal can share his screen? So I think sharing screen options enabled. So
I am unable to share the screen.
Okay.
So, good afternoon, everybody. I hope I am heard very clearly.
Absolutely, sir.
Okay. So, today I am going to take everybody through the dreams in the diabetes. And those dreams are very simple and doable. And to prepare this presentation, the whole of my staff has helped me. That's why their name. Next. I am unable to change, so I will say the next, no issues. So Abdul Kalam said, the dream is not what you see in sleep. It is the thing which doesn't allow you to sleep. Mad and passionate people, Dr. Parth Karta said, passionate. People live their dream once so that wise worldly people can relive those agonies again and again, which we see, and relive and relive happy and healthy life. That seed was shown and sown by Banting. Next. So this presentation is dedicated to all Humsafar, that is traveling together and not suffering, and type W and 1 diabetes. So I will not be fighting for the nomenclature. I have a simple nomenclature: insulin injection deficient and dependent and resistant for the life all over the world. And I have in that bargain receiver, their families, medical team, society, and the governing bodies. Next. So this is a very busy list, which I will be covering. Next. So the story of diabetes doesn't start with the endocrinologist. It starts with the orthopedic surgeon, and in a sheer love for his fiancée Jane, who was suffering from type 1 diabetes, and after her death, he took it to his head to do something about the diabetes. And as a respect and a tribute to her, next, he discovered insulin. So the discovery of insulin is like a 1 in the current figure of, say, 100,000 lakh. If you remove that 1, that is insulin, only zeros remain. So that is the hope, help, and heartfelt hard work, which is going to help our children suffering from this particular problem. And here the hope or a dream is the most important. Next. So this was a scene before insulin. Children with a diabetic ketoacidosis will get admitted to the Toronto General Hospital Children's Ward, and the dead body comes out. But after that, this was a before and after insulin. And after that, this particular ward was closed down, which was considered as a post-mortem ward. Next. So this is a survival of juvenile. Before 1921, death rate was 100%. And after that, it is a progressively increasing. And I am happy to say that it will be crime that juvenile child with the insulin dependent cries because of dies because of want of insulin. And that is the dream coming true. Next. So there are the devices, initially thick glass syringes and needles, then insulin syringe, then insulin pen, jet injector pump. And the most important thing which I want to tell all the technologies all over the India, to find out a port which can remain in the body for at least 3 to 7 days, which will make multiple painless shots possible. And then we can use the pen without any much of a cost. And there are two pricks, pricking for blood sugar and pricking for insulin. These two pricks, if reduced, the whole story will change. And I personally feel that the port business should be taken very seriously by the industry. Next. Now comes dream true. CGMS on one side, pump on another side, and with the artificial intelligence and our own intelligence, and with the carb count and exercise, training, physiology, we can achieve almost normal blood sugars throughout the life. And that is a dream coming true. Next. So initially there were urine sugars, urine ketone, then came blood sugar, then came meters for sugar, meters for insulin, and now CGMS. So the whole diagnostic history has taken a different toss. And that dream of diagnosing properly, managing properly has come true. Next. Now, two important trials, DCCT and EDIC, they have proven beyond the doubt that tight monitoring of blood sugar round the clock makes a difference in terms of reversal of and prevention of, almost prevention of microangiopathy, that is retinopathy, neuropathy, nephropathy, and reduction drastically macroangiopathy. So this particular dream that once diabetes will develop the complications and die, that is shattered and achieved something. Next. Now diabetes means no. That myth has been broken down by the variety available round the clock. And with this variety and variety of monitoring and insulin, life becomes really happy. So diabetes no more becomes a disease of a no. Next. And variety of physical activity, exercise, marathon, triathlon, you name the physical activity and children with diabetes can do. So there is no more restriction in terms of this particular aspect of a physical fitness. Next. So disciplined lifestyle on one side, that is the head of a coin, and proper monitoring and insulin is a tail of a coin. When both are equally important, that coin becomes a true coin, otherwise it remains a fake coin. So lifestyle on one side and monitoring and insulin on another side, that is the most crucial thing, and that dream has come true. Next. So almost normal control of metabolism, mental, physical, emotional, psychosocial, and economical, which was a dream. There was no question of all these things because child will not live long to have all this. And child has traveled from 1921 to 1921, 100 years. And we have seen those dreams are coming true one by one. And for that, so many organizations and efforts are involved. Next. So the variety of professions are possible. You name the profession and there is a juvenile diabetic, including astronaut. So what more I can say? Next. And you can achieve anything. You can be celebrity and you can celebrate in spite of the diabetes, and that's the message. Next. And the healthy, happy, fruitful life is possible. So these are all our couples with the juvenile diabetes, and this particular couple, both are juvenile both have juvenile diabetes. And here is a child who doesn't have diabetes. And now this child is around 20 years old. And here is our Mina Fernandez. She is 75 plus with a diabetes from the age of 8 years. So fruitful and happy family life is possible. Next. So there are different organizations, International Diabetes Federation, World Diabetes Foundation, American Diabetes Association, UK Diabetes, Australia, so many. And one of the, we'll go through next. So I am very passionate about the CRY and the HOPE project. HOPE project has laid down foundation of education, and CRY has a laid down foundation that no child with a diabetes should die because of the insulin. Next. So Ispad, we have already heard, and the Diabetic Association, RSSDI, all organizations all over the India are working day and night for its cause. Next. 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 I will specifically mention the role of RSSDI, Ispad, National Diabetes Education Program. These are our national programs, and they are contributing a lot towards the education in diabetes. Next. JDRF is one of the best involved in a research with a motto of freedom from diabetes. They've achieved freedom from complications of diabetes. Now, next step is a freedom from diabetes, and I'm coming to that next. So these are the different organizations again. Next. So I have named all the organizations in India that I have access, and I present this particular presentation to all these organizations to be used freely for helping, counseling, and empowering. Next. So now this particular new drug is available. Cost is bomb, but hope is like that. Next. That this particular therapy in the early part of autoimmunity, if given, it can increase beta cell survival and increase in the C-peptide level. Today, it appears impossible. In 1921, insulin appeared impossible, but today, every child has a right to get it. So similarly, every child will have a right of early diagnosis and early therapy, not curative, but definitely preventive. Next. Now, why I am so much hopeful about the lifestyle? So this is me in 1984 with a liver tear, hypovolemic shock, fracture of the both arms, and so many injuries. Next. Here you have to start the video. At the bottom, there is a switch. No, you go to previous slide. In the bottom, there is a switch and you put it on and you will see the video. So I am always a hopeful and empowering because of my personal experiences with the different lifestyle changes. Next. Next. I am done this. Next. We are done with this. So again, we come back to Abdul Kalam that we have to work throughout the day and the night for our dream. Next. I will be sending this particular presentation to all the people. It is in a Word file, which they can use freely. And now I am open to the questions. Thank you for giving me this opportunity. Thanks to organizers for the same. Thank you.
Do we have any questions?
Yeah. Beautiful session, sir, and we are open for questions. If you have any question for Dr. Dalal or Dr. Bensiko, we can take.
I think we are done. The presentation was well, and so I thank Dr. Irina ma'am and Dr. Deepak Dalal sir. The presentations were superb, especially the slide where the insulin was happily carrying the glucose molecule was a delight to watch. So thank you so much, both of you. I would also like to thank the chairpersons, Ms. Sachi Batwal and Ms. Nupur Lalwani. Thank you so much for the presentation. So we'll move on to the next session, and we have the moderator, Mrs. Bima Jan Yusuf, and I would like to introduce her. She is a credentialed diabetes educator in India, Vice Chairman of Type 1 Diabetes Foundation of India, Senior Advocacy Worker for people living with diabetes. So over to you, ma'am. Mrs. Bima Jan Yusuf, ma'am, if you're there, we would like to have you. Yes, ma'am, you're there. Welcome.
Good afternoon,
and
everybody.
over to you.
Can you hear me?
Yes, ma'am. You're audible.
Good afternoon, everyone. I'm actually speaking to you from Sydney. It's really such a pleasure to see you all. Well, let me, there are three speakers in this session. One is Mr. Tino Tendo Jekiti. Hopefully I'm pronouncing it well. He's a certified diabetes educator in training. He's a voice, DDoc voice patient advocate. He's a young leader in diabetes for International Diabetes Federation. Oh, so much to talk about him. And he also, technically, he is very much into diabetes advocacy, very active in it. May I speak? Are you in? Yeah, Mr. Suzuki. Over to you, please.
All right. I hope everyone can hear me clearly before I speak. You can? If you can just know. You can hear me?
I'm able to hear you. I don't know about other people.
So if you can, then everybody, I would assume everybody can hear me.
Thank you.
So thank you for having me. Extraordinary conference. As it is, I don't take it for granted. So thank you for having me to represent Africa. I mean, I had to put this, like, it will just match with what I'm going to be speaking about. And today I'll be just sort of like representing the entire continent. I mean, Africa has over 54 countries. And I'm just going to sum up like this, how we do our advocacy from our perspective. And I hope that it will be impactful, as it should, just like every other talk that has been done before me. So allow me to start by saying, so like access to vital insulin, diabetes supplies, those are the things that we're usually advocating for. Diabetes supplies, medical, should not be complicated as diabetes is. So these are, like, I'll share like briefly some of the things on how we advocate as patient advocates in Africa. So we raise diabetes awareness mostly through our social media platforms, because usually going on the streets like we usually see in the United States is a bit toxic. The politics in Africa is a bit toxic. It's in like outside working with a banner, I think you can actually be arrested for that. So we usually take advantage of our social media platforms, hoping that the policymakers will be trying to check them whenever we are posting things to raise awareness, so that even our networks, not just people living with diabetes, but even our friends, because we had friends who had life before diabetes, I'm hoping that they're seeing whatever that you're going to be posting, they're going to be, because you'll be saying like basic information, what diabetes is, how you feel, that kind of thing. Also like sharing with our own experiences on before we got diagnosed, what we were feeling at first. I mean, people usually appreciate that because they can actually relate to say, I think I might be diabetic. Maybe I have to go to a pharmacy, get tested, that kind of thing. And also, some of the things that we do is we visit schools, local clinics, training even healthcare providers, because not only like the general public not aware, but even especially the healthcare provider, especially from the less remote areas like rural areas, they're not really aware about diabetes. So as part of the people like is working with organizations within our own countries, we are also like part of the team that goes on to clinics, visiting clinics, taking advantage on every community gathering, speaking about diabetes so that everybody who is part of it can actually benefit something. Even, I mean, they really appreciate, especially the nurses. It's of course, I think they might have been spending with the general information so much about diabetes because it's specific. It's like something that is like true today or true tomorrow might not be true like maybe next year because things are changing. So many researches are being done. So we take advantage of even the conferences that we attend, the information that is just incredible. And it's actually a shock to see that maybe I might be the only one, or maybe say less than 10 people from Africa attending that conference. So it's actually saddening because it's actually only the patient advocates and not the providers, those that we wish they should be part of these faculty, attending, learning, improving their skills so that they can actually help us to live a healthy, good quality life with whatever that is they're going to be sharing with us. And further, some of the things that we do is we also launch petition. We'll be appealing to our local government officials in respect to the cause of diabetes because in our case, we have seen like some of the people, they can actually get diagnosed during post-mortem. Those are things that are still real, they're still happening, and it hurts us, especially as the people that are living with diabetes, to see that, like, even our communities, yes, we have people living with diabetes, we are talking about this, but there's just people are not really aware. Nothing is being sort of like our impact is not being noticed because people are not willing to speak up and maybe just we could raise the voice together against them. It's not really great. We are trying to change that narrative because it is really sad. And how can I say, like, how is this advocacy or how is it helping? We cannot say that it has helped, but it is helping because it is an ongoing process. We cannot say that we have not reached the goal, our objectives, like where we want really to go. So education, what I believe is education, what we believe in Africa is education helps to alleviate, that exists within the communities because people might think like if I get in touch, if I get in contact with someone living with diabetes, I might also get diabetes. Or if I share an object or if I share anything with someone with diabetes, I might get diabetes. So like those are the things that we're trying to educate. Say, hey, someone has done something, it's not like yes, I might not have to share like okay, compare diabetes with any other non-communicable disease. It's not sort of like, it's not contagious. Those are the things that we're trying to share with people so that, because if you see those things, anyone can be at least. You can actually get diabetes. It's not like you must have done something because type 1 is this. Sort of like to say, what might have caused the type 1 diabetes? Nobody knows yet. But we're hoping that with all the research that are being done, with our collaboration, people working together, we can actually go somewhere. So also sharing through our personal experiences, I believe that it also helps. This is something that is helping to change the narrative. Because like when you, even with the International Diabetes Federation, because as I speak right now, there is a call for action that is being sent. Like if you just are willing to share your perspective, to sign that call for action, that was launched by the International Diabetes Federation to help us. It will help us to raise diabetes education so that our healthcare or our ministers within our national, within our countries can actually see those things that are actually being done in the global perspective. And I believe that if we continue to initiate such initiatives, collaborate, getting together and working together with those international organizations, we can actually help to raise awareness, because awareness is not something that we spread out, like people are not really aware, because they're still living, because as I speak right now, according to the International Diabetes Federation, they say that about 54% of people living with diabetes in Africa are undiagnosed. So like I think Africa, with all the 7 regions that IDF has across the globe, in Africa is only has the biggest number. Actually, that is third, because people are not really in this together. People are sort of like fighting. People are sort of like community organizing. There is sort of like a decentralization. We should have something that is combined. We should be coming up together. But it's something that people like are sort of like fighting. And then so even to get things to sort of like having like a sort of like a common goal, the things that you always out, it's not really known, it's not really being practiced because people they sort of like they want to fight over resources for their own ambitions. But at the end, it's so most of the big pharma, I believe the big pharma is well aware of the training being patched, which is insulin for all. And since 2014, and I think like almost the diabetes community, they're coming up together to sort of like raise their voices together to demand that you should have like proper access to healthcare. Because insulin, as I speak right now, even in Africa, you can actually do that. Like if a person or a parent with someone living with type 1 diabetes, when they go to the hospital, they can actually be prescribed, or a doctor can actually give them to certify, which is okay. You can actually go to metformin. Like you cannot have like a type 1 diabetic patient having to use like sort of like metformin, a drug that is meant, or a tablet that is meant for people living with type 2 diabetes. We still have these cases in Africa. It's not just a matter of misdiagnosis, but even a wrong medication, because insulin is expensive. So I believe that like if we continue to come up together, even we can have insulin for all being realized in not just in Africa but the worldwide, because insulin is a bit expensive every day. So what are some of the challenges that we are facing as people in Africa? And I believe so we might even share like we share the same sentiments. Those are the things that like we believe that even in the outside globe, globally, these are some of the challenges as a people. One, lack of support from reliable diabetes organizations. Civil society are not supposed to be like the civil society or organizations that are supposed to be coming up together and uniting people to stand on like one voice. They're fighting, as I say, as I mentioned. They're not coming up together. They want to be like we cannot have sort of like an organization in the same country. They advocate for the same thing, but then they are not together. They're all sort of like calling for donations from the same organization. But then how can you collect for 5 different, like, there should be one voice. There should be one voice. We believe like diabetes is one, we are the one symbol. We should all be united for diabetes. Some of the challenges that we're facing. And it is therefore extremely difficult to get resources together and fight on a common goal because of this. I don't know, like I think it just exists in Africa. I don't believe like this can actually be happening with the outside world. I believe that if we do come up together as a collective, as a one voice, we can achieve and we can deal away with all these problems, the challenges that we're facing. How do I think like how can we sort of like overcome these challenges that we are facing right now? I believe it is extremely, yes, of course, I believe it is extremely difficult to have all these organizations to work together. But I think that, like, in the case, let's say, for example, this organization is sort of like doing raising awareness on diabetes, because I believe if you continue to do that, people would appreciate. You never know who you're speaking to. You might be speaking to the same people, even people living with diabetes. It's not just the people in the general public that need this awareness. Even people living with diabetes, they are still doing some of the things because they are not really going to get to their for reviews because of money issues, financial burden. So everyone needs to like have this awareness. We need to continuously speak and encourage others so that we collaborate, come up together, and just be one voice. I believe if there's a one voice, I think we can go somewhere. And also, as I always say, we really need to get involved. We need to get involved and come up together, or sort of like to create the change that we need. And in my honest opinion, I think that people within the international diabetes community should join forces and be
True. Yeah, it's a world cry that everyone should come forward for this, isn't it?
Right. Yes. So like one thing I would like to share about like how I sort of like build my own advocacy network. This is the last item that I'm speaking about, and I believe I'm not out of my time frame because I was speaking fast. And apologies if anyone is failing to get me correctly. So I got involved with the Zimbabwe Diabetes Association like 8 years after my diagnosis because they just like in the court.
No, you have hello.
Okay. You can hear me?
Okay. It was really nice. Like you have really touched various challenges you face in Africa, and I think a little bit later when we can all chat after the other two speak about their experiences in their countries.
Thank you so much. All right. That's right.
Thank you.
Right.
The next speaker will be Dr. Sana Ajmal. Sana Ajmal is the founder and executive director of Meeti Zindagi, Pakistan. She has been living with type 1 diabetes since the age of 15 years. Fantastic. She holds a PhD degree in computer engineering and has served as assistant professor with reputed academic institutions in Pakistan. She's also a diabetes educator and has worked extensively volunteering in various international and her national associations. She's a trained advocacy worker for the Young Leaders in Diabetes program in 2011, and since then she has rendered great services nationally and internationally for the purpose. And she specializes and specialities and interests in this regard include advocacy, community work, communications, strategic planning, organizational project. It looks like she is the only person in Pakistan who is doing through this advocacy through Meeti Zindagi. Over to you, Dr. Ajmal. Dr. Ajmal?
Hello, everyone. Thanks to Ispad and Dr. Sabu for inviting me to be a part of this amazing session. I apologize for being unable to make it live due to a pre-scheduled travel. I do not find video recordings the best way to communicate. However, I'll try my best to do justice to the vast topic given to me, which is advocacy by people with diabetes, a perspective from Pakistan. I'm Sana Ajmal, and I've been living with type 1 diabetes for around 24 years now and involved in advocacy within Pakistan and internationally for a decade. When I was growing up, I noticed that while I myself felt very lonely with diabetes, I at least had access to the basic human insulin and 2 to 3 test strips a day. People living in the remote areas might be truly disadvantaged, with no trained healthcare professionals available thereby, and insulin access a huge problem. In such conditions, knowing others with diabetes, were there any others with diabetes at all? It was a question that I still am asked by a number of people coming from these remote areas. That is why Meeti Zindagi was established, and initially working as Pakistan's first and only diabetes community organization, we stepped up to become the representative for the diabetes community in Pakistan. And now I'm going to switch to a slideshow to show you some pictures and stories, because I believe that whatever I'm going to talk about will not have an impact unless there is some visual connection to the stories that are being shared. So I'll pause for a little while. So before I continue, let me tell you that all pictures and stories are shared here with consent. However, to avoid any assumption that we might be that people benefiting from Meeti Zindagi might be indirectly pushed to share the stories and pictures, I have tried to convert all the pictures into a painting so that the children are not recognizable. However, all these stories are true stories, and the pictures are also shared with consent. So, what is advocacy near us? So advocacy begins with the community rallying around a cause. And in Pakistan, there was no community. There was no concept of anyone knowing another person with diabetes. When I was growing up, my doctor helped me meet a number of people with type 1 diabetes through her support group sessions that she was holding within her clinic. But that was a small group that I knew, and I did not know anyone else with diabetes. So with internet coming in and social media helping more and more of us connect, the community started building, and there are around 2,000 community members on our Facebook support groups now, and they've all found us through random internet searches. What needs to be done here? When I started my journey as an advocate, I often used to find people feeling very stigmatized and very unsafe about sharing their stories. But a major change that has come in over this last decade is people proudly sharing their stories, because they feel good about themselves. They know that they're incredible. They know that they have suffered, but they have also been through all this with a lot of courage and a lot of resilience, which has helped them be who they are, and they're proud of themselves. So with the goal of nothing about us without us, we embarked on developing a methodology for nurturing these advocates who could actually raise their voices for a cause. Now, what was the first thing that was a common theme occurring again and again and again amongst the community members that we were trying to serve, from the stories that we were getting all the time from our community groups? The most common theme was the restricted government support. So the government does provide insulin in the tertiary care hospitals for people with type 1 diabetes. However, in most of the hospitals, the only insulin available is premixed 70/30. In some rare hospitals, you might find regular and NPH. No test strips are supported, no glucometer, nothing else, not even syringes. Though Ispad says that twice daily regimens are discouraged, especially in cases of food insecurity, and you can imagine that the people going to these public sector hospitals are generally the people from the bottom of the socioeconomic classes, because nobody in Pakistan who can afford a dime would ever go to a government hospital because of the services, because of the healthcare teams being overburdened. And there are a few very good hospitals as well, but in general, the government hospitals are overloaded and the services are not up to the mark. So here's the story of Daim. Daim has been type 1 since 2019, and he's around 7 or 8 years now. Daim was consistently going into severe hypoglycemias at night. However, the hospital that he could access only offered 70/30. And his family stopped giving him insulin because of the fear of those hypoglycemias. So when Daim came to us, he was not in a very good condition because he was having nighttime hypoglycemia and severe hypoglycemias, and his family would either stop the night dose or cut it down to a bare minimum level, which meant that the child was not being provided the total dose that he needed. So this is how our Promise of Insulin program was conceived, specifically for people who could not access the insulin that they needed, and we provided flexibility in insulin regimen options which could be tailored to the child's needs. Now, let me talk about this. This is a child who was facing nocturnal hypoglycemia, but let me tell you another story. This is a very recent picture, around less than a month ago. This was taken less than a month ago. Now, this child, Ramesh, he lives in a remote area in Mithi, which is within the Tharparkar Desert in Pakistan. This you can see his house behind him. It's made out of straw. The child has access to less than 2 meals a day. And the nearest road from his house is at a distance of 20 minutes, tough walk. There is no hypo support available. We do not have glucagon in Pakistan, and the child, of course, has no meals to eat, what to talk about the juices and everything else. Now, this child was also on premixed insulin. And what we have seen is that it is not just always, I think as my role as an advocate makes me say this, that it is not just always the government that is not providing the right kind of insulin or is not providing the flexibility in treatment options, but also sometimes acceptability for these newer kinds of insulins that come from the healthcare teams. So though we provide even analog basal bolus to children who might be facing food rejection problems because of their issues with pre-bolusing and the time required for human insulin to start acting, we still find that specifically from remote areas, there is a 70/30 or premixed insulin continues to be the most favored prescription. And these are the most difficult settings as well. So what we need is unequivocal, loud and clear advocacy and clinical guidelines to stop the usage of these premixed insulin in children, where you can at least where at least the supply chains or the or support from any government organization or a non-government organization allows, premixed insulin should not be prescribed to children when there's so much at stake. Another issue that came up as a theme again and again and again was the long waiting lines and availability issues, both at the government sector hospitals and at the charities that are supporting the causes. So Neha's father told us that it costs him a full work day to just get her insulin. And for a child whose rest of the life is requires him to go to the hospital every month and get that insulin, it's a terrible, terrible option, specifically when these people are daily wagers. 24.3% of our population lives under the poverty line. So we as a community member, we with our boards and community members sat down together and we decided that we're going to work on a flipped model. And what that flipped model is, I'm going to explain in a little while. So what we do is that we provide insulin to these children at their homes with the condition that they visit their doctor once every 3 months or as required by the doctor. Now, this little child, Khadija, she passed away at the age of 2 months. She was born with a pancreatic malfunctioning pancreas and had other issues such as epilepsy associated as well. The place where this little girl lived was at a 2 hours hike from the nearest dispensary, which did not have any proper healthcare available. So it was like it is more like a makeshift clinic. This child required 1 unit of basal insulin each day, only 1 unit. And it was not available at the government hospitals. She passed away due to an epileptic fit when her family could not bring her down from the home to the nearest dispensary for medical care. So people may need to travel long distances without proper network to access care. And when we as diabetes organizations and as health professionals say that we're providing the care, we also need to think about how difficult it might be for anyone who requires this care to come to us and access it. And that is what we all need to join hands for, to make that access problem easier. So distances and long waiting times continue to be a huge access issue in Pakistan, especially in government and charity healthcare settings. Most of the government hospitals that provide this care and most of the charity healthcare settings are based in the main cities, which do have a catchment area, which do see people from the remote areas as well. But just imagine how difficult it is for a family to travel to get this support every month. So we looked at the ways of flipping the model. And I've just explained to you that we are providing it at their homes through cold chain maintained courier every month, with the requirement that they visit the consulting doctor once every 3 months, or if the doctor requires it to be earlier, they need to visit them earlier. Can we as advocates, my message to all of you is, can we think about flipping this model for every setting that has similar issues? Now, one of the requirements of our insulin support program is to attend school, because we believe that attending school is important for future productivity. Of course, this is only for those areas where schools are accessible and where children can actually feel safe at these schools. 22.8 million children in Pakistan aged 5 to 16 are not attending school as per UNICEF. Around 30% of the children who come to us for insulin support are out of school and are put back into school after they start acquiring the support. Some of them have left school because of health conditions. Some of them have left school because they were not feeling safe and were discriminated. But schools need to make safe spaces for children with type 1 diabetes. And we're still thinking of if digital awareness campaigns can help and trying to implement some as well. This is a huge area of work, and we really need, the world really needs to join hands for this to ensure that schools in the remote areas, those small schools where no proper education system is present, and when these children from remote areas, from the underprivileged backgrounds, they go there, they feel safe going to these schools with type 1 diabetes so they can lead productive lives later on. This is Abdullah, and Abdullah's future can be as bright as his smile. I love this child's smile. Why not? Why should we not think about this? Why should we only think about improving his HbA1c? Will improving the HbA1c alone really make a difference? We really need to think about quality of life. We really need to think about putting smiles back onto these children's faces. So one of the ways that we do it is through diabetes camps. And it is, as it is said, it doesn't get better than camp. These are fun-filled, hands-on learning for children and families where adults with type 1 diabetes take care of groups of children with type 1 diabetes. And this is modeled with support from Diabetes Education and Camping Association USA. Last time we had one for 2 days in a mountainous area, and there was a child who started crying at the end and said, "Why can't this be for 2 months?" This is the kind of support that they need. They really want to talk to others like their own. They really want to feel safe in a space where they're not judged for their blood sugar levels, for example, where they're not judged for their food choices, where they're not judged for anything, where they're respected and taken as humans with choices which may be right or wrong, and guided as per their acceptance level and their own way of thinking about how they should move ahead with improving their diabetes care. The power of social media is huge. Now, what we do is that these groups, of course, these camps cannot be held every other day. These camps cannot be accessed by everyone. So what we do is that we have made peer support accessible to anyone with an internet connection. Of course, there's still some gaps here where we need to see how to make this accessible for people who may not have smartphones or internet connections, who may not be using social media. However, for those who do, this takes diabetes self-management to the next level. It is monitored and led by volunteer community leaders who are adults living with type 1 diabetes. These are safe spaces for experience sharing and helping each other feel better, and also learn about managing diabetes better. There are very organic, open discussions on these groups, and people learn a lot. People, even when they're not talking themselves, even when they're not asking questions or responding to those, people learn a lot through these groups. And then, of course, when you are talking to a lot of people online, you also want to meet them. So in 3 big cities in Pakistan, we have the therapy days once a month. These are self-help support group sessions designed to change a person's perspective on life with diabetes. Every session is based on a certain topic, which is a topic selected by people from that city. And emotional well-being with a chronic condition like diabetes is supported using cognitive behavior therapy tools. And you know what? The community was the one that pushed us to start flood relief work. When floods came into Pakistan this summer, and these were horrific floods, the community members got down together, and they kept on requesting that we should do something for children with type 1 diabetes in these areas. And that's how we started our flood relief work. You can see this picture. You can see the child. He does not have proper shoes. He does not have a shirt to wear. And our teams, which are also based on a lot of volunteers from the community, are going from village to village, house to house, knocking doors, asking if there is a child they know with type 1 diabetes who might be needing insulin. And they're distributing this, the supplies, they're taking doctors along and doing all this amazing work in these areas in interior Sindh as well as in the south of Punjab. So here's the community. Here's the community, which is the first thing that's important when we talk about advocacy. The community rallying around insulin access, the community rallying around empowering education and peer support. They're co-creating the resources, they're co-creating the projects, they're co-governing them and co-executing for Great Lives with Diabetes, and also collecting and compiling data to build an advocacy framework in our setting, which is an experience-rich setting, but a data-less setting. So we're working on data collection to make sure that our advocacy is data-driven in the future. So thank you for listening. And if you're interested in discussing more, here's my email address. And I look forward to feedback on this talk and any other things that you want to discuss about. Thank you so much for having me.
A great thank you to Dr. Sana Ajmal. Lots to learn. We came to know so many challenges, the social, economical, environmental, human capital, political and infrastructure issues in Pakistan. Thank you so much for sharing everything. Now, let's go to Saireka. Saireka?
Hi, Bhimaka. I'm right here.
Yes. About Saireka. She's one of my favorite girls. She's a qualified lawyer and has lived with type 1 diabetes for the last 27 years. She co-founded Club 1 Diabetes, a patient support group in Pune with Dr. C.S. Yagnik and KEM Hospital Diabetes Unit in 2017. 2019, she co-founded the Type 1 Diabetes Foundation of India with other T1Ds.
One of them being you.
T1D of India is a unique pan-India inclusive platform for patient advocacy and bringing in change. She heads the Mumbai practice for Cohere Consultants, a practice that specializes in diversity, equity, and inclusions in Indian workplaces. She leads conversations on diabetes, NCD-related policy on various national and international platforms, and is a part of think tanks on the subject. And above all, she's a wonderful human being, and she's always there for type 1s. And over to you about our LMICs, what we face in India.
Thank you so much. I'll just quickly thank you for that very kind introduction. I'm just going to quickly share my screen, my PPT. Bhimaka, I'm going to just ask you if my screen is visible.
It's visible, dear.
All right. Thank you so much. So thank you, Mrs. Bhima Jan Yusuf, for that kind introduction. Thank you, RSSDI and Ispad, for giving this platform to us. Dr. Banshi has always been most kind in, bringing patient voices to the fore. So it's a privilege to be here. And thank you for giving me 10 minutes of your afternoon. So without much ado, let's jump right in. I take great pleasure and privilege to be speaking at this forum to August doctors and patient advocates and colleagues and, caregivers and survivors of type 1 diabetes. And this is such a unique opportunity for us to sort of explore together what is the India perspective. First of all, shout out to Zikiti and Sana, for their strong stories. The Indian story is very, very similar, I must say. All right, so let's quickly set context into what I would like to share with you today over the next 10 minutes or so. I know that, when I was asked to talk about advocacy and patient advocacy, and in 10 minutes, it felt like, this is the universe in a teacup, but I'm going to try. I would like maybe in the next 10 minutes or so to set context to patient advocacy in India, in terms of why is it relevant, what are our pressing issues. And then I would like to move on to sort of explore synergies. I mean, what can August doctors like you, how could we come together? Because one of the favorite sayings in my community is stronger together. And if you've met any person with diabetes in a diabetes community in India, whatever they call, we could be diabetes, blue circle, DIA, we could be JDF, but we all say we're stronger together. So I would like to take, the opportunity of using this platform to explore ways in which we could be stronger together. So let's dive right into it. So what you're looking at in your screen is a little bit of a context of a person with diabetes and, our life. Like, we're looking at it like a pizza chart or a pie chart, as you see. So at the center of it, the largest slice is self-awareness, the consciousness of living with type 1 diabetes. What does that mean for us? How do we self-regulate? How are we autonomous in managing a lifelong chronic medical condition, that requires a lot of cognitive decision-making in terms of meal dosing? You have to basically substitute for your pancreas. So there's that. And then we move on to the next layer where we're living with, families or somebody who we're in a romantic relationship with, an intimate relationship with. So when we're looking at that layer, we're looking at, of course, we're engaging constantly with a person, possibly a caregiver, who's living with our diabetes as well. And oftentimes there are a lot of codependencies in scenarios like this. It could be a financial codependency where that person pays for insulin, right? It could be a physical codependency where that person requires to be a part of, even the insulin giving process, or maybe helping out when there is an emergency like a DKA or a hypoglycemic episode, right? So there is the family layer or the relationship layer. Then we move on to the immediate social circle layer that we all live in, which is our friends, which could be our neighbors, peer groups. So peer support, peer pressure, all of this forms a huge section of the identity of living with diabetes. There is a whole perception created among our peers. So a lot of us are all right with identifying as diabetic. There is a very large volume of persons living with diabetes don't want to identify that they're a person living with diabetes. And a lot of that sort of hinges on the kind of circles we go on and their perception of diabetes. And then, things get a little more serious in the next layer, which is kids who go to school or college or workplaces when we're talking about teen adults. And here's where discrimination comes in. We're talking about kids who go to school, and at the very outset, and this is first, I'm taking the liberty to share voices and stories from the tons of diabetes communities. We all work together in India. We're a part of multiple WhatsApp groups. We swap stories. And I think today we have so many people who run communities in this call as well. We have Nupur from Blue Circle. We have my colleagues, Prashant, who are the huge patient points in India. So they will also tell you that the thing we hear from mothers is that, my kid is denied admission in school because, the school doesn't want to take responsibility for the fact that my child has T1D. Or we're talking about even post-admission pushback for children wearing their medical devices, whether it's a pump or a sensor. There was this huge row a couple of years ago where there was a school that actually asked a child to sort of disconnect their insulin pump. And, at the end of the 4-hour paper, the child went into DKA. So there are these kind of pushbacks in, schools as well. Then there is this whole row around, how and where is a child going to inject insulin, and how is that going to play out when there are other children in the school, hypo-management. And of course, in the workplace, the issues are, a little similar, but there are discriminations, associated with even employment, where people, once, they were to disclose the fact that they live with a condition like type 1 diabetes, a lot of workplaces have pushed back and not hired them. Then you have the whole issue of, once again, storing insulin in the workplace, taking insulin in the workplace, leaves regarding, personal health care, health insurance. So there are a lot of these subjects where, a place like school or work, finds its intersectionality for a person living with type 1 diabetes. And then, of course, there is a larger systemic issue where, we're all sort of citizens of a country and, we're all, dependent on the government for support. And then, therefore, we are, of course, having more universal issues like insulin pricing, access to medicine. We have access to technology, right? And then again, there is recognition that the community is fighting for to be recognized as a disability, tax breaks. So the list is endless. But this is why, if you're looking at this whole pizza chart, these are the contexts from where, the core causes of advocacy have actually stemmed from. Allow me to say that it's very ironical that this is a pizza chart, because pizza, of course, is the most difficult food group for a diabetic to bolus for. Am I right? So therefore, we sort of move on to why awareness in T1D has become so central, right? Looking at the whole pie structure of how we integrate into society, some of the largest issues that, groups discovered, or groups of diabetes, people living with diabetes discovered in India, was isolation. I think isolation was the reason why most groups somewhere around early 2016 or 17 were born. In fact, I've lived with type 1 diabetes for 27 years, but I didn't know any other group apart from JDF, and kudos for that, JDF in Bombay, that actually, worked with other people, with T1s. They had programs for T1s, nada. Which is why I think around early 17, we were one of the first people who banded together to create a patient support group. Those days, Nupur also helped out with the whole KEM story, and we started Club 1 Diabetes. Of course, she moved on to create Blue Circle. Jazz started Diabesties around the same time, 17, 18. Apurva, Jyotsna, Sahil, and a bunch of others started something called Dia in Delhi. Mridula started T1D Fighters. So there were a lot of groups born around the same time, which was sort of triggered by isolation. There was an immediate need to know other people living with the condition. It was a need to go and make friends, to sort of have another person to relate to. And what we found out, since then and now, is that isolation, while it sort of provided a lower motivation to self-care, being in a community, being in a group, looking at other people who looked like you, lived like you, sounded like you, ironically increased motivation for self-care, which is why today we have so many vast groups, patient-created groups, support groups in India that are created both for persons living with diabetes and their caregivers. All right. Then we moved on to other subjects that we heard from each other about social stigma. And a large voice that we heard was, of course, from kids who were afraid of being bullied by other kids, parents who were sort of suffering, in the school authorities. We also heard from young people who were being discriminated against in the arranged marriage system. So again, the community stepped in. We have an initiative in South of India. You can probably come back and look at our website later. There is a wonderful community. Sweet Soul started this initiative where they wanted to create a group for arranged marriage alliances for persons with, type 1 diabetes. There's a T1D matrimony system available. I'm aware that JDF does something similar as well. We also have multiple groups. It doesn't matter who the group is, but I know all groups in India do this, where there's a mother who, voices out saying that there's trouble. Somebody from the group who's qualified will step into liaison with school authorities. So this is how social stigma is managed. Discrimination in schools and workplaces. Of course, with workplaces, it's a more sophisticated conversation. So we talk to various employers to see if they can roll out policies, and I do that for a living. So we call it DEI, diversity, equity, and inclusion in corporate packages. So we try to talk to corporates to include T1D in the diversity inclusion initiative, so that insurance is included. But this is, of course, a pebble in the sea, a rock in the sea. Then we look at persons, living with type 1 diabetes, living in isolation, feeling different from others, feeling stigmatized a little bit. And we often see, lowered self-esteem in people. And with the pandemic, we've seen a skyrocket of mental health issues in the pandemic. Then, of course, there is this thing that is so less talked about, which is that a person living with diabetes is in a constant state of anxiety. We have these constant cognitive burdens of, dose decision, what is my sugar every 5 minutes? Do I need to correct my sugar, staying in range? There is a constant cognitive burden that just comes with diabetes management. And invariably, we all burn out. Okay. And then, of course, there is a larger piece that adds to the anxiety. And I speak from personal experience when I say that there is a very real fear of mortality in all of us. And then, of course, there are systemic challenges like Sana beautifully pointed out and CKT beautifully pointed out, which concern access to healthcare. The experience of living in a Bombay with diabetes or Bangalore with diabetes is so different from somebody who lives in Tirunelveli, someone who lives in Madurai, someone who lives in a small place called Sarchi in Himachal, who has to drive for 8 hours to Chandigarh to buy insulin. right? So access to healthcare today is a huge challenge in India. And even if we do have access to healthcare, the costs of healthcare are absolutely crazy, considering, we don't have any public support, we don't have any governmental subsidies. Of course, that's a more sophisticated conversation. I mean, in 16, we had zero government support. In 22, of course, with a lot of rallying from patient groups, governments have started including certain kinds of insulin and DPCO. We have a lot of free government schemes. But again, there is a huge ground to cover there as far as the India story is concerned. Quick segue into a little something that, we put together at the T1D Foundation. We looked at so many voices that were rallying together, and we thought everybody has to join the voice. So somewhere in the pandemic, and T1DS has a lot of techies with us. We have IITians who sort of work at the foundation. So we put together something called a Community Finder tool. It's there on our website. The link is what you're looking at your screen. This is a really simple tool. If you go, but let's say you're in Pune, then it would show you Blue Circle. If you're in Ahmedabad, it would show you Jai Besties. If you're in Bhavnagar, it would show you JDF Bhavnagar. If you're in Chhattisgarh, it would show you the T1D group in Chhattisgarh. So that's what we did as, when we put together this tool. What it simply does is that it lists patients and caregiver groups all over India. Okay. So there is a pin option and there is a drop down option. You never have to be left behind. You never have to know who is your nearest voice. You just have to get onto a site and you'll find who is the nearest group. The tool contains name and contact details, of each group, the person who's in charge, so that, they will integrate you into their groups. It sets out their social media handles for you to follow and know what's the nearest event going on near you. It's completely free, obviously, because, it's for the community, it's by the community, and it's easy to access. So in this kind of a backdrop, patient advocacy in India has grown, where you have all of these wonderful groups. And every group I know today is striving very, very hard. And I speak from personal experience. They go to camps, they sort of participate in insulin distribution schemes. They educate on the ground. Like, especially I see pictures every day from various groups, whether it's, Jazz doing work in Gujarat, whether it's Sweet Souls, Lakshmi and all in Hyderabad, where they go and speak in schools. I know for a fact that Prashant just came from a huge road trip in the south, where he was sort of talking to people in Kerala, parents in Kerala. I know Udan does a lot of work, in Maharashtra. So there are so many of these patient groups that are already doing such fantastic work. How can you fit in? I know you're a doctor and, you are our first point of contact. We come to you, because oftentimes we may not know each other, but we definitely know you. So how can you, a doctor who's watching this content, make this better for us? I would say that you do use our community finder, and please participate in a community if you're not already doing one. I cannot say this in the same breath, because a lot of our communities were built with the blessings of our doctors. I know for a fact that the first community, T1D, was set up with the help in Pune at Club 1 was with Dr. Yajnik. Dr. Banshi is such a huge patient voice today. A lot of patient leaders, so to speak, in India today were all like founded on his platform. Like, he made this whole Wild AI thing, and he's always given us forums to speak, and he's been a part of our growth story. Dr. Archana has always been very, very supportive. Dr. Mohan has always reached out. There are a lot of doctors, and of course we have grown on your shoulders. But I think all hands on the deck is what the community needs right now. Participate in a community. If there's none around you, foster a community. If there's a small community, if there's none, create a community. All right. Do encourage your parents, in fact, to even set up a community. Again, no rocket science. You can come to our website. We're all about community creation. We do have a program where we foster little communities. We give them the tools. Again, it's completely, open source to set up communities. What you can do is you can help create relationships for your patients. For example, all of us, we need insulin. We need some of us who wear a CGM, we need Libres, we need strips, right? And we don't know how to go about it. We don't have, the means to have an affordable way to do this. And some of us can't even afford insulin. So you can forge these relationships for us. You can sort of set up an ecosystem where, we can access healthcare products and, healthcare facilities in an affordable way. I would request doctors here to also look at, even private community kind of a situation. Start your own community within your patient cohort where you do knowledge sharing routinely with your patients over VCs. Talk to them about, insulin therapy, how to use this, how to use that. whether a CGM makes sense, how to read their graphs, so on and so forth. Join your patients for their events, especially if they're a part of a community. Every city today I know has a run, right, where T1Ds are running every month. So join them for these events, all right? But most importantly, here's where you can really make an impact, okay? You can create opportunities for representation. I know a lot of you are sitting on boards where you take decisions that impact patients on the ground. Allow a patient voice to be on that board, okay? Call one of us, let's have a partnership between a doctor and a patient to create opportunities for these representations. Allow a voice on these forums. All right. Relook at the impact of your T1D programs. I know all of you are rolling out, so many of you are rolling out, schemes where you're distributing insulin for patients. Maybe you could relook at the impact of your schemes to see who more could you include, who else would benefit. All right. Like, is it really reaching it? How is it doing it on the ground? And maybe you could engage some of us to be your eyes and ears for that sort of thing. All right. But I guess the bottom line is that the need for Indian communities today, irrespective of what we're called, is to join hands with you to bring legitimacy to our cause. Another important way where you could actually do that is that today there is a lot of public advocacy that's going on for diabetes, where we're talking to the regulator, we're making constant representations on various subjects, whether it's insulin costing, whether it's access to insulin. In 2016, the regulator didn't even know the difference between type 1 and type 2 diabetes. We've come thus far where now the regulator is asking us, oh, I gave you a glargine in DPCO, why is that not enough? Okay, so in these kind of conversations is where you come in, bring in legitimacy to our cause. Maybe be the liaison between the government and the patient voice to see what is the need of the hour, what is the pulse of the hour, why does the community really need what it needs? So join us, because like we say in the community, together we're stronger. And while I sign off, fun fact, I was just speaking of events. Next month for the Type 1 Diabetes Foundation is a huge event in Chennai. The Chennai Marathon is sort of dedicating their event to us. So yeah, that's happening on the 8th of December. So if you're in and around Chennai, run for diabetes, just not from it. And all of you are welcome to join that. So that's that. What you're looking at are the faces of my wonderful team at T1DS India. We're a platform. We are also a part of multiple ground communities, but our main aim, we exist, is to be a part of meaningful conversations like this and to advocate, for diabetes policy at a national level. With that, we're at time, and I give the baton back to Bhimaka. Thank you for having us.
Beautiful, beautiful, Saireka. Should I call you Saireka, Suresh? Yeah. Is there any question? It is just for Chenda is here, Saireka is here. Is there any question? Of course, like as I said, the social, economical, political, and of course, all our infrastructure, there are so many challenges. We have come very far. And first was JDF. I think the next we started young people with diabetes in 1993. And we are around 300 people. We were around 300 people, but 30 of us are still, we keep in touch, and we still do advocacy work in our own way. Those days we were not able to connect like Facebook or social media was not there. But we still connect as individuals, So this advocacy work is really, really very much, it has taken a different path, different perspective as well. Like from, as Saireka said, from 1990, 2016, nobody knew not many knew about type 1 and type 2. But today, when we talk about this awareness, type 1 awareness all over the world, it is amazing. It is very, everyone who works on this thing, they are very dear to our hearts. When we can live a fantastic life with type 1 diabetes, everyone can.
I have a small suggestion to Saireka. Can I ask?
Yes, sure, doctor.
So, Saireka, we can definitely join with you for beyond blood sugars, number one. beyond blood sugars and beyond glucose, there are so many things in lifestyle. And through your advocacy group, we can share very simple knowledge slides, and the message can go deep and wider. And I invite you to join our NDP program so that you will be the qualified CDE for the same. So that was the only thing. Thank you.
Thank you, sir.
What is NDP program? NDP?
It is a National Diabetes Education Program all over the India. And we welcome everybody to join now because we have online also.
Okay, thank you. Thank you for the information. Yeah. That was fantastic. Anybody, any questions? I can't see anyone on the chat. It looks like they're all overwhelmed with our information. It looks like nobody knew we were doing such vast work.
Probably, ma'am, things have been well explained. That's why probably people do not have a question. So we would like to carry forward. I thank all the dignitaries, and I especially thank the moderator, Mrs. Bimajan Yusuf. Thank you. Thank you for such a wonderful presentation. And next, we move on to the next session. And I would like to introduce the chairpersons for the next session. And those are Mr. Prashant Mani. He was diagnosed with type 1 diabetes in 1998. Is the founder and president of Tamil Nadu Type 1 Diabetes Foundation. And Ms. Jaz Sethi, she is the founder and director of Diabetes Foundation. She is the IDF's Young Leader of Diabetes for Southeast Asia for 2019 to 2022, term representing India. Over to you, dignitaries, chairpersons.
Thank you so much, and a very good evening, good afternoon to everyone. Lovely session before this as well, and very happy to be here with my co-chair Prashant, and we've got some really excellent talks lined up in the next hour and a half, and it's a kind of a mixed bag session, so to say, of talks and topics, but we will be covering type 1 diabetes, how to use new kinds of apps and technology for the same, as well as looking at diet. So Prashant, I think we are running a little late. So would you like to introduce the first speaker, please?
Yes, of course. A good Sunday afternoon for most of them. And it's been a long session, but a wonderful session from the morning. So the next speaker, I'll just get on to the next speaker. Nupur Lalwani. I think most of them are familiar with her on various forums and talks. She's the founder director of Blue Circle Diabetes Foundation, an NGO supporting people with all kinds of diabetes. And she herself is a person living with type 1 diabetes since the last 26 years. She's a certified diabetes educator and a pump trainer. She runs marathons and led India's first team, which completed 100 kilometer at Oxfam Trail Walker. Yes, over to you, Nupur. All of this. Looking forward to your talk and learning from most of them. More than a chairperson, I think I'm the student here. Yes, please go on.
Thank you, Prashant, and nice to see all my buddies here. Thanks, Prashant and Jaz, for their introduction. Hi, Said, and everyone. Lovely, lovely talks, everybody. So my name is Nupur, like Prashant said, and I'd like to thank the organizing committee once again for this wonderful Best of Ispad, and particularly Dr. Banshi Sabu for this platform today. So I'm going to share my screen now. Just give me a moment.
Hello.
Yes. All right. I believe my screen is visible, and so am I. So I'm going to talk to you today about the use of mobile applications for diabetes care. And I'm going to talk to you about an app that we developed called the Blue Circle Diabetes app. So I think in this day and age of technology and smartphones and mobile apps, it's only fitting that people with diabetes also use technology effectively to manage their day-to-day living with the condition. And about a little over 2 years ago, we got a focus group together. We said, we got a bunch of T1Ds together, and we said, let's talk about what an app should look like for us in the Indian context. There are multiple apps. We've all used them over the years, and slowly this is how the Blue Circle Diabetes mobile app came about in early 2020. So it's an app made by people with diabetes and for people with diabetes. And while we initially started out, looking to sort of create something for people living in India, we quickly realized that people around the world were using it as well. And I'll tell you more about that later. But so now on the screen, what you see are two snapshots. The first one on the left is the home screen of the app, where you can see the current blood sugar, you can see the estimated A1C over different durations in time. And you can see that the app allows you to log very easily on the home screen itself. It allows you to log your blood sugar. So there are multiple ways to log your blood sugar. One, of course, is good old glucometer, which we all have used. And then, of course, you can also sync your CGM along with the app and certain third-party apps. Apart from blood glucose, you can also enter your meals and snacks, your exercise for the day, and your insulin, which is segregated by bolus and basal. And we're also keeping in mind that there are people, whether it's for reasons of accessibility or affordability, that still use mixed insulin. So we've kept that as an option as well. So that's what the home screen looks like. And like you can see on the top of the screen, the app now has 39 million blood glucose related records. So that's a lot of input. And I think the more input, the better, because, diabetes is such a data-driven condition, right? Until you log your blood sugars down, until you write it down, until you study it, until you analyze it, until you take it to your doctor and discuss it with them, you can't really make sense of all of these data points, and you can't really join the dots. So the goal here is to fill the gaps in education and management, self-management. And you can see on the screen, there are a bunch of features. So not everything came together at the same time. We took our time. We took all your feedback. People can write to us and tell us what they'd like to see in the app, and we put it in as and when possible. So the next screenshot that you see on the right, which is next to the home screen, is a screenshot of the food which has been entered. So you see a photograph of some sauteed vegetables here, stir-fried vegetables. And what's pretty interesting is that a lot of us are visual learners, right? So you can see on the screen that my blood sugars before eating this was 72, and 2 hours after eating it were 100. Now, this is where, AI and apps and technology come into use. This is where we don't have to sit and manually, track. I mean, I'm on a CGM and have been for a while, and there's a lot of data points. So to be able to pick out what was my pre and post, what was my macros. So you can see down below, it mentions 10 carbs, 15 grams of protein, so on and so forth. And there's also a facility where you can share this with the community and, motivate others like you to stay on track as well. Another thing I want to point out is that on the top right of the screen, you'll see a post-meal reminder. This I find particularly useful because all of us have busy lives. It gets really hard to sometimes remember to even scan. I remember hearing a talk yesterday, by one of the esteemed doctors, where they mentioned that it's not good enough to just put a CGM. You also have to scan it, right? So even if you're using a pump or whatever technology you're using, testing your blood sugars is very vital. So what you see on the screen now is a snapshot of the reports. This is, something that we created just as a template to show you this is not a real person. But this is what the reports typically look like. The green bars are the time in range, and the ochre is out of range, and of course the red ones are hypoglycemia. And it also shows you in those three little neat circles on the top. You can also share your food that you've eaten. You can share it with the community, or you can share it for your own record and analysis. So you can mention what you've eaten. In this case, what has been eaten has been very interesting looking papaya salad with beans and tomatoes. Sounds like quite a delight. And the pre and post meal readings, which, by the way, automatically get picked up if you're on a CGM. So if you're using a CGM, and if the CGM syncs with the Blue Circle Diabetes app through certain third-party apps, then you don't even need to enter this manually. This gets picked up automatically. I think one of the important things about diabetes technology, and one of the brilliant things really, is that how it makes our lives easier. We all use some or the other technology in our lives with respect to diabetes or without. And I think the goal really is to be able to make life of people living with diabetes much easier than it currently is. So what you see on the screen now is a quick, bolus, is a quick calculator where you can sort of calculate your insulin to carb ratio and your insulin sensitivity factor. Now, a couple of years ago, we were not familiar with these terms. We've come a long way since then. And if you are bad at mathematics like I am, I think, you'll find this incredibly useful. So this is something that you can encourage people living with diabetes to use. They need to enter in their total daily dose, of course, and this in no way replaces medical advice. It's simply a tool that is meant to be able to support people with diabetes to calculate their ICR and ISF quickly. We also have something called the nutritional information in the app, where users can click on the menu on the left hand side that you can see in the second snapshot here, and they can click on nutritional info and type in the names of food that they are looking for. So if you type in chicken, or if you type in cauliflower, it will throw up a bunch of values for you. So you don't need to remember, you don't need to carry a physical, paper or anything with you. You have it all on your fingertips. You have it on the mobile app, and that's what makes it super easy and super convenient. So at the beginning of my presentation, I was mentioning that, when we started out, our goal was primarily because we are based in India, and I think we understand the Indian landscape fairly well. The goal was to be able to be of service to people that are living in India, people with diabetes. But soon we realized that there were a lot of folks, from Europe and from different countries across different continents that were using this app as well. And that was a sweet surprise for us. We had a lot of requests coming in where people wanted us to also show, the blood glucose in mmol. As we all know, in India, we use mgdl. So we added in this feature a little bit later after we made the app, but now the app is accessible in mmol as well. So if you are in certain parts of the world that uses this metric, this way of measurement, then you'll be happy to know that this works. The other screenshot on my screen on the right hand side is something very interesting, and I think it's probably one of my favorite features of the Blue Circle Diabetes app. There's something called a follow feature. And I really wish this existed back when I was in school. My parents would have really felt at ease and felt relief knowing that the child is okay and that they can see my blood sugars remotely without having to visit the school or without having to call the principal. And mind you, back in the day, maybe I'm a bit of a dinosaur, but there were obviously no mobile phones, when we were in school. So if my parents wanted to check on me, they would have to then call the landline in the school, call the principal, who would then check with the teacher, and then, come back down. And the circle, was long and tedious, and it just there are better and easier ways to do this. So, for all the healthcare professionals that are watching, you're very welcome to share this with your patients, and parents and caregivers can track remotely the blood sugars of their T1, and we have an extensive blog on how to do it, and I'm more than happy to explain to anyone who would like to understand better. But in interest of time, I'm going to move on. I want to also quickly mention the Buddy Project helpline, and why I'm mentioning a helpline in a talk where I'm supposed to be talking about a mobile application. Well, I'm mentioning this because the helpline is on the app. So the helpline is one of the features of the Blue Circle Diabetes app. And what's pretty unique is that this helpline, you see 10 smiling faces there. There are people living with various types of diabetes, including caregivers. And these people have been trained in not just the basics of diabetes, of course, of which they have lived experience as well. And some of them even, over 40 years of individual lived experience of diabetes, but also psychosocial support. And they've been trained by a team of psychiatrists as well to support friends and peers living with diabetes. And we do get a large percentage of our calls from families who have people living with T1D. So this is a multilingual app. We recognize that there's a huge language challenge in India. It's not just English or Hindi. It's an array of different languages. So 10 people here speak 7 to 8 different languages and are trained folks. And mind you, the app is completely free. All of these people here, the buddies here are volunteers on the helpline. So they take out time from their busy schedules, and because they have a strong passion. And I think passion is the word of the day. I've been hearing it since the morning, and I'm just another one of all of you that is going to reiterate that all of these people have a passion to give back to the community, and it's a peer support helpline where not just the T1 but also family members can call and speak to somebody about diabetes, because sometimes all you want is to be able to vent, share. You may be frustrated, you may be anxious, and you need a safe and non-judgmental space. So you can see that, we have partnered with the Center for Mental Health, Law and Policy and the Chelaram Diabetes Institute to train our buddies. And these are just a couple of the buddies here. And how it works is that people reach out through the mobile app. They schedule a call with the buddy that they pick. So that's how it works. How to schedule a call is also very simple. 3 steps. Open the app, click on Buddy Project, which is the helpline. Second thing, you go on to schedule, the tab called schedule, and you can actually read through in English and Hindi, the short biography.
Last minute, please.
Thanks, Jazz. You can also read through the short biographies of all the buddies on the app, and then you can schedule a call this way. And to join, you just need to press join. So as you can see, a combination of community and technology is brilliant for people who want to be able to self-manage their diabetes. There are also reminders to log into your call because, of course, you can forget. So with this, I'm wrapping up, and this is just a simulation. This is just shared as an example. This is what a call looks like. It can be only audio or audio and video. Thank you once again for your patience and for listening to me. And it's been a pleasure. Over to you, Jazz.
Amazing, amazing. Thank you so much, Nupur. And I think what you've created is quite spectacular, and it requires a lot. And what I really like about it also is the fact that it's such a user-centric design, because it's made from people who have lived experience. So the nitty-gritties of what I keep talking about DIY loop is because it's made by the people who live with it. And the same way this app is made. Just one question off the top of my head was that, is the app itself in multiple languages, or is that something in the pipeline?
That's in the pipeline, but currently it's just the helpline that's accessible in multiple languages.
Right. But I'm sure you have plans to make the entire app in Hindi and stuff like that so that more people can use it. Yes. Brilliant. And everyone watching, please do check out the app. It's quite amazing. And congratulations on the 39 million sugar checks that have come in. That's a huge milestone. And I think it's just onwards and upwards from there. Prashant, any other questions from your end, or we can move ahead to the next and take questions at the end as well?
Yeah, I think we'll go to the questions at the end because there are a lot of other speakers, and I think others will also have a lot of questions. Yes. So next we have Mridula. So Mridula is another figure very well known in T1 community, especially among kids. So I know personally that she does a lot of activities with kids. And coming to the introduction, she's a public health professional from Hebrew University, Israel 2018. And she has been living with type 1 diabetes for 30 years and is a certified diabetes educator. She has work experience for over 10 years in healthcare and public health consultation. She's also the founder of Diabetes Fighters Trust. I think most of them know that she operates from Delhi. And also she organizes amazing, comprehensive, large-scale forums to include a lot of stakeholders, policymakers, people with living experience, and doctors. So that is something that we all appreciate Mridula has been doing, because it takes a lot of effort in bringing in people together and doing that. So congratulations, Mridula. And yes, over to your presentation.
Thank you so much, Prashant, for the lovely introduction. And I love my diabetes community, T1D fighters community. I'll just share my screen and let me know if it's visible. Is it?
It is now.
Okay. So, hello, everyone. When I was in school, because my topic is diabetes in school, and I have to talk about it, I realized very early, like in very early days of my schooling, that you get popular at the school time when you can do something that others can't. And so I would boast about injecting myself and pricking in front of my friends, and would show off my knowledge in the science of type 1 diabetes that I live with. And I didn't feel that something like a challenge in the school premises and the workplace can ever be a concern, because I never had realized that until when I flipped the coin, or let's say flip the slide. I realized that there have been so many issues in the news, in the community itself, and so many people coming up to me saying that there has been discrimination against my child. They're not letting my child in the school. These are some of the headlines of the news, digital news, or the comments from the community itself. So one case that was revealed was the occurrence of type 1 diabetes in both the siblings, and distressed parents had to stop sending their children to school due to the level of discrimination and constant bullying, that too in Delhi NCR itself. And this was the turning point for me. I had this in mind, that something has to be done around the challenges that a child is facing in their schools. So we did some formal and informal interviews, and we discussed with the parents, with the communities, and found out that
तो सबसे पहले यही चैलेंज था हमारे लिए कि नंदनी को अब स्कूल कैसे भेजें हम, क्योंकि स्कूल में तो कोई डायबिटीज के बारे में जानते थे इसके टीचर वगैरह, मगर टाइप 1 डायबिटीज के बारे में कोई जानता ही नहीं था। तो काफी डर था हमारे। फिर चैलेंज ये था हमारे संग में कि नंदनी अब इंसुलिन कैसे लेगी स्कूल में। फिर डर ये भी था कि नंदनी अब चेक कैसे करेगी, क्योंकि डॉक्टर ने तो उस समय बोला हुआ था कि आपको इस टाइम पे चेक करना है, इस टाइम पे अपनी डायबिटीज चेक करनी है, इस टाइम पे डायबिटीज चेक करनी है। फिर डर ये भी था कि नंदनी किसी बच्चे के संग में कोई टॉफी या चॉकलेट, क्योंकि छोटी थी वो उस समय पे, कोई शेयर ना कर ले, कुछ खाना ले, ऐसी चीज जिससे उसकी डायबिटीज बढ़ जाए। ये भी डर लगता रहता था कि कहीं कोई ऐसी चोट वगैरह ना लग जाए जो ज्यादा गंभीर हो जाए, क्योंकि डायबिटीज में डॉक्टर वगैरह हम तो जानते नहीं थे पहले, डॉक्टर वगैरह कहते थे कोई चोट वगैरह ऐसी ना लगे इसे। फिर डर मैडम ये भी लगता था कि बच्चा अभी छोटा है, ये अगर इसकी डायबिटीज लो में चली गई तो वो कैसे हैंडल कर?
I could have presented like lots of data, research work and all, but I felt that these stories had to be shared. These stories are needed to be in the forefront on the platform to reach out to as many people, and so a collaborative action can be taken towards the challenges and discrimination against children, and of course even adults at the workplace. So the big question is,
Mridula, sorry, we can only see your first slide till now.
Oh, is it?
Yeah.
But could you hear that?
We could hear the audio, yes, but I just want to just let you know that we're only seeing the first slide right now. Prashant, are you also seeing the first slide, or is it just me?
Yes. Actually, I think she should be sharing the window, then sharing the. I think it's just the tab that's being shared.
Okay. Let me just.
And yeah. So before she picks up some things, I'll just translate what was said in Hindi. Because I'm sure that there are people, international audience as well. So it was an audio of a T1 caregiver talking about the difficulties a child is having in school. How does she take insulin shots at school? How does she monitor her sugar? And her hypo snacks shouldn't be shared with the other children because she needs that the most. So these were the difficulties what Mridula was talking about and the caregiver shared.
Presence.
It's okay now.
Yes, now it's good. Okay. I'm so sorry. I didn't realize that. Yeah. So does India have any laws around safe accommodation in the schools and workplace? This was the question that just, was on top of my mind, and even on, in the community's mind, that why don't we have any policies, or do we have any policies that we don't know about? And the answer was no. Unfortunately, we don't have any policies. Of course, it's a right. Any child in going to any school, they cannot be discriminated. It comes in general in the Disability Act, and also in general that every child has the right to education and right to safe accommodation inside the schools. But for a child living with type 1 diabetes, the whole scenario changes. And one action that I still remember was taken by Dr. Ashok Jenkins, sir, under whom I did some work. And he actually announced, or actually advocated, that every child going for board exams and during the exams time in schools or outside must have a snack with them, so that in case of low blood sugar levels, they can go and eat, or they can, on their seats, they can have their snack and prevent low blood sugar levels. But I also realized that in other countries, there are well-established laws, and even American Diabetes Disabilities Act has been implemented by American Diabetes Association, which actually prohibits most schools from discriminating against children with diabetes. I want to again come to another story of a child who is actually trying to express the emotional trauma that she has gone through. And I'll definitely translate it into English as well.
स्टार्टिंग ये तो क्लास में और दी ये सब बहुत जो मैंने फेस किया है और दी हमने अपने ग्रेजुएशन का मैम देखी ना तो मुझे तो ये भी बोल दिया था कि आपको बीमारी है ना तो आप वाइट यूनिफॉर्म में आना, एक अलग यूनिफॉर्म में। और यहाँ पे पता है कोई एंडोक्रिनोलॉजिस्ट भी नहीं था और वो लोग कह रहे थे और फिजिशियन लोग मना कर रहे थे कि हम नहीं लिख सकते और कुछ, तो मुझे दिल्ली से ही अपना लिखवाना पड़ा था लेटर। और दीदी क्लास टॉप, दीदी सब लोग मुझे मतलब रुला देते बात करते थे ना, बहुत मैं इमोशनल हो जाती थी।
So this child, who is just 11 years old, and she expressed herself and said that she got really emotional. She doesn't live in an urban area, And she said that when we talked about my type 1 diabetes in the school staff said that yes, she can come, and they actually told everything about type 1 diabetes, how to manage that and all in case of low blood sugar levels or high blood sugar levels. But they actually asked the child to wear a white uniform which was separate from every other child, and making it visible for for everyone to understand that okay, she is different, she has some problem, some issue, and that's why she is in that kind of uniform. For a child, this can only be called as a trauma, because that child would never like to be differentiated from others, and of course when it's visible also. Another point that she mentioned was in her area, no doctor was ready to write a letter to the school that she has this problem and this can be managed in this way. And then she had to come to Delhi, all the way from Rajasthan to Delhi, and to get that letter from a doctor that she can manage her diabetes. The only thing is, in case of an emergency, these all steps have to be followed. And the last point that she mentions is that she felt like crying all the time. No person living with diabetes wants to be sympathized. They want to be empathized. They want that their problems to be understood, and they can actually take care of it. It's just that anyone can land up into a challenging situation, but for a person living with type 1 diabetes, and especially a child, it becomes really emotional and can even lead to diabetes burnout and distress. So I also researched and found out that the only study being done on the Indian population is from Dr. Anju Virmani ma'am, and this study actually understands some of the aspects of self-care in urban schools, including institutional attitudes and availability of support and the challenges around it. But there's still so much to be done. There are so many schools to be reached out, because there might be facilities available in the private schools, in the schools with better infrastructure, but in government schools, and even also in private other schools which might not be able to take care of every single child, we need to reach out, and also to understand not just the caregivers and children's perspective, but also the perspective of the authorities and the schools. And this is the last story which actually totally moved me. This child was going to the school for the first time after COVID, and very excited, and she was already packed up with new bag and pencil box and everything. But her mother found it really difficult to convince the school staff, even when the application and every detail was submitted inside the school, one of the reputed schools in Delhi. And when she mentioned, when, as you can see, I've highlighted this second comment. She was very excited on the first day, but she's a strong girl and she didn't react to it. I'm very concerned about this statement, because child who is just 9 or 10 years old and is not able to express what they're feeling is because their emotional intellect has not been developed yet. And this is a matter of concern, because this is definitely going to restrict that child from every other thing in the school. The child might feel low, the child might feel inferior, and might not even perform well in the studies or in other co-curricular activities. And so we thought, why not bring in some of the experts, healthcare experts together, and the community together at one single platform. And what we did was we divided them into different groups with 1 or 2 healthcare professionals per group, and we asked them to discuss on the challenges as well as the solutions which has been missed out from one group can be understood through the presentation. And on the bottom right, you see all the points that have been captured by the group, one of the groups. And through the Women Lift Health Fellowship, I decided to take this whole initiative further by the name called Schooled Project, which is diabetes education and empowerment in schools, where we are going to bring in all the teachers and students together and educate them in a very innovative way, because it's in the development stage. I won't be able to talk about it much at this particular time, but definitely by the end of March, we'll be completing every single detail about this project, the proposal, and what you see on the right is already the theory of change that we have for the project, and hope that something concrete can come out. Story. I want to end it with a story. This picture is from outside the school of this child whose anonymity has been maintained, and we discussed everything with the school staff members. School principal himself was type 2 person living with diabetes, and we discussed that sound. So we discussed it with different authorities, teachers, staffs, and everyone. And the teachers and the authorities have confirmed that we'll be conducting the program, school program, in their school very soon, and with a very structured way. Yeah, I'll stop here. Thank you so much, and looking forward to any questions to be answered. Thank you so much.
The work you do, and with such sort of consistency and detail, and all the best for the Schooled project. And you, of course, the entire community here will like to contribute in any way we can, and I'm sure there are questions, but we will take them at the end, just in a matter of time. So Prashant, over to you.
Yes, and actually, even any questions, I think it can be posted in the chat box as well, so that more people will read and respond. Yes, so we move on to the next speaker, Ms. Salma Meher, and that's a quite long list I have to read out here. So I think people.
I would just skip it. I would just skip it if I was.
No. Actually,
Salma Meher is more than enough.
No, I know that you like to skip it, but people would like to know more about yourself and what you've been done. Maybe you can give a brief presentation of yourself and
I think that might be more interesting than you reading.
Yes.
So
Yes,
when you're
please.
ready, I'm happy to start.
Yes, please do.
So I'm just going to share my screen and give a very quick introduction about myself, not to bore you all. Just share my screen. Okay, so first of all, I'd like to thank this organization from the bottom of my heart to invite me here today. I am hugely honored to be here. It's quite a surprise to be in a new faculty. But my background is I'm Salma. I'm a dietitian. I'm a South Asian background. I have worked in the South Asian communities living with diabetes for over 20 years now. My passion is to address health inequalities particularly amongst diverse communities where language and literacy challenges exist. And I've worked with a number of organizations trying to address some of these health inequalities in the UK. As you know, UK is a very diverse country, their first language. So I'm going to talk very briefly today about this debate which has been arising in the last couple of Ispad conferences around low carb versus very low carb, and the use of this particular diet in children with type 1 diabetes. I will confess that my expertise is very much developing resources for children and adults living with diabetes. So I would like to share some of the resources that we have developed with the organizations today so that you can also learn and benefit from what we have used in order to address some of the challenges faced in dietary assessments with this cohort of community. I have no disclosures at all. So I'm just going to start off with giving you a brief sort of introduction in dietary therapy with children living with type 1 diabetes. So before we even talk about whether we should be advocating low carb, very low carb, it's really important to understand the child and the importance of nutrition before we even discuss whether they should be following a particular type of diet. So the fundamental laws of having a balanced diet, making sure that we understand the individual's cultural preferences and also their literacy knowledge as well. Apart from that, whether they actually have access to food or not. And then as clinicians, we are experts in focusing matching insulin with the meal composition that that individual is going to eat. But we know when we are in consultation that it is a multifactorial approach, not just the individual nutrition, but we've got to think about the environment. We've got to understand the patient's individual society, where they come from, how they live. So as a dietitian, we are challenged with a multifactorial approach when we talk about individual nutrition. So just to talk about very low carb or very low calorie with an individual can be quite challenging for dietitians. So why has this diet sparked all of a sudden around low carbohydrates? So as you know, there's a lot of media attention, a lot of social media attention, and a lot of internet attention around low carbohydrate diets in amongst both type 1 and the type 2 community, but more so amongst children nowadays living with type 1 diabetes. There's a lot of forums out there. There's a lot of platforms where young people will go and talk about their experiences of insulin-friendly food, low Apart from the internet and the media interest in low carbohydrate diet, we know that there is a growing pandemic of obesity, here in pediatric endocrinology, which looks at the various trials in type 1 diabetes and the level of obesity amongst these children. And what we can see is that there is a growing rise and concern in the type 1 community with young people, where there is a greater prevalence of obesity, which we would not have seen many years ago. The other concern we have with children and families is the variability in postprandial glycemia. And we often find the challenges that when people are having large amounts of carbohydrates or they're consuming predominantly carbohydrates in their meals, they often struggle to manage this and not quite understand why this is happening, even if they are carb counting or they know exactly how much carbohydrate they're eating. But we know from evidence that large carbohydrate consumption can lead to huge variability in postprandial glycemia. And apart from carbohydrate, there's also the fat and the protein intake that we need to take into consideration as well. But as a dietitian, it's really important to address and emphasize that not all carbohydrates are the same. And this is the debate that has been going on amongst dietitians, that whether we should be advocating low carbohydrates or not. And if we just take a simple metrics of a portion of fruit, which could be anywhere between 10 and 20 grams of carbohydrate, can match exactly the same amount of carbohydrate in a donut. So do we advocate low carbohydrate diets in just cutting out all carbohydrates, or is it the focus that we need to educate our children and our families on what clear definition, evidence-based strategy that it is the age and also the growth that will impact the amount of carbohydrates that individuals require. And very nicely put here in a study that children, as they're growing up, they have different requirements, and that needs to be addressed with the dietitian or their clinicians. If we look at our international platforms, there is no conclusion that low carbohydrate diets should be recommended to children living with type 1 diabetes. The use of low carbohydrate diets in the type 1 community, purely based on the carbohydrate requirements and the development needs of this particular. A number of studies, they will show you that there are benefits of reducing carbohydrate intake in your diets, but there are also concerns with following a low carbohydrate diet. And some of the key things that as a dietitian, we are more concerned about is things with families who are anxious about large carbohydrate intakes with their families. And also, as I touched on, the variability of glycemic control, but more so now also improving time in range. So there are studies coming out looking at whether low carbohydrate diets are actually improving time in range for children with type 1 diabetes. But also as a clinician, we're more concerned around hypoglycemia, ketoacidosis, nutrition deficiencies. So we can understand more of the clinical outcomes that are concerns listed with very low carbohydrate diets here. If we reflect on the evidence of low carbohydrates in type 1 diabetes with adults, which is more well studied, we know that there is not huge data to support the benefits of low carbohydrate diets in type 1 diabetes, whereas in type 2 diabetes, we can quite. But just reflecting on some of our data from type 1 in adults, we can see that the amount of carbohydrate, although is following low carbohydrate diets, they're not actually touching very low calorie carbohydrate diets here. So the significance of very low carb diets is not showing huge amounts of outcomes. And what the studies are showing that is actually difficult to continue to follow these low carbohydrate diets on the long term as well. More so recently, there was a multi-center study conducted in Prague, which looked at several sites and the use of low carbohydrate diets in children with type 1 diabetes. And what they wanted to understand is whether there is a sort of acceptance of low carbohydrate diets in these centers. And again, they found that there was not much use of low carbohydrate diet. And the study also showed that there's not significant difference in the outcomes in comparison to those children following non-low carbohydrate diets. So what we clearly are seeing from these evidence that the outcomes are very similar to non-low carbohydrate diets, and the adherence is not great in the long term. The interest that has sparked internationally is more so from a very low calorie diet, carbohydrate diet. Sorry, I keep saying calorie because I'm currently doing another study on VLCD. So very low carbohydrate diet, where an online study was conducted by a group of dietitians in Boston. And what they showed clearly that there is a split between 40 to 50, near to 50-50 split between children and adults online platforms who are following very low carbohydrate diets and actually achieving very successful results. And what we've got to remember in this particular study, that they were actually following less than 50 grams of carbohydrates per day, which in some of our communities can be very, very challenging for some of our families. Although the outcomes were very promising in this study, it is a biased study in terms of self-reporting and needs further clarification from our clinicians. Just going on to more of the practical implications of following low carbohydrate diets, as I touched on very briefly, children come from poorer social economic communities where it can be challenging for children to fit into or wanting to follow low carb diets as well. Some of the stated behavior strategies that have been suggested by dietetics and the community of dietitians is that maybe we need to move away from low carbohydrate conversations and talk more around carbohydrate prescriptions, which is very well documented from our dietitians at Barts University Hospital, where they have trialed carbohydrate prescriptions in both type 1 and type 2 diabetes within children and young people, where this works much more effectively. The other thing we need to be mindful of that low carbohydrate, when talking about low carbohydrate diets to our communities, we need to be mindful of age, weight, activity as well, and also looking at the family as a whole. So more so from a dietetic perspective, if families do want to follow a low carbohydrate diet, it is important that the type of fats they are consuming is from monounsaturated and polyunsaturated fats. Trying to encourage people to have some form of omega-3, which can be challenging in some communities as well, which I'll go on to talk about. Aiming to increase the amount of fiber in their diet if they are going to be consuming, if they are reducing carbohydrate, what type of carbohydrates they're having, ensuring that they're having at least 2 portions of fruit a day, and increasing the amount of dairy consumption in their diet as well. So I just did a little bit of work around the type of carbohydrates and the amount of carbohydrates children from type 1 diabetes community in India are consuming. And I did struggle to find some data on the amounts that children from with type 1 diabetes are consuming on average. But from observational studies and from my work experience in communities, we know that in certain communities, the amount of carbohydrate consumed, carbohydrate counting, carbohydrate awareness remains a huge challenge. So just by reflecting on some of the different areas of India, I realized very quickly that there is majority of the foods consumed are carbohydrate based, and it can be quite difficult to encourage families and children from this particular areas or who have children living with type 1 diabetes to follow the concept of very low carb diets. And most importantly, I wanted to know whether the education is available for families to the commonly eaten foods that they're having and whether there was an understanding of the amount of carbohydrates in these foods or not. And I myself found it challenging to find the amount of carbohydrates in these foods. So what I would encourage our colleagues here today is work with the dietitians locally, understanding the commonly festivals, or if they're going to be following a particular diet, is not to exclude children and families living with type 1 diabetes from these celebrations, but understanding what they eat, how we can educate them better on the amount of carbohydrates in these foods, what can be the alternative options for these families. So just to give you a flavor of what we do with our families here in the UK, we work with families, we ask them to dish out the plates, we help them to calculate carbohydrates as a meal, not as individual foods, because we know people don't eat foods as, in isolation. Meals should be complemented with balanced meals, and this is what we do with our families here. We also have a wonderful resource known as the World Food Book. Sorry if I've gone over time, but I will try to rush as quickly as I can, which has listed over 1,000 foods from cultural communities, which supports families in understanding the basic concept of carbohydrates, how it impacts their blood glucose, and how to simply change their portions rather than excluding foods from their diets. And this has been a real eye-opener for a lot of our families. I also work very closely with DigiBeat, which my colleague will talk about today, is how we develop culturally specific resources both online and in videos as well. So in summary, I'd like to say that it's not just a nutrient that we should be talking about. We need to be looking at behaviors. We need to be looking at the diet as a whole, because one diet does not fit to everybody, and also tailoring the education to the cultural needs. So we must take into consideration the individual's nutritional status, status, their nutritional affordability, their social status, and their cultural content. And this comes with experience of talking to communities like we've heard from our colleagues today, when we can actually go into the communities and work with communities themselves. So in conclusion, we know that there is not enough evidence to support low carbohydrate or very low carbohydrate diets in the type 1 community. But what we do know is that many people are looking for self-notions and going online to look for strategies to better manage their diets. So we must work with our families and communities to support what they understand and give them clinically sound advice. So whether it is a medical choice or is an individual community choice, we need to outweigh the clinical risks and the barriers and the challenges of these diets before we actually conclude that this is the diet that they should be following. Thank you so much for listening. This is my email address. If you'd like to reflect on any of the resources that I have touched on today, I would be more than happy to share them.
Thank you, Salma. Thank you so much for a comprehensive, and there was a lot of data for a lot of us to study and learn from. And I think a lot of efforts and study has gone behind this. And I'm sure like people have more queries after this. And very good, like I must point out, to keep the balance. People just keep one biased approach, and you've given a very comprehensive state there. And yes, so we'll go on to the next speaker right now, and then maybe take questions later, as just said. Yeah, so we have our next speaker now, Ms. Madeline Julian, and she's the co-founder of DigiBeat and centrally funded from NHS. So we are having more NHS-based people. Is on self-management platform. Yeah, and she's a teacher by profession and has worked with communities, including those with challenging behavior and complex needs. And yeah, she and her husband identified the need for DigiBeat in 2016. And I think, yeah, she has more than 300 self-management resources and extends reach for clinical teams. Okay, I think that's a lot to say. And I think I would prefer, even I wanted Ms. Salma to have her own brief self-introduction than me reading out the full thing. So anyway, so over to you, Maddie. And I think your passion for serving the community, when you all are attached to the NHS, like we all learn from India, like we have a lot to learn. So over to you, Maddie. Yes, carry on.
Thank you very much. I really appreciate the introduction. And thank you very much for inviting me on today. I'm really proud to present to you DigiBeat today. We are a community-led yet clinically approved resource. So we bring together the community and clinicians into one space to make sure that we're providing education not only is clinically accurate, but also is built by the community. So we very tightly co-design everything we do with different members of the community and clinicians together. So there's a quality cycle to what we do that's kind of different to maybe what's out there already. And really happy to share this today and share our learning. And if there's any collaborations, then we'd be more than happy to support you in the future. So we have many people collaborating with DigiBeat. We work across the National Diabetes Programme in England and the NHS Improvement Programme, but we also work with multiple academic organisations and NHS organisations and community organisations too. DigiBeat has had quite a large impact already. So we've got 158,000 users. We've got 216 diabetes clinics using the app. So what's important to understand about DigiBeat is it's not just something that people download, it's prescribed by the clinic. So it's a prescription app, if you like. The clinics run the app for their service and personalize the app with all their clinical information, their booklets, their leaflets and things like that, their important information and documents, their clinic numbers, and healthcare professionals. So, I was listening to the call yesterday and realizing we're in the early stages over in India, I think, of developing the pediatric diabetes clinics, but effectively these are run out of those clinics. So we have, but all supported by the DigiBeat infrastructure. So we have over 300 resources ourselves that support and plug the gaps really for those communities, and it's available 24/7 when they need it in the middle of the night. to provide different parts of the diabetes education care. So I'm going to play you just a quick 1 minute video, but actually, if you don't mind, I'm just going to stop the share and reshare because I realized that I might just need to tick that share the sound box. So there we go. So I'll very quickly play you this, which will just give some context to DigiBeat.
The multi-award-winning and free DigiBeat app have been created specifically for children and young people with type 1 diabetes and their families. Our community-led clinically approved resources promote better self-management and can be accessed 24/7 to improve care. DigiBeat have created hundreds of resources with multi-language functionality, providing awareness, education, training and support for patients, families, their communities and healthcare professionals. The DigiBeat app grows with patients by tailoring resources by age and is a vital self-management communication tool, enabling the delivery of a device and resources from local diabetes teams direct to patients' smartphones or tablets. Store insulin ratios, school healthcare plans, record future health appointments and receive ongoing structured education and so much more. Type 1 care in your pocket. For more information, visit digibeat.org today.
So the big question really, even in the UK, is how do we scale out good? What does good care look like? And how do we make sure that everybody gets access to some of it, to the fundamentals, to the essential care films to keep you well, whilst living with diabetes? And we have variances in care. And when we started this a few years ago, the variability was more, and I think it's getting better as we move on in terms of standardizing. But DigiBeat's there to standardize what good care looks like, and to help all families receive some of that good care in digital formats to complement anything they get in at their diabetes teams. So we're not replacing care, but we're complementing care, and we're providing that care in the middle of the night and weekends and when people can't get hold of their diabetes teams. So we're an age and culturally appropriate resource. We are multilingual. We have 10 languages that you can actually, all the essential films are now in 10 languages, and you can access that free to use yourselves. Please do use it. It's out there. So this is the website here, digibeat.org. And so if you in your diabetes clinics and you've got other languages and you need to use that, please do. You can also turn the site into 99 languages as well. So it translates the site into 99 languages. So all the written documents, all the care documents is in 99 languages. And I think, we embarked on a big mission really at the beginning of COVID, which was to make sure that everybody had not just the website, but the availability of the DigiBeat app, which that tailors all the support via age. So as you grow up with diabetes, you have different issues, don't you? Different things you need to be able to support with. So going into puberty and transitioning into adult care, for example, going to secondary school. And we've heard about school issues today. And sadly, it's the same in the UK. There's been lots of issues with schools in the UK as well. And we've done lots of work on the website. So please use those free resources if they help, maybe help structure things. So our study was commissioned at the beginning of COVID. We've done we've sort of onboarded 21,000 patients in the last 2 years onto our DigiBeat app, and through the app they've watched about 82,000 videos, and there's been 363 hours of training for healthcare professionals. So we train the healthcare professionals how to use it, and effectively we're digitalizing their service. And why would we want to do that? Well, the biggest thing is efficiency savings. So it's looking at how we can scale out support to the thousands of people that need it. This may be something that we could take some conversations with India and how we could support that. Out of all the patients surveyed, which is over 1,000 patients, 4 out of 5 would recommend the app, and 4 out of 5, and 96% of healthcare professionals recommending the app to their colleagues and saying get on board with the app and commission it, have it in your service. So the app was commissioned centrally by NHS England. It's funded free for all children and young people and their families in England and Wales, and we've really seen a massive use of the app over the last couple of years. And you can see that through the poster. We'll be presenting this at IDF as well, if anybody's there. So, in terms In terms of the language resources, please go onto the app. You can see the Essentials tab there, and you can choose your language on the app. We have lots of different types of resources. I'm not going to play this because we don't think we have an awful lot of time today, but we have, animated explainers of what is type 1 diabetes, signs and symptoms. We have a page dedicated to awareness as well for the community. So the platform is like the community support platform, and the app is for the individual self-management, and that's about good care reminders. We have new resources as well, always appearing within the app. And this is where you can see the sort of different preferred languages you can choose. And we've now got our app in 10 different languages, and we're developing the languages at speed to cover all the different resources. And you can record your time in range in the app, for example. You can do age-appropriate quizzes, and the clinicians can see what structured education that you have done. So there's lots of data that the healthcare professionals can see in terms of where the gaps are. We want to make every minute in clinic matter with games and quizzes. We want to learn together as a family. We want people to be able to share this with their family. So we're creating games and other animations. But we've also got lots of real life stories on the app as well, and patient stories. And really, it's just enabling that to be available whenever people need it. You can record your ratios in the app too, and all your diabetes information. So healthcare professional feedback has been very good. People have talked about how they believe it's the best resource available to families, fantastic information at fingertips, and it's the number one place to go to direct families to all things diabetes related, and helps me with my job almost every day. I can't imagine work without it. And similarly, from a patient, even 5 years into their journey, I've only just found this resource, but it made them take a deep sigh of positive relief. I'm writing this on the day of a diabetes appointment, and for the first time, I'm looking forward to seeing my consultant armed with my app and my notes on what I want to discuss. And that's what it's all about. It's about helping families. It's a massive thing in terms of organisation as well, receiving a diabetes diagnosis. How can we support people at home? So we have 35 clinics now at 100% as well. These are some of the most deprived areas of England and Wales that we've got people on. We've onboarding Scotland too. And really, healthcare professionals, again, saying it's a really excellent app for young people. It's like having a diabetes specialist on your phone in your pocket. This is the personalisation of the app. So sick day rules and everything goes in the app. Multicultural resources that we're developing with Salma. Cultural festival resources, helping people understand, what they need to do whilst living with diabetes and living a full life with diabetes. And we have lots of different resources available for people as well, preparing them for adulthood. This is an app that can stay with them, and they can stay logged into it for as long as they need it, really. So it's all about organising diabetes information, cost-free support, improving patient experience, and really enabling everybody to have some good care available to them. And we have lots of stats, and we collect lots of information so that teams can see what good looks like. So I'm going to just finish there and say thank you very much. I know that we're probably quite tight on time, so I'll stop that share, and hope that has been useful for you to see a whistle-stop tour of DigiBeat.
Thank you, Maddie. That was quite quick and crisp and to the points, and your app looks very, as you say, I think people with diabetes like myself would want to try it, and we appreciate that you want to share and help for the digitization in India as well. And I even saw Ms. Salma's data with Indian perspective because of the diverse culture, and you had specific state-wise as well, Karnataka and Tamil Nadu back in South India, where I come from. So great, kudos to both of you for making this data and presentation absolutely mind-blowing and very informative. So I think we are at the end of the session, and I'm we don't have the other speaker because of some health reason. So I think we are done with our speech session. So we are open to questions, and yes, shoot. I think session was quite informative, and maybe people don't have doubts. Maybe they will look at collaborating with you in the future. I'm going to do that. I think a lot of people in India will reach out to you both, and let's see. And Nupur, actually your BC app was like India specific with multiple languages and all that. So failed to mention in the beginning because we thought we'll take questions in the end. So that was another comprehensive India-based app as well. And I think we have, yeah, okay. So DigiBeat and BC app and everything. So doing well. Thank you for your presentation. So I don't think we have any other questions. Maybe people will reach out to you later. So yes, end of session. Thank you all so much for the wonderful presentation. Very informative, at least for me. It was wonderful learning process. I think Typhoon is all about trial and error. So that is what even your LC diet said about, so continuous learning process, and the learning continues from yesterday and today. Yes. Thank you, Riya. Over to you.
Thank you.
Thank you all so much.
Thank you. Hello.
Yes,
Thank
yes,
you all.
you're audible.
So this was the end of the session. And do we have any more discussions, or we can close the session?
Yes, I think that's the end, and we can, if there is nothing else to be added here.
Thank you, doctors. Thank you, speakers. Thank you so much. 2 days were wonderful, and we got a lot of insights about type 1 diabetes, its education, awareness, and how better we can propagate the idea of better treatment and better lives. Thank you all. Thank you all for joining. Thank you. Riya, we can close the session now.
Thanks to the organization team. It was wonderful organizing this. Bye, everybody. Thank you so much.